Good morning, everyone. Very warm welcome to respected dignitaries, faculty members, panelists, my teachers and colleagues. I'm welcoming you all for this Apollo Conclave 2026, which was organized by Apollo Hospital, Navi, Mumbai. I'm Dr. Ashwini Mane. I'm your host for the today. And I'm feeling highly privileged because I got the opportunity of the hosting this show, which is full of the academic feast. So as we all know, the critical care is not only about the saving lives, but also about the providing compassionate care. So to update our knowledge of the critical care, we have invited the finest intensivists from all across the India so that we can discuss about the latest guidelines and the evidences, so that we can contribute to the save life of the patient. Feeling responsible, right? So without further delay, I would like to call Dr. Akshay Chalani to deliver welcome note. Dr. Akshay Chalani is the lead consultant of the critical care department at Apollo Hospital, Navi, Mumbai. So please welcome Dr. Akshay Chalani with a big round of applause. Over to you, Dr. Akshay Chalani.
Good morning, everyone. On the behalf of Critical Care Department of Apollo Hospital, I welcome you all here. It's an absolute privilege to be here. And first of all, I thank you all of you. So there are a few branches in the medicine, particularly about critical care, oncology. These are changing very rapidly. What we learn today might not be the same thing what is there for tomorrow. So to keep it updated knowledge and what is happening in the mostly critical care, and to bring together all intensives across Apollo, actually we thought that we'll arrange this Apollo Critical Care. And mind you, all the people who are coming across, all are from topmost institute in their field and institute at their area, and they are working relentlessly in ICU from a long time. So to just deliver first talk, I request Dr. Chakravarti to just come on the dais and talk about the AKI. He will talk about AKI, SLADE or CRRT. In last few years, we have seen so many papers, particularly in one or two group of patients other than hepatic failure, acute liver injury. Particularly, we offer a CRRT, but whether if you don't have a CRRT or in a resource limiting setting, in addition to CRRT, suppose you are offering the SLADE, it makes sense whether is any evidence to favor the SLADE or CRRT. So to just touch upon these points, Dr. Chakravarti will deliver his talk on this topic. So I request Dr. Chakravarti to just take over from here. He is Chief of ICU at Apollo Hospital, Calcutta, and managing Neuro ICU plus ECMO section in Apollo Hospital, Calcutta. To chair this session, I request Dr. Chaitanya to come on the dais, and in addition to that, I request Dr. Sangeeta Srivastava to be on the dais as a chairperson. Thank you. Dr. Chakravarti, please.
Good morning, everyone. It's a privilege to come here and talk about a very core topic in critical care. I hope I'll update next 20-25 minutes on all the literature which evolved as I came across all different 7-8 hospitals over the last 20-25 years. So the burden of acute kidney injury in ICU is huge. We daily deal with it. Almost 30% of our ICU admissions are acute kidney injury, and it increases mortality about 50 to 70%, which evolved with renal replacement therapy originated almost 75-76 years back, with a dialysis machine with arteriovenous filtration. And since then, we are just trying to manipulate to adjust with the human body. So start with the imaginary case, a 67-year-old man who came for elective major surgery for bowel cancer. he was hypertensive with chronic kidney disease. The baseline creatinine measured 3 months prior to that was around 1. He has background of diabetes and he's relatively overweight. So we have the parameters, we know what is the urine output, and the patient arrives in the ICU. 6 hours post-op, we still have a creatinine slightly increased to 1.1 milligram per deciliter, with urine output relatively well, 0.7 mils per kg per hour. So is my patient going into acute kidney injury? Just a couple of months back, the new guideline came, and let's see what this is. So as per the definition, newly guided by the guideline makers, both for the children and adults, is defined by one or more abnormalities in kidney function or structure. So we do not only define by creatinine and urine output, we also have a structural criteria, and as in my place also, we don't have these biomarkers to monitor, only to be done for research purpose. So what they say for the functional criteria, the serum creatinine rise more than 0.3, or a serum creatinine rise more than 1.5 is the baseline, which is monitored in the last 365 days, or a rise in cystatin C, which is relatively not affected by the muscle mass or the cachexia of the patient. Even in obese patient, you don't know what is the muscle mass. Or the urine output less than 0.5 mils per kg per hour for more than 6 hours. With that, we have a structural criteria to monitor the biomarker if we have of cystatin C, which is usually produced by all the nucleated cells, really filtered by the glomerular membrane, and measures the GFR more effectively than creatinine. So at 6 hours, if we have the serum creatinine, if we have the urine output with the rise from the baseline and the urine output over the last 6 hours, we can say my patient is at high risk of developing acute kidney injury, so it has to be monitoring the hemodynamic status, what is the compromise, monitoring cardiac output, fluid status at the urgently to prevent the patient going into acute kidney injury. So based on the current criteria, this patient doesn't meet the functional criteria of AKI. It's less than 0.3 milligram rise, and urine output is adequate. So we cannot conclude this patient is having functional AKI. But if we have the structural, that is the cystatin C, which rises faster than creatinine, still we can put the patient in acute kidney injury criteria. So establishing the baseline creatinine is very tough unless we have like a patient who is coming for elective surgery. We don't have the baseline creatinine. So it is last 8 to 365 days, any baseline creatinine is adequate, or any prior hospitalization creatinine. Or maybe if we have the cystatin C level, we can still be more accurate. The biomarkers and evolution of biomarkers have progressed over the years. Creatinine has some loopholes, like it cannot detect subclinical AKI. It cannot predict whether my patient will go into severe or moderate AKI or not. It cannot guide me to tell that whether my patient requires renal replacement therapy. And different biomarkers came in over the years to try to fill in the gap. But still, the NephroCheck is the only one which is FDA approved. None of the biomarkers we commonly use practically, and none of them say what is the management to prevent the AKI and which patient at what time requires renal replacement therapy for my patient. Of course, they are costly, which is not for the creatinine. So we check at the baseline the background of the patient who is diabetic, chronic kidney disease, what is the risk, like albumin or cast in the urine. And there are some stress biomarkers which recently been said that you combine the biomarkers like inhibitory metalloproteinase and the insulin growth factor beta, you combine them and then say whether the patient is at risk of kidney stress. And of course, you try to diagnose with the damage biomarkers like the urine NGAL. So, different studies in research purpose, of course, came in and see what is the sensitivity and area under the curve of these biomarkers, and they found that when they combine this TIMP2 and IgBP7, of course the area under the curve is higher, so they tell more, but still to be used at the bedside in maybe in 10-20 years, I don't know. So as per the guideline, they say to assess the kidney stress with combination of the biomarkers, these two biomarkers they have said is having the most sensitivity because they rises very fast within the first 12 hours of ICU admission and doesn't alter with major severity, and after sepsis onset when the inflammation is high, you can use them for a better diagnosis to optimize the risk factors, hemodynamics of the patient to prevent AKI. So biomarkers in kidney damage, the latest one which is more specific than the serum one is the urine NGAL. So as you know, it is being called the troponin of the kidney, which rises very fast within 2 to 6 hours. It is a marker of tubular injury. It doesn't get affected by the muscle mass and probably more specific for the kidney. And of course, it has some advantages over serum creatinine, but it is still used in the bedside. So there are two types of biomarkers, as I said. One measures the stress with the combination of TIMP and IgBF7, and one is used for the damage which has already been happened. So it is called the troponin of the kidney, and that may guide us and still to be validated at the bedside for using the renal replacement therapy to salvage the kidney. So from the guideline, we can see the AKI is pretty much common. It uses the structural criteria using cystatin C to diagnose acute kidney injury when the functional criteria is still not subjected. And biomarkers probably in future terms is coming more at the bedside quite quickly. So if we look at the guideline again, we see our patient, if you have the cystatin C or maybe the combination of the biomarkers is relatively high, more than 0.3. So based on that, the KDIGO 2026 criteria, our patient is at risk of acute kidney injury with the background of diabetes and chronic kidney disease. So we have to optimize our hemodynamics, fluid balance and cardiac output to prevent it to go to more chronic disease. As usual, in 7 days time, patient will catch up some secondary infection, patient is febrile, having increasing oxygen requirement, and patient is relatively hypertensive, causing more stress to the kidney, and we diagnose there is a hospital acquired pneumonia. So you optimize the fluid and the antibiotics as we commonly do. So what happens? The creatinine value is little high, 0.2 rise from 1. Urine output is little low for last 16 hours, still not AKI. But if we have serum cystatin C, we can see that it is 1.5 times rise from the baseline. So we can say that my patient is developing acute kidney injury. So now we have to decide whether to go for renal replacement therapy to salvage the kidney or just wait. So, as I said, as per the KDIGO functional AKI criteria, serum creatinine is still not high, but the serum cystatin C is high. Still, the criteria has not met for this functional criteria, but maybe at 7 days time, the biomarker is positive. So, they stage the AKI based on this. One is serum creatinine value, one is urine output value, and one is the biomarker value. And each stage, whether it is 1, 2, or 3, the biomarker may be positive or negative. Just to summarize this, as per the Akin criteria, which is amalgamated in the guideline, there are C stages, more than 0.3 rise in the creatinine, or 2 to 2.9 from the baseline at stage 2. and if it is more than 3, we call it stage 3 AKI. And also similarly, as the urine output drops, we increase the severity of the stage so that we can include these patients in different guideline-based therapies. But the biomarker part has came only recently. So as for my patient, we have to decide whether the patient is having AKI and getting resolved with our management within 48 hours, we call it transient AKI, or it is progressing from 48 hours to 7 days, we call it persistent acute kidney injury. So at 7 days time, with the secondary infection, with pre-existing renal disease, and with the insult of the surgery, still my patient can revert back from 7 days to 3 months time to not to progress to chronic kidney disease. So we still have time, but at 7 days time, we are going into persistent AKI. So different studies that came in to prevent the patient from going into acute kidney injury, progressing to chronic kidney disease when the AKI is persistent. What they did, they assessed the fluid balance using the bedside, as we commonly do, passive leg raising test. They optimized the fluid balance of the patient with some crystalloid boluses as per the septic shock guideline. They optimized the mean arterial pressure of the patient with quick use of the norepinephrine. And of course, at sometimes when maybe the heart is also compromised, they used to increase the cardiac output. At the same time, as it is a elective case, so pre-operatively they have stopped some drugs or fluids which may hinder the recovery of the kidney in the post-operative period, like AC inhibitors for 40 to 72 hours. So, in this time, for last 2 months back, this guideline differentiated between acute kidney injury, transient and permanent AKI, and then progressing into acute kidney disease to chronic kidney disease. Because the patient may have some risk factors which we cannot alter, like age, of course the genetic factors, hypertension, diabetes, before coming to this insult. And of course there are some disease modifiers in acute kidney injury which we can modify, like different stages, the number of episodes of insult, like hypertension, sepsis, and other things. And then we outcome these parameters before 48 hours or before 7 days, and ultimately, if not possible, before 3 months, so that the patient doesn't progress to chronic kidney disease. So, less than 3 months is acute kidney disease from 7 days. After 3 months, patient will progress into chronic kidney disease as per the new definition. So, just looking into the acute kidney disease criteria as per the new guideline, there are some functional criteria as per the creatinine and urine output, and of course, there is some structural criteria. And the AKI by structural criteria, when they progress to chronic kidney disease, we need a biopsy, or maybe some urine analysis with proteinuria, hematuria, or leukocyturia, so that I know my patient is going into acute kidney disease, into the chronic kidney disease or not. Complete resolution may happen with our management within 7 days if the creatinine comes down to less than 1.2 times the baseline, or if it stays within 1.2 to 1.5 times the baseline, we call it partial resolution within 7 days. But if it is more than 7 days to 3 months, the same criteria diagnose this patient as an acute kidney disease with or complete resolution or partial resolution. Of course, in ICU, because of different other reasons, the patient may have a recurrent insult on the creatinine, rise and fall and fluctuations and more hit to the kidney. They diagnose, define it as a recurrent UTI within the 3 months time. So patient have a prolonged ICU stay at day 14, which is crossed more than 7 days, and the patient suffered a hit to the heart because of this stresses, and the creatinine again rises. Management for the heart, the more hit to the kidney with the contrast, and ultimately serum creatinine rises to 1.5 milligram per deciliter. But finally, there is a positive outcome in those cases because it's an emergency case. So patient get discharged with the baseline creatinine 1.4, which is 0.4 rise than the baseline, and he becomes positive in the long run with positive for proteins. So we call it a transition to acute kidney disease. So to summarize, at day 1, our patient didn't have any structural criteria, functional criteria to call it AKI, but there is a biomarker positive. So at day 9, there is a sepsis hit, there is a complete resolution. At day 14, patient had an end STEMI, so there is second, third hit, and then at day 21, patient progresses into transition to acute kidney disease. Then we have to decide in this time what is the best time for the renal replacement therapy before we progress to what is the best modality. There are 5 major trials over last 17 or 18 years. To summarize them, first is the ELAINE trial, a single center trial from Germany, around 231 patients. And they used at that time also the serum NGAL with relatively less sick KDIGO stage 2 AKI patients for either taking for early within 6 hours of renal replacement therapy or wait for the more aggressive biochemical parameters to dialyze. And that was a positive outcome for the early renal replacement therapy. Then came the French group, which started in 2016, the AKI trial, which was equivalent. And the larger trials like IDEAL, ICU, and START-AKI over the years. And finally, the AKI2 trial. They use more delayed strategy, and AKI2 is far more delayed strategy, and they found that early is not that beneficial. Maybe we can wait. So 5 major trials, over 4,636 patients across 15 countries. Which will start AKI is the largest trial over the years, over 168 sites. What they found, as we summarize, RD strategy versus delayed strategy, and AKI2 is a more delayed strategy. First trial, of course, there is a benefit around 39% versus 54% in 90-day mortality. In AKI2 trial, they delayed the strategy and they found almost 50% of the patient not requiring a renal replacement therapy. Then later on in IDEAL, ICU, and START-AKI2, they started doing the late strategy and found that, of course, if you delay dialysis, many of the patients may not require dialysis, and dialysis-dependent complications like bleeding and infections and other adverse events may be averted. But in AKI2, they tried to delay it further, and they found that there may be some relative harm if we delay further. So how much delay? So going back to the AKI2 trial, they found that in terms of survival and recombinant of renal replacement therapy, there is not much difference. But in the IDEAL ICU trial, they found that when they delayed renal replacement therapy, many of the patients didn't require renal replacement therapy, and of course the difference is quite high. In the START-AKI trial, the Canadian group, they of course use different modalities of the therapy. They took more the subgroup of sepsis and septic shock patients, almost 43 to 44%. And they also found that in terms of timing of therapy, the mortality at 90 days was not much difference. And finally, the AKI2 trial, which used delayed versus more delayed renal replacement therapy, where the delayed group was getting a dialysis in 48 hours. The median time for the more delayed group was around 90 hours, which is more than 72 hours as per the criteria. The urea initially in the AKI and the biochemical parameters was around 112. They tried to push it further in the more delayed group to 140 and tried to see whether delaying it further can prevent recombinant renal replacement therapy, and they found it is probably having a higher hazard ratio in the more delayed strategy compared to the delayed strategy. So you can wait, but waiting for too long may not be great. So to summarize again, as we come across the years from 2016 to 2026, we found that probably waiting for around 48 hours is great. Whatever the modality used in as per your availability and the hemodynamic status of the patient in your ICU. Waiting for too long, except just excluding the patient who require dialysis for hyperkalemia, metabolic acidosis, rising other organ dysfunction. Any modality if you have to use to optimize the patient, maybe 48 hours to 72 hours is the optimal window to choose any form of therapy. If we go back to the trials, what is the median time for renal replacement therapy? For that delayed timing, in Elaine it was 25 years and it is gradually progressing to AKK is 57 hours. Both the ideal ICU and start KI is around 31 to 51 hours, and AKK to the more delayed group was around 72 hours. So if we delay more, probably the odds ratio for the hazard ratio is rising to 1.6, which is more for the delayed. All these trials, of course, thousands of patients, no universal mortality benefit was gained from the early RRT. Watchful waiting avoids unnecessary dialysis and dialysis-related complications. Early RRT may increase the dialysis dependence because RRT-free days doesn't differ much. And of course, excessive delay carries the risk when of course, as per the trial, the urea around 112, which is just an arbitrary number, which may vary from patient to patient, was for the optimum time when you can dialyze your patient. There are some biochemical inclusion criteria apart from the timing, which is used in different trials. Like in Elaine, they took KDIGO stage 2, which is less sick patients, and all other patients usually taken almost Akin stage 3 or Rifle E as a criteria for dialyze the patient. So those parameters like the urea, creatine, and all that probably doesn't matter much. It depends on the hemodynamic status of the patient. And of course, the urgent criteria for dialysis like hyperkalemia, metabolic acidosis of less than 7.2 when it's refractory as an indication for dialysis. So summarize this in a tabular form. Urine output also doesn't matter when these patients are not having a volume overload. Hyperkalemia also you can manage with your medical management. And metabolic acidosis also you can manage with lesser concentration of the bicarbonate till you think that it's too late for dialyze your patient. As per the subgroup analysis of different patients, you can see only Elaine has used the plasma NGAL at the time for a criteria for dialysis. Other patients are mostly our common population of patients with mechanical ventilation and catecholamine infusion with some amount of septic shock within last 48 hours. So this is a subgroup of patients we commonly deal with over the years. So KDIGO stage 3 or Akin stage 3 is the time when you can think of dialysis, and with medical management the patient is not improving. Of course, the urgent dialysis criteria is very much common to our patients, whether it's a hyperkalemia, metabolic acidosis, pulmonary edema, or uremia. And of course, when we cannot manage the patient without giving fluids. Now, choosing the renal replacement therapy modality depends on where we work and what is the financial status of the patient, whether they can use, of course, the low efficiency dialysis or a CRT machine, whether that is available. And there is not much change over the years across the countries. So initially till 2015 there is 3 major meta-analysis came in who have included more than 17,000 patients, and they have analyzed all 3 modalities like intermittent hemodialysis versus SLADE versus CRT. And first to start with the 2007 Cochrane database analysis by the Robindranath et al., who found that CRT gives a better hemodynamic profile, probably just a map higher maintained throughout this session, which is around 5 millimeter marker. I do not know how much it matters, but in terms of hemodynamic instability, trend favors CRT. Hypotension episodes, although doesn't matter much. And of course, there is a increment in map difference of only 5 milliliter mercury. And of course, if you use the vasopressor in a dose commonly used, it is recommended is less. In terms of in-hospital mortality, doesn't matter. of the modality you use. ICU modality also doesn't matter. In terms of renal recovery or dialysis independence, also CRT versus intermittent renal replacement therapy doesn't matter. But of course, CRT has its inherent complications of circuit clotting. Recently, we have started using the citrate-based CRT machines, but otherwise, heparin-related bleeding and clotting and changing of the circuit also reduces the amount of time you use the CRT, so dose gets reduced. So there is a hazard at the bedside. Dialysis dependent at day 28, maybe in CRT, maybe less as per the Snyder et al. In 2013 meta-analysis. The hospital discharge is probably in CRT is better significantly, and they also found quite differently that day 90, of course, the renal replacement therapy free days is higher with CRT, which is markedly different from the Cochrane review. So based on this meta-analysis, you can say that CRT is more favorable. Of course, it is not available at all the sites. And finally, in 2015, which is also 11 years old, they found that if you use both the modalities, the effect is mostly similar, even in terms of hemodynamic instability and RRT dependence at follow-up, almost at 19 days. So if you use both the modalities, probably not much difference. Even we can feel that probably CRT is better in hemodynamics, but we have to titrate our dose to adjust to the hemodynamic requirement of the patient. After that, of course, new studies came in. This is a systematic review by the Daniel Nash et al. And they found that and actually substantiated that in terms of SLADE and CRT, whatever modality used, dialysis dependence and in-hospital mortality doesn't differ much. And these have included in your recently ISCCM guideline. They also say the same thing repeatedly, that whatever the modality used, whether SLADE and CRT, it doesn't matter much. Going back to the trial makers who have done this ideal ICU trial, the secondary analysis, and they found that probably in terms of renal recovery, CRT may be better, but you have to analyze it again as per your availability of the modality. So death or renal replacement therapy at 90 days, the therapy may favor CRT when it is available as per the secondary analysis of those ideal ICU and START AKI groups in Canadian groups. So they have done the subgroup analysis as per the severity status of the patient as per the SOFA score. When they found that when the higher SOFA score, more sicker patients, there may be chance that CRT favors the patient at the bedside, but it is, of course, the SOFA score is more than 13, is quite sick patient, hemodynamically unstable. We feel that CRT is safer, but still the studies has to come in to prove it at the bedside. So how much CRT and intermittent hemodialysis you use at the bedside, it depends on the mean arterial pressure, hemodynamic requirement, the filter related hazards at the bedside, and probably we feel only hemodynamics and MAP maintenance is better with CRT, but otherwise there is not much difference in terms of mortality or renal replacement therapy requirement at around 3 months time when the patient will progress into chronic kidney disease. How much dose to use? Of course, over the years 2000 to 2013, these trials came in, around 6 trials. First is the Ronco trial, who used 20 versus 35 versus 45, and they found that probably there is not much difference between 35 to 45. Survival as 15 days was the only primary outcome they looked into. And then came the ATN trial, which changed our practice from intensive to more intensive therapy. 35 versus 70 was the latest in the Ivory trial. Of course, if you use the more higher dose, chances of more hemodynamic instability, chances of more electrolyte abnormality like hypophosphatemia can come in to complicate the picture. So based on these trials, commonly we use around 25 to 30 mils per kg per hour as a standard dose divided between the dialysis and hemofiltration as per the metabolic of the patient, to decide how much CRT dosing we have to use, if you can use at the bedside. So really in today's time, as for our patient, we have to decide at the bedside when to use RRT and which modality use. So any staging more than 2 with multi-organ failure in our ICU with life-threatening indications for RRT, you have to decide yes to go for dialysis for the urgent indications, or still to wait and assess the structural criteria of the patient to decide whether the patient having acute kidney injury. If there is a yes for all those emergent parameters, definitely we will go for RRT. We can delay it for 40 to 70 hours. Then depending on the availability of SLADE and CRRT, we can use whatever we have to salvage the kidney. Thank you.
I have a question.
Yeah.
So I am a general practitioner, but caution is not related with this topic. एनुअल हेल्थ चेकअप कर कर लोग आते हैं, बिल्कुल फिट हैं, पर क्रिएटिन इज 1, 1.1, 1.2, ऐसे समय में हमको क्या करना है?
If there is no insult to the kidney, so nothing to be done. I mean, in terms of renal replacement therapy, patient doesn't need renal replacement. And then in terms of other risk factor management like diabetes, hypertension and comorbidities, we have to manage so that the stress to the kidney gets reduced, like proper sugar control. Even in the ICU phase, the most stressful patient phase in this patient, we try to optimize the blood sugar. We try to optimize the hemodynamics only, so that the insult to the kidney, fluctuation of the sugar and blood pressure level doesn't happen. So in normal health checkup, we will do the same thing.
So अगर कोई symptoms नहीं है, patient non diabetic है, non hypertensive है,
Yeah.
so कुछ नहीं करना.
No, nothing to be done. Proper hydration has to be maintained. And if the patient is going for surgery, you have to stop those AC inhibitors and all. You don't know the whole acute insult. Even tooth extraction can cause infection. So at that time, the patient may get hypertensive and all. So that has to be prevented only. That's it. Thank you.
Thank you. That was a great talk. Now, as a token of appreciation and the gratitude, I would like to honor my speakers and panelists with the memento. And for the same, I would like to call Dr. Divya Kukian on the stage to felicitate our speaker as well as panelists.
नहीं चले गए बोलो. बड़ा करना है. हाँ ठीक मैं कर कुंदन को फ़ोन करता हूँ, आप ले लो तब तक. नहीं ठीक है. We'll do it one more time actually. On. Dr. Sangeeta, please. Dr. Chaitanya, please.
Now the next will be case discussion. The presenter will be Dr. Amal. The moderator for the session will be Dr. Divya Kukian. And the panelist will be Dr. Sandeep Agarwal, Dr. Divyashri and Dr. Lakshman Jesani. Please be on the stage.
Good morning all. Today I am presenting a case of 67-year-old male patient, no known comorbidities, had a history of RTA 15 years back, underwent surgical fixation of right greater trochanter, admitted in outside hospital from 7th March 26 to 10th March 26 with history of lower back pain since 5 days, yellowish skin and sclera since 3 days and fever since 2 days. Outside hospital, the blood investigation suggestive of leukocytosis. Initially, it was 29,000. Day 2, it was 30,000, and day 3, it was 31,000. And thrombocytopenia, 80,000, 70,000, 60,000, respectively. And hyperbilirubinemia with total bilirubin was 8.5 and direct was 4.6 on the first day. 9.5, total 9.5 and direct bilirubinemia 5.7 on second day, and third day it was 10.5 and 7.2 respectively. They did a CT abdomen with IV contrast outside, which was suggestive of hepatomegaly with bilateral minimal pleural effusion. So they shifted to Apollo Hospital, Navi, Mumbai on 10th March in view of worsening jaundice, fever and thrombocytopenia. On arrival to ER, patient was conscious oriented, febrile, icterus was there, no pallor cyanosis, clubbing, lymphadenopathy and edema. On arrival, vitals were BP was 145/90, heart rate was 110, saturation was 90, room air, and febrile with temperature of 101. So there was no history of travel, no history of consumption of Ayurvedic medication or alcohol use. There was no history of weight loss, abdominal pain and vomiting. No history of recent hospitalization, prior liver disease, no history of bowel bladder irregularities.
So this patient came to us with fever, thrombocytopenia and jaundice. At this point, looking at all the history and what investigations we had so far, Dr. Sandeep, what would be the probable provisional diagnosis and what investigations would be needed?
Hello. I think again the differentials can be huge. The primary problems that the patient came with was fever, thrombocytopenia and liver dysfunction. So there can be a number of differentials, but homing on to something will be again difficult. So at this point of time, we have what investigations we have seen? I mean, for the etiology.
So basic blood investigation what we done suggestive of fever. Thrombocytopenia was there, leukocytosis was there,
So
and
these are the observations that we are getting.
yeah.
So how we have investigated this patient for the etiology? What else have we seen? So procalcitonin looks low, more of direct hyperbilirubinemia, raised alkaline phosphatase.
Sir, alkaline phosphatase is 552.
Sorry?
552.
Yes. So it is raised.
And SUT was 134, SGPT was 109, and total bilirubin was 13.65, and direct was 10.4. INR was 1.29, creat was 1.13, hemoglobin was 12.5.
And OTPT are normalish, I mean very slightly raised.
So typically when these type of patients come to us, we put them into what particular syndrome are we dealing with. So it's basically acute febrile illness with altered LFTs, especially high bilirubin and slightly high SGOT-PT enzymes are present. So we have to distinguish what are the possible etiologies. So it could be infectious etiologies or non-infectious etiologies. Amongst the infectious etiology, this patient probably looks to be in sepsis. We don't know what is the source of sepsis, whether it is some respiratory viral infection which has triggered this, whether it is a hepatitis type of infection. There could be possibility of leptospirosis, scrub typhus, thrombocytopenia, fever. We need to rule out dengue, we need to rule out malaria. So all in all, this is an elderly gentleman presenting with fever and altered LFTs. I would like to keep all these differential diagnoses. So one is your tropical workup and your sepsis workup which will be needed.
Obstructive jaundice and cholangitis probably.
So the main provisional diagnosis at this point is sepsis, or it is tropical, this thing.
So the tropical fever panel was negative, triple H done was negative, HIV, HEV, IgM and IgG was negative. Urine routine microscopy was normal, ECG shows sinus rhythm, and malaria peripheral smear also was negative. Dengue LSA also came negative. USG abdomen shows mildly enlarged liver and distended gallbladder. There was no obstruction. Spleen, pancreas, kidney, bladder looks normal. And bilateral pleural effusion also was there. Portal vein Doppler also was normal.
So blood cultures were sent. So till the reports come, the provisional antibiotic started was piperacillin, tazobactam and doxycycline. Would you agree with that, or would you want to add any more cover to that?
Piperacillin and doxycycline.
Piperacillin, tazobactam, doxycycline.
So we were thinking about tropical infection, some tropical infection or
infections
something?
came negative.
Came negative.
Most of the
Right.
workup came negative. Sepsis, the culture reports were awaited. So finally the culture flagged a gram-positive.
And patient was not in hypotension.
No.
Not in shock,
Not
no
on shock.
organ,
Not
no
in
other
shock.
organ
So
failure.
BP
Not
was
in shock.
So predominantly looks like a sepsis picture because even the procalcitonin was raised and other parameters are suggestive. The next question comes into mind, if it is a sepsis with altered LFTs and fever, what is the source of infection? That we need to elicit. You mentioned a significant past history of some implant which was present. And now given the fact that there is now a gram-positive which is growing in the blood culture as well, my impression would be we need to look into that as the source of infection which has caused the sepsis.
So initially flagged gram-positive, and we started with teico-planning, and clinically patients started to improve and bilirubin levels also started to improve. On further examination, it was found that patient had tenderness over the right hip. We did a CT pelvis with a right femur, and it was showing a peripherally enhancing, centrally non-enhancing collection in the inter and intramuscular planes around the surgical site. Largest measuring 7.8 into 1.3 centimeter in axial dimension and 5 centimeter in the craniocaudal dimension. And there was a displaced metallic wire or pin noted, which was 5 to 6 mm posteromedially to the adjacent femoral vessel and adjacent medial to the right tensor fascia of the upper thigh region. So this was a blood culture report which was suggestive of MRSA, which is sensitive to teicoplanin, clindamycin, linezolid, and tetracycline, and daptomycin.
How earlier was the transplant, this implant was
It was
placed?
15 years back.
15 years back. And did that patient have any skin and soft tissue infection
No,
to
sir.
begin with?
No. Outside there was no infection.
So that is a
while-
bit surprising because the elderly gentleman with no significant comorbidities having an implant in situ, but why all of a sudden he will go on to develop a joint infection without any additional factors? So whether he had some skin infection which was ignored and then it got infected and then it has turned out to be MRSA, that needs to be elucidated. But now given the fact that you have an MRSA bacteremia, you have a source which is present, the first and most important thing is source reduction. So get an orthopedic guy involved and get it source reduced.
What are the possibilities? Suppose the skin is absolutely clear, there is no trauma, nothing, the skin, no laceration. What is the possible source that after 15
Then,
years?
yeah, then I would suspect whether there is any hematological source. We need to rule out any endocarditis like that picture. Why would a patient suddenly develop MRSA bacteremia? There has to be some source. There was no history of any significant contacts or any contagious diseases or anything like that, which was
No, sir.
present. So probably hematogenous source. So I would like to work up for the heart as well to rule out if there is any endocarditis or not.
And no comorbidities.
Sorry, sir?
Patient had no risk factors for MRSA
No, sir.
and no comorbidities.
No comorbidities.
And he never presented with pain in the hip. He
Yeah.
presented with,
Basically, he
Backache.
presented with
Backache.
fever, undifferentiated fever.
that is again strange.
So the transthoracic echo done, which was normal and no vegetations noted. Planned for right hip thigh implant removal with SOS revision fixation. Patient shifted to ward on 15th March. Fever started in the ward and started requiring 2-liter oxygen. UST guided aspiration of right hip done on 16th March and pleural fluid tapping under UST guidance done on 17th March. PET CT done on 18th March and patient shifted back to ICU on 18th March in view of fever and breathlessness. A repeat blood culture sent on 18th March which shows no growth. But the culture from the right hip aspiration shows MRSA with same sensitivity pattern. And the expert MTP of the right hip pus was not detected. And PET CT suggestive of there was an active disease on the lung parenchyma, mediastinal nodes, and moderate right and left pleural effusion, and hypermetabolic right paraspinal collection extending from the D5 to D9 vertebral level, and hypermetabolic pre-paravertebral collection extending from L2 vertebral level to the bilateral psoas muscle, and hypermetabolic small collection beneath the right iliacus muscle along the iliac bone, hypermetabolic multiple collection in the right thigh, and no metabolically active disease elsewhere in the body in the PET scan.
Yeah, so clearly the now focus has shifted not just in the right hip, now it has become a disseminated MRSA infection because the infection now is present in the lungs, in the paraspinal areas, and in the iliac muscle and everywhere. The only question is what caused this hematogenous spread, whether it was any embolic phenomena. He did not have any atrial fibrillation or clots or anything. We have worked up for the transesophageal echocardiography, there was no endocarditis. Whether he had any secondary immunodeficiency state, but I think you checked for triple H and that was also negative in this particular case. So maybe just an elderly gentleman, slightly altered liver functions, some source of gram-positive infection which has rapidly spread all across the body. And can you show us the culture report once again, MRSA?
So
Yeah.
this is right hip pus collection.
Pus collection and the blood culture both grew MRSA, and in both the cases you can see oxacillin is resistant, so it is definitely MRSA. Teicoplanin is sensitive, vancomycin is also sensitive. The vancomycin MIC is slightly higher, it's around 1. We preferably would like to have it 0.5 to 1. Teicoplanin MIC is good, 0.5. And despite starting the patient on teicoplanin and still doing the source reduction, still there was a case of disseminated MRSA. So I would begin to think whether he has some secondary immunodeficiency illness due to which there is such a rapid spread of MRSA infection.
What was the dose of teicoplanin?
So initially we started with 600 mg BD twice day, followed by we gave little higher dose 400 mg BD we gave. So initially there was no renal dysfunction, so easy to give less nephrotoxicity. Because of that, we prefer teicoplanin. Trough. Creatine was normal, but because of the trough level monitoring and nephrotoxicity concern, we started teicoplanin.
See,
So even if the MIC for
So
teicoplanin
is lower. If you look into the IDSA guidelines, it is the American guidelines. They use only vancomycin because they have no exposure to teicoplanin. But whereas if you look into the European guidelines, there is a lot of teicoplanin which is being used. The only thing is that teicoplanin has to be given around 6 to 8 milligram per kg. So if you have given at a 60 kg patient with a normal creatinine 600 or 800 loading and then 600, that should have been good enough considering the MIC is only 0.5. Vancomycin has its issues of checking the vancomycin trough levels, and that can be erratic at times. So I am okay with the drug being teicoplanin. You have done the source reduction as well, but despite giving a sensitive antibiotic and a source reduction, why did still the patient go on to develop such a disseminated MRSA disease? That is which I am not comfortable with.
So one more point, I was reading through the literature. The last IDSA guidelines are in 2011, I think. So the newer papers say that in preference to vancomycin or teicoplanin for soft tissue infection or bloodstream or soft tissue infection, particularly if that is the source, use daptomycin, 10 mg per kg per day, along with clindamycin. In preference to, so you can comment on that. So in preference to vancomycin and teicoplanin, it can be considered, say, for lung or some other issue where the vancomycin MIC is less than 1, then probably vancomycin is a better choice. For bloodstream infection and specifically for soft tissue infection, the first drug that should be given is now daptomycin. For bloodstream infection, ceftaroline in combination with daptomycin, and for soft tissue infection, daptomycin plus clindamycin.
Yeah. So in these cases of complicated MRSA infections, we move over from one drug to a combination therapy. Like sir rightly mentioned, if you are giving teicoplanin and it has not showed the desired effect, we would rather change it to daptomycin. But only thing is, in his PET scan, you mentioned there was lung opacities as well. Now daptomycin is rapidly deactivated by the surfactant. So daptomycin won't work so much for the lungs. So probably we should give a combination of daptomycin with another beta-lactam antibiotic. Now there have been reports which show that daptomycin with ceftaroline has very good effect in these MRSA infection because they have a seesaw effect. What happens is, because when you combine daptomycin with ceftaroline, the susceptibility to the beta-lactam antibiotics decreases even further. So actually it has a synergistic effect. So daptomycin with ceftaroline, or maybe daptomycin with probably something like a levodopa would be my choice to go further in this particular case.
So after the CT scan, we started with the ceftaroline 600 mg twice a day, along with the teicoplanin in view of disseminated MRSA infection. Underwent right greater trochanter of femur implant removal with a debridement under GA on 20th March, extubated in OT and shifted to ICU. Hip tissue sent for histopath and culture from OT. Fever subsided for next 2 days and shifted to ward on 22 March 26. This was a culture report of right hip tissue, also suggesting of MRSA with same sensitivity. And the histopathology report suggestive of acute on chronic necroinflammatory granulation tissue. So patient shifted back to ICU on 23 March in view of fever and breathlessness. Intervention radiology reference given to drain the psoas abscess. Size of the abscess was small and not visible in USG, planned for serial USG after 15 days. Breathlessness worsened, started with HFNC and later NIV in view of severe hypoxemia. We did a CT pulmonary angio, intubated on 26 March 26 and prone in view of severe hypoxemia. Teicoplanin stopped on day 13 and ceftaroline stopped on day 9, started with daptomycin and levonordi-fluoxetine. So this was the CTPA report. There was no evidence of pulmonary thromboembolism. Extensive ground glass opacification noted in both lungs. Confluent areas of consolidation are also seen in both lungs. These features likely suggestive of infective etiology. And there was bilateral mild pleural effusion also noted.
So despite being on ceftaroline and teicoplanin, still he continued to worsen.
I think even though you did the source reduction of that implant, the infection had already spread and he had sources of infection in the psoas abscess, iliacus muscle and in the consolidation in the lungs. So I think the burden of MRSA infection was too high in this particular case. Although the choice of antibiotics, I agree with you, daptomycin plus ceftaroline or daptomycin plus levonordi-fluoxetine. So levonordi-fluoxetine achieves good penetration into the lungs, even into the tissues as well. And daptomycin is very good for the bacteremias. So you have given the appropriate combination, you have done the source reduction. Maybe the burden of the disease was too high and maybe he had some immunodeficiency due to which the infection spread rapidly.
So this was the X-ray after intubation. This was the blood gas before intubation and after intubation. Before intubation, the PF ratio was only 64. After intubation, it was 160. So we did a transesophageal echo. There was no evidence of regurgitation in mitral or aortic and pulmonary valves. Increased echogenicity noted in tricuspid valve with TR, but no evidence of vegetations. So we send an SPUD carbo of rectal swab, shows NDM and OXA48 positive. Started with Savisefta and Astrionam. Repeat culture sent. Received 3 proning cycles for patient. FiO2 requirement reduced, X-ray improved and extubated to HFNC.
Did his repeat cultures show any gram-negative bacteremias, anything?
So before this worsening, we sent a culture. That culture shows blood culture was no growth.
So we are suspecting in a background of a disseminated MRSA disease, a new onset gram-negative sepsis as well, probably line-related this. So we have escalated the antibiotics in this particular case. And since it shows a resistance pattern of NDM plus OXA, our logical choice would be to go for ceftazidime, avibactam and Astrionam.
So this we have started based on the resistance pattern only and no bacteria available.
No. So this was the X-ray before 2 days before the extubation, and repeat blood culture sent on 8th April in view of fever and leukocytosis. Grew multi-drug resistant Acinetobacter baumannii as per successfully pattern. On 10th April, patient developed refractory hypertension requiring triple inotropic support. In view of worsening drowsiness and respiratory distress, the patient was intubated and initiated on lung protective mechanical ventilation. Bronchoscopy was planned. However, the procedure was deferred due to severe hemodynamic instability and high FiO2 requirement. Polymyxin B was added in view of progressive clinical deterioration. This was a culture report of the blood showing Acinetobacter, multi-drug resistant Acinetobacter infection with intermediate sensitivity to cholesterol and minocycline.
So this is a secondary nosocomial infection. In a background of disseminated MRSA, he had an Acinetobacter bacteremia. Mostly was it because of line related or was it was some any other focus of gram negative? And as per the sensitivity, we would definitely prefer either a polymyxin B with minocycline or even high dose sulbactam in this particular case to take care of the Acinetobacter infection.
So
One
because he was
question here. We started empirical antibiotics based on the resistant gene pattern, but the organism which grew was entirely different. So I am not sure. Maybe we could have started, if we could have found the organism, which is Acinetobacter, we could have started polymyxin or minocycline or sulbactam earlier. Earlier we started something else, just based on the resistance pattern.
Yeah, so the blood culture grew this Acinetobacter at a later date.
Correct.
So I think this Acinetobacter, because all the antibiotics that were going on, they were not covering Acinetobacter. So that might be the
Exactly.
one of the reasons why
Exactly.
preferentially
Exactly my
there
point.
was a
Yes.
infection with Acinetobacter.
And any this PCR based testing or something?
No.
No,
No,
sir.
we didn't. Okay. So carbar is again just plus oxa. So why endim and oxa?
So mostly what happened is he must have become colonized with all these resistant bacteria, and because the blood cultures were not growing and it grew NDM plus oxa, that's why they changed it to Zavicepta astronam. But that is one of the biggest drawback of Zavicepta astronam, that it does not cover Acinetobacter. So many a times we see these breakthrough Acinetobacter in patients who have been on Zavicepta astronam for a long time.
And is it common in your ICU, Acinetobacter
It's not common, but there are, in between there are some
outbreaks?
outbreaks.
Exactly. Once Acinetobacter gets into your ICU, it never goes.
But it's not the routine nosocomial infection that we get. We get more of Klebsiella than Acinetobacter.
Continuous renal replacement therapy was planned in view of anuria and severe metabolic acid. Repeat blood culture sent on 10th April showed no growth. Despite aggressive supportive management, the patient continued to deteriorate clinically. Following discussion regarding prognosis, the relatives opted for comfort care measures. The patient succumbed to illness on 11th April 2026.
So only question is, why did he have this disseminated MRSA infection? That is, to me, still not clear. So maybe whether he had any underlying liver disease to begin with, whether there was some baseline dysfunction in his liver.
There was
So
no
we-
chronic liver disease.
So the only clue was on USG. It was mentioned he had some altered echo texture.
He
It was
has mild
mentioned.
hepatomegaly, but the portal vein Doppler was normal, and he had fatty liver, but there was no ascites also.
That is the grading sort of thing, but altered echo texture was mentioned.
That liver issue, initially the patient was in under respiratory only.
Acha.
Once they clear from their side, shift to our side. So he came with bilirubin 15, but then everything settled down. And virtually they said that the liver is absolutely okay. That is the reason that only my question whether underlying he has some malignant say lymphoma or tuberculosis which has caused this.
Possibly.
So, yeah, that's what I was, because couple of times the imaging showed Ralliamotor's lesions here and there, and even in histopath also some one of the reports. So was Fox investigated and ruled out in this case? Because given the scenario, in our case I also talked with one of the panelists that there could be definitely a case of background of immunodeficiency. Because MRSAs we have seen also asymptomatic often come in different samples. But one patient going into MRS bacteremia and that too on the subsequent 1 or 2 weeks. Again, MDR Acinetobacter embryo, bacteremia is very uncommon. So I would suspect definitely this patient might have an attenuated presentation of disseminated box etiology and psoas abscess. MRSA infection from that.
I think that pus they had sent for gene expert, which was
The-
negative.
The hip debridement they did, that tissue was sent for gene expert, that was negative. Psoas abscess was too minimal to tap. So that was not.
The psoas is very difficult.
So that's what.
Sometimes you can't have that. Just a question in thinking loud, like probably an underlying box also
Possible.
explains the immunodeficiency. I do not know. I mean, all this lymph node, etc. Only in MRSA bacteremia cannot be explained. That kind of thoracic multi lymph node involvement.
You think when you are mechanical ventilator, you could have done the biopsy from lung or transbronchial biopsy or something from the ball or whether that tissue sample could have been taken. PET scan is never suggested fracture of it. It's only like kind of a localized correction in the thorax area. So because you have done a PET scan, if it is something like lymphodystimulated cause, you would have find some reason, like significant lymphadenopathy or something like that.
Otherwise,
So for me, it
lymph
looks
nodes
more
were there.
of inadequate source control to start with. That's the reason for spreading of MRSA. Because if it's an MRSA, I feel to start with only it is more of bone and
So there was some disease in the
Mediastinal.
mediastinal nodes. And
tubular manifestations could be very, very varied. We know that, like starting from some tertiary involvement to anything multi sites.
even if we are showing it's a delayed source control, the moment we came to know that impact came out, even if suppose in between he improved, only that is the only source and that is the only reason we should have not tried to
usually primary immunodeficiency should occur in a much younger patient. He is already 64. So
66. Thank you, sir.
Thank you, panelists, for the very good discussion.
Thank you for sharing wonderful insights on MRSA. So, to felicitate our speaker as well as our panelist, I would like to call Dr. Mahendra Bagul on the stage. Dr. Divya, please come on the stage. Now for the next talk, I would like to call Dr. Lakshman Jesani, and the topic will be how to deal with MDR bugs in ICU. And the panelist for this talk will be Dr. Vijay Debarao, Dr. Anand Srivastava, and Dr. Ameya Gode. Please welcome Dr. Lakshman Jesani with a big round of applause. Dr. Lakshman Jesani is the infectious disease consultant at Apollo Hospital, Navi, Mumbai.
ये पढ़ लो। नहीं इसमें बाहर है डिस्प्ले। किया सुबह ही किया है, सबसे पहले तुम्हारा ही किया है, सबसे पहले तुम्हारा ही किया है।
A very good morning, one and all. Thank you, Dr. Akshay and the critical care team for inviting me for this talk. I bring you warm greetings from Apollo Hospital, Navi, Mumbai. And what we are going to discuss over the next, that is multi-drug resistant bugs. And for the sake of time and for the sake of staying in the same topic, I have discussing mainly the gram-negative multi-drug resistant bacteria. I'm not dealing with the gram-positive or the fungi. So friends, we all know about bloodstream infections. It's a major cause of mortality and morbidity despite having appropriate antimicrobial therapy. And in our last case, we saw how a multi-drug resistant bacteria like Acinetobacter can be so fatal. But bacteria with gram-negative bacteria is basically a significant problem in both hospitalized as well as community-dwelling patients. We get many a times patients with urosepsis from the community, and they are also developing multi-drug resistant bacteria. So what are these gram-negative bacteria? They can have a mortality rate to the tune of 12 to 38%. The frequency of specific gram-negative bacteria depends on your hospital setting. It depends on the onset of infection, whether it is a hospital-acquired infection like the last case, or whether it's a community-acquired infection like the urosepsis. But what are the most common gram-negative bacteremias that we see are namely your Klebsiella, especially in Apollo. Klebsiella is the #1 multi-drug resistant bacteria that we see, followed by E. coli. Then comes Pseudomonas. In fact, Pseudomonas, we are again seeing a slight higher rise in Pseudomonas as compared to what we used to see maybe 5 years down the line. And because it is a tertiary and a quaternary care hospital, we see a lot of Acinetobacter infections as well coming from some of the secondary or tertiary nursing homes who come to Apollo Hospital. So friends, whenever you have a gram-negative bacteremia, we need to see what is the resistance mechanism. So for that reason, it is very important for you to understand how to interpret an antibiogram. So an antibiogram is basically a culture report which shows which bacteria is present and what are basically the antibiotics that it is sensitive to. So I have just enumerated few steps for you. How do you read an antibiogram? First thing is make sure that it is a gram-negative bacteria, it's not a gram-positive cocci. Second, then differentiate between gram-negative bacteria from fermenters and non-fermenters. For example, your Klebsiella, E. coli, these will be your fermenters as compared to non-fermenters such as Acinetobacter or basically your Pseudomonas or even some cases of Burkholderia or Stenotrophomonas. Third thing is then you have to anticipate what is the resistance mechanism in these particular gram-negative bacteria. Like we saw in the previous case, we did an expert Carba-R to see whether the antibiotic resistance is NDM or Oxa. Always remember which antibiotics not to use. For example, if you have a case of Acinetobacter, don't go for ceftazidime, avibactam and astronam because that will not work for those particular bacteria. Use molecular mechanisms. Now this is the flavor now. In tertiary and quaternary care hospitals, we always use molecular mechanisms to see the resistance mechanisms, which may not be true in tier 1 or tier 2 or tier 3 cities. Use of MICs. Now, MICs are very important. MICs are your minimum inhibitory concentration. Always use your MICs to make a treatment decision of which antibiotic to use and which not to use. Like in the previous case, we saw the MICs of vancomycin, which was slightly high. So to begin with, let me start off with a case to you and let us see how can we approach this case with this background knowledge of gram-negative bacteria. So this is a 28-year-old male who was admitted with hematemesis melina since 3 days. He is a known case of a chronic alcoholic and he presented with hypotension, tachycardia, icterus and hepatosplenomegaly. So typically these patients who come with hematemesis, they are resuscitated and stabilized in emergency. And as you can see in the LFT reports, they have slightly deranged LFTs and creatinine of 1.1 as well. So to prevent this hematemesis, endoscopy variceal band ligation was done. This was his X-ray which was taken on day 1. He had persistent tachycardia but no fever. BP was also borderline. So typically suspecting sepsis, blood cultures was sent and he was started on cephalosporin sulbactam empirically. The patient continued to have GI bleed and in view of this repeated GI bleed, he underwent a TIPS procedure, that is transjugular intrahepatic portosystemic shunt. His ascitic fluid culture was done, which showed no growth, and post this TIPS procedure, his GI bleed stopped and he improved clinically. But 2 days later, again he deteriorated, and by this time antibiotics were day 5 and WBC count was around 19,000. Then the blood culture report, the initial blood culture reports which were sent showed no growth. The later blood culture showed coagulase negative staph, which basically only grew in 1 out of the 4 bottles, so probably it was just a contaminant or a colonizer. What happened over the next few days in the ICU is he developed respiratory distress, his WBC count increased, he developed worsening renal and hepatic parameters, he was put on sled, and finally he was intubated and he was mechanically ventilated. So this was his X-ray on day 1, as I had shown you earlier. This became his X-ray on day 5, and then this became his X-ray on day 9. So what do you think? What is the diagnosis and what would you do? Anyone from the audience? Okay. So clearly this shows that possibly the patient has developed a hospital-acquired pneumonia because the patient did not have any radiological features to begin with when he came. Probably even some factor of ARDS or probably fluid overload as well. So what typically was done was his antibiotic, which was cefepozin sulbactam, it was escalated to colistin and tigecycline and meropenem. Everything was started for him, and his ET cultures was also sent, and one ID opinion was sought. So now coming to this case, now how do we approach this case? So this case is possibly a case of some gram-negative sepsis which is going on. Now how do we tackle this case? So in this case, remember, we have to make a choice of empirical antibiotic. In this case, because the patient has been exposed to carbapenems, we are probably dealing with a carbapenems resistant bacteria, which is our MDR bugs. So the choice of empirical antibiotic would be to cover the carbapenems resistant Enterobacteriaceae. So what are the points you need to take into account? First, as of now, we don't know the bug because the cultures have not flagged yet. It could be either of the 3. It could be Pseudomonas, Klebsiella, Acinetobacter. We don't know the resistance mechanism as well. It could be KPC, NDM, OXA. So we need to select a broad spectrum antibiotic that will cover all of these things above. So the blood culture report came, blood culture showed no growth, but the ET culture which was sent showed that it had a GNB growth. Now what do you do? Now such a patient who is sick patient in ICU, respiratory distress, having hospital-acquired pneumonias, ET culture showing gram-negative bacteria, which antibiotic would you go for? So this patient had grown XDR Klebsiella, a CRE Klebsiella. That means if you look at his culture report, you will see that even the carbapenems are resistant. So it is not an ESBL, it is a level higher than ESBL, it is a carbapenems resistant bacteria, and the patient is already on colistin, tigecycline and meropenem with these particular days. So what would you like to do in this particular case? So let me take you to the definition of MDR. So this is a typical case which we see now in our ICUs, where we see patients having gram-negative bacteria, they have resistant mechanisms, they have resistance to carbapenemases, and now we are left with very few choices. So when we say MDR, MDR means resistance to at least one agent in 3 or 4 antimicrobial categories. The typical example of an MDR is your ESBL. ESBL is basically extended spectrum beta-lactamases, in which typically we see the bacteria like Klebsiella or E. coli, they are resistant to either your ceftriaxone, they are resistant to amikacin, they are resistant to other antibiotics. When we talk about CRE, when we talk about carbapenems resistant bugs, we are talking about XDR, where there is resistance to at least one agent in all except 2 or few antimicrobial categories. So like in this case, a CRE bug is called an XDR bug because it will be resistant to carbapenems, it will be resistant to amikacin, resistant to your other gram-negative antibiotics, but it may be sensitive to colistin or tigecycline. And the third definition is PDR, which means resistance to all antibiotics, pan-drug resistance. But remember, that is never a possibility. There will always be some antibiotic which may be resistant. So PDR is more of a theoretical concept which is present. When we talk about carbapenems resistant bacteria, these carbapenemases, these are, what are these? These are enzymes. These are the carbapenem hydrolyzing beta-lactamases which confer resistance to a broad spectrum of beta-lactam substrates, including your carbapenems. That means in these patients, if you give carbapenems, they are not going to work because the bacteria are secreting enzymes like carbapenemases which rapidly render them useless. And this is a very important classification for all of you to remember, which is called as the Ambler classification. Here we divide the bugs into 4 categories: Class A, Class B, Class C, Class D. Class A are basically your KPC carbapenemesis, which is seen in Klebsiella. This typically is seen in the Western countries, in the United States, not so much in India. But Class B and Class D. Class B includes NDM. NDM is basically a New Delhi metallobeta-lactamases, which is very common in India, what we see. And Class D are your OXAs, especially the OXA48, which is very commonly seen in India. So from India's perspective, our Class B and Class D enzymes are very, very important. So typically, as I told you, if the bacteria secretes these carbapenemases, these carbapenems won't work. So we need to find out newer agents which will work against this. So this resistance rate has spread across. Earlier, maybe 5 years, 10 years down the line, the carbapenemase rate was only around, say, 5 to 10%. But now in our hospital, we see CRE rates to the tune of 20 to 30%, in some cases even 40%. And these resistance rates has spread all across India and all across the ICUs. And the percentage of NDMs have been very high. But as the recent paper which was there by Dr. Balaji from CMC Vellore, he has shown that the most common resistance mechanism in India, which was previously NDM, is now NDM plus OXA48. So if you look into your hospital ICUs, like we looked into our data as well, we found out that NDM plus OXA was the most common resistance mechanism for all your gram-negative pathogens. So friends, we have a mixed audience in front of us. We have the general practitioners and we have few of the intensivists as well. So just to make a broader understanding, how has these antibiotic resistance evolved over a period of time? So to do that, I have just given a bit of a Bollywood tadka to it. So let us consider antibiotics as your Bollywood actors, and let us consider your drug-resistant bacteria as your Bollywood actresses, and let me show you how the evolution of these gram-negative bacteria happened over a period of time. So let us go back to the years of 2000 to 2010. This was the time when the bacteria were predominantly ESBL and AMC. Just as these actresses were in their prime during the years 2000 to 2010, these bacteria were mainly ESBL and AMC. So what were these ESBL? ESBL are basically extended spectrum beta-lactamases, and they register resistance to your 3rd generation cephalosporin. That means your cephalosporin, which you use ceftriaxone very routinely, will not work. And the most common type of ESBL was your CTXM. But we were not worried. Why we were not worried? Because we had a solution to your ESBL and AMC. We had our very own Shah Rukh Khan. We had our very own carbapenem. So we were happy. This is from the year 2000 to 2010. ESBL, AMCs, not worried. We will give our carbapenems. What if we don't give carbapenems? Then we can give other antibiotics, like we can go for cephalosporin sulbactam, or we can go for piperacillin tazobactam. We were still not worried. Okay, there is ESBL, we'll encounter with piptas. If you have AMC, we'll encounter with cephalosporin sulbactam. We were happy. But the prevalence of ESBL started increasing to the tune of more than 75%. And then the bacteria went into a dangerous cycle. What was this cycle? They started producing ESBLs, and this ESBL producing bacteria, we started using carbapenems. When we started using carbapenems, the bugs became smarter. They started secreting carbapenemases. And these carbapenemases, like NDMs, were secreted by the bacteria. And then came the question, what to be done next? So then this is the years from 2010 to 2015, where all the XDR pathogens came into play. Then came into play the carbapenemase resistant Enterobacteriaceae, carbapenemase resistant Pseudomonas, carbapenemase resistant Acinetobacter. So these were the new bugs which were coming from the year 2010 to 2015. And all our carbapenems and the BLIs, these were gone. These are not going to work anymore. So what we needed to see, we needed to have a newer antibiotic. And this resistant movement spread all across the globe, not just in India, but abroad as well. So treatment options for carbapenemase resistant bugs were very, very limited. So the carbapenems is being gone. What were we waiting for? We were waiting for the new kid on the block, the colistin. So carbapenems were gone, colistin was in, and colistin was a relatively good molecule in the 2010 to 2015, where we used to encounter the resistance, but it used to work in many of these cases. Then there was always a debate which one is better. Is colistin better or is polymyxin B better? But as you all know, in our intensive care field, the polymyxin B has probably a better safety profile because it is an active drug which is there into the body, unlike colistin in which it gets into an active form. So colistin is given by a non-renal clearance, whereas polymyxin B, it is gone from an active form, not cleared by kidney, and then it achieves a higher plasma concentration. So clearly polymyxin B is an antibiotic which is superior to your colistin, but it's not very great for your urosepsis. The time to achieve Cmax, if you give colistin and polymyxin to the same patient, the colistin will take around 7 hours to achieve its maximum peak concentration, whereas polymyxin B will achieve that in 1 hour. So definitely, clearly, polymyxin has an added advantage over colistin as compared to its time to attaining the Cmax. The nephrotoxicity is also less with compared to colistin, because the colistin, the nephrotoxicity is there because it is renally cleared, whereas in compared to polymyxin B, it is not so much. Then there are other antibiotics for gram-negative like tigecycline, very good tissue penetration, good for intra-abdominal infections, good for skin and soft tissue infections, but it will not cover your Pseudomonas, not cover your Morganella. Then there is a minocycline. Again, minocycline, good antibiotic, especially for your Acinetobacter, and it has shown good results when you combine it with other carbapenems as a synergistic thing. And then there is always the sulbactam which is there, a high dose sulbactam. Now to the tune of 3 grams TID, up to 9 to 12 grams of sulbactam nowadays we used especially for our Acinetobacter. Then comes the question, which one is better, whether colistin as a combination therapy or colistin as a monotherapy. But what happens is the end result is the patient becomes bankrupt. So with all these antibiotics and all this combination therapy, the ultimate burn is borne by the patient. So this is a big problem. Antibiotics versus the resistant bacteria, the big fight which is always present. So let me take you to the journey. How do we approach these cases? So as I showed you the evolution of bacteria, how from ESBL to carbapenems and how did we use these antibiotics, let us now apply the same principles to our case which we had discussed. So remember, I have divided this into 2 parts. One is a resource limited setting, which is basically a tier 2 or tier 3 hospitals or a small nursing homes where you don't have the mechanisms to molecular testing. Second is a resource-rich setting, which is basically hospitals like Apollo, Terna, Fortis. In these hospitals, where basically you have access to your enzyme testing methodology. So we'll discuss in each of these particular cases, how do we approach. So resource-limited setting, let us come back to our case. So we had shown this case to you where we saw that the patient had developed an ET culture which was showing XDR, Klebsiella which was present, and now this patient is in your tier 2 or tier 3 city. What will you like to do in this particular case? So in this thing, we have 3 options available. Number 1, use antibiotics for which resistance has not yet occurred. Use the standard antibiotics with increased doses so that the pharmacokinetic, pharmacodynamic principles are achieved, and finally using a combination of antibiotics of all these above. So what are the options available? Use the carbapenem with the least MIC. So whenever you look at a culture report and you see carbapenem is resistant, always select the carbapenem which has the least MIC, use the highest possible dose, and always give it like a prolonged infusion of carbapenems. Use colistin, polymyxin B or tigecycline, and also make use of older antibiotics like chloramphenicol, phosphomycin, minocycline, so on and so forth. These beta-lactam antibiotics work by the principle of time over MIC. That is, longer the time the antibiotic is present, better would be the penetration. For example, in these 2 graphs, you can see if I am giving the carbapenem as a 0.5, as a 30-minute infusion, the time over MIC is only 33%, which will have a lesser killing effect. Whereas if I give the same antibiotic as a 4-hour prolonged infusion, my time over MIC becomes 60%. That means I am covering a larger area under the curve. That means it will have a better killing effect. So what should be the next step? Always know your MIC values. So just to recapitulate, what is MIC? MIC is basically the minimum inhibitory concentration, which means it is the smallest concentration of an antimicrobial agent which will inhibit the bacteria. So typically if you see all the antibiotics can be divided into 3 categories by the PK/PD, the pharmacokinetics. One is the concentration dependent. Now these concentration dependent antibiotics examples are your aminoglycosides. So when you have amikacin or gentamicin or streptomycin, you don't give it as an infusion, you give it as a push. When you give it as a push, as a bolus, it achieves a very high concentration, it kills all the bacteria and rapidly comes down. Whereas when you talk about beta-lactams, when you talk about penicillins, cephalosporin and carbapenems, you don't give it as a bolus. You give it as an infusion over 1 hour or 3 hours, because the longer the time over MIC is present, better would be the killing effect. And the third variety are your AUC by MIC, which are basically antibiotics like vancomycin or colistin, in which you have to calculate the area under the curve, and that will show the killing effect of that particular antibiotic. So coming back to the case, what did I mention? In a resource limited setting, look at the MIC values. So look at the MIC values. The MIC values are 16. Now these are very high MIC values. Why do I say high? Because when you talk about sensitive strain, the MIC value should be less than 0.5 to 1. So if it is less than 0.5 to 1, it is sensitive. But in our case, the MIC values is 16. So what will it do? So this higher MIC values is associated with higher mortality. Like just to show you this graph, when the meropenem MIC was 4 micrograms, and when we gave a high dose meropenem, the mortality rate was 13%. As the MIC value increased from 4 to 8, you can see the mortality rate also increases. When it increases to more than 8, the mortality rate jumps to 35.3%. So it clearly shows higher the level of MIC, difficult to treat the infection, higher is the rate of mortality. What about, can we increase the infusion time and can we overcome resistance? Now that is also possible, because if you see, if the MIC is say 4 for a meropenem and I give it as an infusion over 30 minutes, standard dose of 1 gram, what is the probability of target attainment is around 69%. Now if the MIC increases to 8, you can see when I give it by a standard infusion, the probability to target attainment decreases. But if I increase the MIC even further, the probability to target attainment decreases even further. So clearly shows that higher the MICs, the probability to achieve that target is decreasing. So what do? We give it as an infusion. So what was 69% was covered with 1 gram over Q8th hourly over 30 minutes. Now if I make it 2 grams over 30 minutes, look at the probability of target achievement. It increased to 93%. Similarly, let's make it 2 grams Q8th hourly. So then the target achievement is 100. So clearly you can see, even though your MICs are high, if you give the meropenem as a prolonged infusion and if you give the meropenem as a double the dose, you can still achieve the probability targetment of 100% even though your MIC is 4. So MIC more than 1 is resistant. So I'm telling you that even the MIC is 4 and I'm giving at a prolonged infusion, I can still achieve my PK/PD targets very successfully. So this is the dosing strategy for your tier 2, tier 3 cities. How do we approach it? So always go for a carbapenem which has the least MICs. MICs more than 16 are usually useless. Don't worry about it, it's not going to work. If the MICs are more than 16, look for alternative antibiotic. If the MICs are less than 16, you can go with meropenem or carbapenem as a high dose strategy, and you have to look at other empirical agent as well, such as polymyxin B. When you look at the polymyxin B, again look at their MICs. If the MICs is less than 2, you can continue with it. If it is more than 2, you have to look for other agents such as a tigecycline based regimen or a double carbapenem strategy. Now what is a double carbapenem strategy is basically you use 2 carbapenems at the same time, like you use ertapenem and meropenem at the same time. In that thing, the bacteria attacks the ertapenem and ertapenem acts as a suicidal agent and the meropenem then gets entry into the bacteria. Tigecycline, again MIC less than 1, you can use it, more than 1, you cannot use it. Similarly for phosphomycin, again phosphomycin, remember the MIC points will be as per UCAST guidelines and not as per the CLSI guidelines. And amikacin also, if it is less than 2, it is useful. So in all these agents, in a limited resource limited settings, one agent for your carbapenemase resistant bacteria is the same molecule that we had discussed, is basically your colistin or your polymyxin B. So if you have a CRE case in your nursing home, don't fiddle around with carbapenem, straight away go for either colistin or polymyxin B. Advantage is it covers all your bugs, Pseudomonas and Acinetobacters. It covers all your KPC, OXA and NDM. And this is a very good algorithm just to show you how do we approach a case of a carbapenemase resistant bacteria in a resource limited setting depending on the MIC values. So on these values basis, you can give the antibiotic in a step ladder fashion, like starting with polymyxin, then looking at tigecycline, then looking at phosphomycin and other antibiotics. And this is the double carbapenem strategy which I told you, which you can use in some cases, but these studies are mainly in the KPCs and not in NDMs, so I doubt whether it is of great value, especially in India. Why do we go for combination therapy? Combination therapy is always better because it provides a synergistic activity, because the beta-lactams act at the cell wall and they allow the penetration of other antibiotics like aminoglycosides to the ribosome. Combination therapy also helps in prevention of resistance, and also it helps in broaden the spectrum of agent from one resistance mechanism to other. So there are various studies which was done for monotherapy and combination therapy. Now this is only of theoretical interest to us, because like you can see, the mortality rate in combination therapy was significantly lower as compared to monotherapy, and studies by Falagas, Tamburello and the increment study had suggested that probably combination therapy is good enough. But our concept about this combination therapy changed with this paper which was published by Mikhail Paul et al., which suggested that you no longer need to give a combination therapy, especially for a carbapenemase resistant Acinetobacter infection, where they compared colistin monotherapy versus colistin plus meropenem, and they found that there was almost equal results which was achieved. So probably in Acinetobacter infection, you don't longer need basically a combination therapy. No significant difference between colistin monotherapy and combination therapy was found out. Even our Indian study by Dr. Gafoor et al. From Apollo Chennai had shown that basically monotherapy and combination therapy, there is no significant difference which is present. Another important concept, especially in your resource limited settings, is your pharmacoeconomics. Remember, cost is a very important factor. Cost includes your medications, the consultants and visits, administration of other medicines. So cost is a tertiary consideration after, of course, considering the efficacy. Now we are in the era of colistin resistance. These are the papers which we had published from Apollo Chennai, which showed that now we are seeing a series of colistin resistance. That means even your new molecule like colistin or polymyxin B is not going to work. So then what are the options left? The options are we go back to our older molecules like phosphomycin. Now phosphomycin is very good molecule, especially if you are dealing with E. coli, if you are dealing with urosepsis. Chloramphenicol, yes, for their severe resistant mechanisms, patients, chloramphenicol is making a comeback. And then finally comes a resource-rich setting. Now, resource-rich setting is something like a Apollo hospital or a other tertiary care hospital where you have access to your resistant mechanisms. So what we do, we come back to our same case again. This was the case where we had left. The ET culture had shown GNB growth. Now, if the same patient was in Apollo hospital, what we would have done? What we would have done, we would have done this particular test called as expert Carba-R, which was advised. This expert Carba-R is basically a molecular mechanism. It gives you the results within 30 minutes. It helps you in detecting whether it is a carbapenemase resistant bacteria or not. Very good sensitivity and specificity, and it can detect all 4 to 5 types of resistance mechanism. So if you look into the conventional method, the Don-Bradman method, if you want to detect a carbapenemase resistant bacteria, you have to wait for at least 48 hours till your lab gives us the result, okay, this is a carbapenemase resistant bacteria. But in today's age of Virat Kohli's age, we can use Carba-R and can find out the results in a matter of just 2 hours. Is it useful? Yes, we had used this mechanism in Apollo Chennai as a pilot project to see for the antimicrobial stewardship practice. So what we did there, in that patients, whoever patient's ICU blood culture had come flagged positive of gram-negative bacteria, we started doing them the expert Carba-R. If the expert Carba-R showed it is resistant, we used to escalate the antibiotic. If the expert Carba-R showed that it is sensitive, we used to rapidly de-escalate the antibiotic. So this was used as an antibiotic stewardship tool in order to decrease the antibiotics which is being used. So coming back to our case, what we did the expert carba in this particular patient, and it showed OXA 48 plus NDM. So again, coming back to our classification, if you have OXA 48 or NDM, what are the antibiotics that you can use? We can use newer antibiotics. Now the new flavor for this season is your ceftazidime avibactam plus astronam, or even better, the combination of astronam plus avibactam. So if you have a combination of astronam and avibactam like Emblavio, which is present by the Pfizer, you can see it covers all the resistance mechanisms. It also covers your OXA 48, it covers your NDM. There is another molecule which is now going to be launched soon called as cefepime zidebactam. Now that is another molecule which will cover all your enzymatic methods. So the choice of antibiotic becomes very simple. You do the resistance mechanism, and by the resistance mechanism you treat that patient with that particular antibiotic. But friends, all is not so easy. With all knowledge also comes a few gaps in the knowledge as well. And just by knowing whether you are dealing with a CRE is not sufficient, you need to know the resistance mechanism. So that is the reason why the IDSA guidelines have now moved over polymyxin or colistin. If you look into the IDSA guidelines now, they don't give importance to colistin or polymyxin except for urinary tract infection. They only give importance to basically a ceftazidime, avibactam and astronam. In fact, what they have mentioned is that polymyxin and colistin should be avoided except in cases of CRE cystitis. So what is the recommendations they give? The recommendations they give is basically using your ceftazidime avibactam with or without astronam depending on your resistant mechanisms. But is this molecule perfect? Is this the final answer that we have? Okay, I have astronam avibactam, I have ceftazidime avibactam, astronam, now I am happy with it. No, it has also drawbacks. What drawbacks are there? Remember, as we had shown in that earlier case, the ceftazidime avibactam does not have action against Acinetobacter. It does not have action against your anaerobes. It will not cover for your NDMs, and that is the reason why we combine astronam to ceftazidime avibactam. And this is a very important consideration, especially in Indian settings in developing countries. And not only that, now we are seeing resistance which have been emerging to ceftazidime avibactam, especially the PB3 inserts, the penicillin binding protein 3 inserts, especially in your E. coli, which is rendering the ceftazidime avibactam also as a useless. There is no randomized controlled trial to show that ceftazidime avibactam is superior to polymyxins, and even when it comes to renal replacement therapy like CRRT, we do not have the exact dosing guidelines how much should be given. So it has limitations in ceftazidime avibactam as well. The combination with astronam, definitely it is better, but again, you should always know your local antibiogram. So this is something which I always tell all of you, go back to your hospitals, go and discuss with your microbiologist, tell them to give you the last 6 months antibiogram and see what is the resistance mechanism. Maybe Klebsiella is most common in Apollo, maybe Pseudomonas may be most common in your setting. You should know which antibiotics work well in your particular setting. So in summary, I have discussed you about the MDR bugs, I have discussed you the treatment options, I have discussed with you the treatment options in a resource limited setting, I have discussed the treatment options which is available in a resource rich setting where you have access to molecular mechanisms, and these newer antibiotics have become available. But remember, these antibiotics are advantageous, but these are expensive, and the resistance is also developing during the treatment. Some attractive agents in the pipeline, as I told you, cefepime zidebactam is there, but there are some unmet challenges, especially for Pseudomonas. For example, right now, for Klebsiella, I am not that worried. I have astronam avibactam to take care. But what about for Pseudomonas? For Pseudomonas, we don't have. We are just left with colistin or polymyxin B. So these are some of the questions which are left unanswered, and these are the answers which we are looking for. So to conclude my presentation, I always leave with this slide for all of you. So this is a slide, this was a heartbreaking image taken by an Iraqi artist in an orphanage. So this little girl had never seen her mother. So she just drew the picture of her mother on the ground and she fell asleep with us. And what a coincidence, today is the Mother's Day as well. And the message which goes is basically, appreciate what you have, since you don't know what you have got until it is taken away from you, and that it's when it is too late. So the point is, appreciate what you have right now. Similarly, use antibiotics judiciously, because we don't know for our future generations we will have enough left or not. With that particular thought, I'd like to end my presentation. Thank you very much. If there are any questions, I'll be happy to answer.
Is there any particular use case where ceftazidime avibactam plus aztreonam combination is preferred to aztreonam avibactam?
So especially the ceftazidime component in your Zavicefta can cause a lot of neurotoxicity. And secondly, the levels which are achieved are not that great. So if cost is not an issue, I would suggest the new flavor is now Aztreonam avibactam. You don't need to give Zavicefta plus Aztreonam, just go straight away with Aztreonam avibactam. So pan-drug resistance, as I told you, is a theoretical concept. There are always new molecules which are coming in. The newer molecule is cefepime zidibactam. So with that molecule, we can overcome even your pseudomonas or your NDM plus oxa. So pan-drug resistance, as I told you, there will be some molecules, sometimes chloramphenicol can be sensitive as well. So it's a theoretical concept, it cannot be pan-drug resistant. Yeah. Yes, sir. Yeah. Yeah. So I think this is always a controversial topic, yes. So the thing is, as per the PKPD, the amount of EDTA which should be present in vivo, that much amount of EDTA is not there in the molecule. So theoretically speaking, if you look into the in vitro lab test, in vitro shows that EDTA chelates and EDTA causes good action. But if we have to extrapolate that to in vivo effect, we need to give very high levels of EDTA which may be toxic. So that is the reason why we had a good discussion on this, and the general consensus was that the EDTA level in that molecule, the LRS what you're talking, is not high enough to inhibit the bacteria, because we cannot give that much toxicity. So I would suggest that we move over that molecule, we go for other molecules which are better available. Yes, exactly. But those are not FDA approved or not approved antibiotics. There is meropenem sulbactam, ceftriaxone sulbactam. Yes, but these are not rational, ma'am. No, ma'am. It is market driven. Yeah. Yes. Yes. No, ma'am, because the SIDS body, which is the Clinical Infectious Disease Society body, has given it strong objection to these particular combinations, but they still exist in market. Yeah. Yes, sir. Yes. Exactly. So bacteriophage is coming in a big way. The only thing is there is no transparent process to see how are the phages being developed and how are they being used. So, but phage therapy is something which we need to look forward to. When no antibiotics work, these phages are going to work. I am expecting big changes in this phage therapy over the next 5 to 10 years. No, we have not used it. The only thing is there are some anecdotal case reports of good results in sepsis patients. But as I told you, they are not well published. There are no randomized controlled trials. They are just anecdotal cases that we had phages, we used, and we got good results. Yes, sir. Correct. Yes. Yes. So surveillance cultures are good from your infection control point of view, where you can have those OT plates and surveillance cultures. This will help you know what is the infection flora which is there in your particular OT or in particular ICU. But clinically, it may not be sometimes correlating, because the OT environmental pathogens are usually your Acinetobacter, but pathogens which may affect your body may be Klebsiella. But it is still always a good idea to know what is the resistance mechanism in your particular ICU. And I agree with you, the pathologist should include these newer antibiotics. In fact, if they can approach the company person, they provide with E-strip and discs as well. So they can, pathologists can check, you know, if Astronam avibactam is sensitive or not, they can check with that. Yeah. Yeah. Yes. So there is a difference between colonization and true infection. So if a patient is coming from some nursing home and just you take the rectal swab and do the expert carbar, you will know that they are colonized with NDM plus oxa. They need not have those particular infections. So what I would suggest is these colonization indexes are best suited for an immunocompromised and transplant patients. In those settings, you can apply these principles. For example, if I have a hemonc patient, he is colonized with NDM plus oxa, and now he deteriorates, I would straight away go for Astronam avibactam. But same patient, if he is stable, coming from community, still colonized, I would not jump with these antibiotics. So it has to be taken on a clinical and case-to-case basis. Thank you. Yes, sir. Now. So what I would suggest is always try to find out the cause. Treat the underlying cause, find out the etiological agent. If the patient is stable, you have time, send the cultures and treat as per cultures. Empirical therapy does not help in a long way. So try to find out the underlying cause for it. Yes, I know this is a challenge, so you should go in a step ladder fashion and try to find out. Yes, thank you.
And nowadays only I would just like to add about the tele-ICU provisions. In such scenarios, actually the is readily available, widely available.
Yes.
So for the doctors, both in the interest of the patient and their own interest or in a hospital as well, can take some advice from the experts across
Absolutely.
domain.
Yes.
And just document that. Counsel the patient. It is up to, of course, their wish to go or do not go, but I think
Correct.
safe and patient is
Yes, Dr. Akshay Chalani is heading the EICU in Apollo, so maybe you can take some words of advice. Yeah. Thank you.
Thank you, Dr. Lakshman Desani, for sharing wonderful insight on the MDR bugs. Now, to felicitate our speaker as well as our panelist, I would like to call Dr. Sudeep Sen on stage.
Lakshman will double felicitate you. No, you be around. You be around. Okay. Sudeep, he will be around actually. I'm changing. Dr. Vijay is our clinical pharmacologist actually. Thank you, Dr. Anand, Dr. Ame, Dr. Vijay. Chairperson को next. So to deliver a next talk, I request Dr. Sharmili Sinha to come on the dais, please. She will talk upon the pulmonary embolism and the recent guidelines. She is a General Secretary of Indian Society of Critical Care Medicine, and now she is heading ICU at Guwahati in Apollo Hospital. So I request Dr. Sharmili to just take on the dais. To chair the session, I request Dr. Bharat Agrawal and Dr. Bhushan to come on the dais, please. Over to you, Dr. Sharma.
Very good morning, one and all, and it's been a pleasure here year after. I think it's year 3 consecutively that I'm here for this Apollo Critical Care Conclave, and immense thanks to Dr. Akshay, my good friend from Hinduja days, and always wonderful to be here. So after this power-packed talk on infectious diseases, it's always a pleasure to hear about MDR infections in ICU. Here is a talk about the recent updates about pulmonary venous thromboembolism. So friends and colleagues, we know about that pulmonary embolism, especially the acute pulmonary embolism, is a life-threatening condition in ICU. And for several years, gradually we have seen the rising awareness about the practices, how to prevent, diagnose, and treat these cases effectively. Recently, there has come renewed guidelines in this aspect from American Heart Association and endorsed by many, many societies across the country. So in this next 30 minutes, we'd consolidate about what are the recent updates in this field. So these are the learning objectives. So as I said, we knew already about this existence, how to prevent, diagnose, manage the complications. But what is more, if you go through these guidelines, what is different, let me tell you in concise, that it has been more consolidated, it has been classified, codified, and some of the newer aspects, and mainly the interventional aspects, also have been emphasized. So these are the broad headings, which we'll be covering in the next few minutes. So I'll start with a case scenario. It's a 22-year-old male who had a fracture femur, was outside for 5 days, and then comes after referral to our hospital on SEC, because the first day was a Saturday. He was planned for surgery on Monday. Unfortunately, on day 2, which is a Sunday, he suddenly collapsed around 2 p.m. There was a brief CPR given, and then he was shifted to ICU. He was severely hypoxic and hypotensive tachycardic. So the obvious diagnosis with this kind of young boy, no other comorbidities, and a fracture femur of around 6-7 days old now, acute life-threatening pulmonary embolism is the diagnosis. So how do you go about it, how you manage? We'll just discuss. And this is a second case, interesting scenario I would say rather. It's a 62-year-old man who had a fall at home. He's a known diabetic and hypertensive. Fracture right femur was diagnosed, but during evaluation, she was found to have a very high blood sugar, which was undiagnosed diabetes mellitus. HbA1c was 11.8, so she was advised for a little bit good control of the sugar and to come back for the surgery. Now 3 weeks later, she comes for surgery. Vitals have been stable. You can see the saturation and all other vitals are good. In the pre-anesthetic evaluations, given her comorbid conditions and diabetes, etc., cardiology clearance was asked by the anesthetic team. Now the cardiologist, during his evaluation, asked to rule out DVT for cardiology clearance. So how many of you do agree with this? cardiologist asking to rule out deep vein thrombosis before giving cardiology clearance. Echo, ECG is normal. DVT screening, anything. Just that is nothing right and wrong. It's a practical scenarios because we see many clinical experiences beyond textbooks, beyond guidelines, and guidelines are not guidelines. So when we practice, things are very different. We had seen the case MRSA bacteremia in the morning, so this could be very different. But anyway, we'll come. There is nothing right and wrong, let me tell you. So would you like to go for this duplex ultrasound of the lower limbs in this cases to rule out a DVT, or just go for a D-dimer assay, just do a 2D echo, which has been done anyway, or CTP at all? We'll explore these answers in the next discussions. Just having a touch of the background, the Virchow triad, which always tells us why DVT is a reality and it can cause life-threatening situations. Just enumerating the risk factors for venous thromboembolism in hospitalized patients. Basically, all sick patients who are chronically ill or acutely in the hospitalized conditions more than 2-3 days are at some risk or other or higher for developing DVT and pulmonary embolism. And you see the varied incidence of this or particular condition varies from 10 to 80%. It's quite varied. And all systemic diseases which have got some inflammatory component also predispose these patients to develop these conditions. So diagnosis basically starts with clinical risk factors, signs, symptoms, history, and imaging biomarkers at the end. And till date, it remains a diagnosis of exclusion because the common things are common and uncommon things are uncommon that we always believe. But however, the history and clinical factors always remain. Quick look at the pathophysiology of instability, why you worry about it, because this is a condition which acutely puts both the ventricles, both the right and the left ventricle can be unstable and hence lead to shock and irreversible shock and hypoperfusion status if you're not addressing the obstruction caused by the embolism. So this is the guideline we have been talking about, and this is a free downloadable literature from the internet. We'll not go into the details of it. It's a very huge and many pages are there, more than 100 pages are there. We'll just touch upon the key aspects of it. So which includes suspect and diagnostic steps. It has been codified according to the severity of symptoms, management mainly in the unstable conditions, and some disease-specific recommendations have been also included. Earlier we used to talk either this unfractionated heparin or low molecular heparin or this newer anticoagulant drugs. They are safe for some disease or some not. They have just made it more concise and consolidated for us. Few scores, I think most of us know this, these are in the textbooks and literature, Wells scores. And when we talk about this acute pulmonary embolism, because it remains till date a diagnosis of exclusion, some of this probability we talk about in the context of diagnosis, suspecting and diagnosis these cases. So Wells score is one of the oldest ones and well validated. Also there is a Geneva score. Now this Geneva score has been revised and made more simplified. EOS criteria. This is something I would like you to draw your attention for this. This is a quicker one and clinically it can be assessed and verified. Does the patient have clinical signs symptoms of DVT? Number 2 is does the patient have got hemoptysis? And if P is the most likely diagnosis. So coming to our case 1, in that case, for the young boy, 22-year-old man with fracture femur, all these questions probably, first one is yes, second one is no, and third one is yes for this case. So this patient has got positive years criteria, which is 2. But if a patient has 0 years criteria, like the second case, patient has no symptoms, but there is a risk factor of more than 3-week-old of fracture, you can suspect these cases. In that case, instead of going for a more invasive state, you can go for D-dimer assay. If it is less than 1000 nanogram per ml, you can safely rule out DVT, hence, of course, symptomatic pulmonary embolism is not there given the stable vitals. This is something the new addition in this guideline. This is another simpler one, PE rule out criteria. So if these things are there, one of these things are there, chances of developing a symptomatic pulmonary embolism is very, very less. Again, it fits the impression, age-old impression and the hypothesis that it remains a diagnosis of exclusion. So it is PE rule out criteria, per criteria for students and for general practitioners. So emphasizing on the clinical evaluation with suspected acute PE. If there is low clinical probability, you can again just go for this PERC, that is rule out criteria. If there is intermediate to high clinical probability, you can go for next for this EAR criteria, which is again a clinical one. and then take help for biomarkers. And that is the D dimer most likely. If the years criteria is less and it is D dimer is less than 500 nanogram per ml, then you can safely rule out PE diagnosis. Even if your years criteria is 0, but D dimer is more than 1000 nanogram per ml, like the second case, if there is no years criteria, it is 0. But if the D dimer comes more than 1000 nanogram per ml, one can go for the diagnostic imaging. Now, comes to imaging, we know, and there is concurrence across the world without any deviation, that CT pulmonary angiogram remains the gold standard for diagnosis of acute pulmonary embolism and even for chronic pulmonary embolism cases. However, wherever VQ scans are available, high probability scans can be also utilized to diagnose this. Having said this, in my practice of around 22 years, I have not seen a single case of VQ scan being done to diagnose pulmonary embolism. Long back in probably 2005 or 6, we had seen one case of VQ scan, and in Australia also one case I had even seen when it was talked about chronic pulmonary embolism. But more or less with more diagnostic efficiencies, better machines, and better patient management, CTPA remains the diagnostic or imaging of choice. SPECT in infrastructure wherever it is available is also a reasonable preference. Lower extremity ultrasound can be done in confirmed PE cases. It is though not necessary, but however it can be done for prognostications and to decide the duration of treatment and subsequent follow-up cases. Now what about pregnancy? Pregnancy, we know that it's a hypercoagulable state, and there could be, again, if a lady presents with breathlessness, there could be at least 5 to 8 cases which could be very close differential diagnosis, especially second trimester onwards. So in these cases, if we have risk factors which are actually invariably there, the P criteria will be fulfilled, even the years criteria will be fulfilled, even the D dimer might be high. So in these cases, a low dose CTPA can be performed with which can be preferred over scintigraphy. Because earlier what we knew is that probably VQ scans can be considered in these cases compared to CTPA. But with the improved radiography and this imaging techniques, low dose CTPAs can be performed in these cases because they will definitely influence the treatment, has got impact on the management and survival. Why CTPA? Along with this diagnosis of and location of the thrombus, it gives you a lot more many informations which actually gives you an outlook or impression about the functional status of both the RV and the left ventricle. So location of even if you can look at the right ventricular enlargement as well. 2D echo as a tool to diagnose and confirm the diagnosis of pulmonary embolism is no more recommended. You can do it to supplement your diagnosis, but this is not a diagnostic imaging. CTPA can give you impression about the RV and the LV contours, their diameters, and even the size of the pulmonary arteries, IVC as well. So this is something which is different from our ongoing discussion for decades about the role of echo. It's not completely contraindicated, but it is not recommended to confirm the diagnosis or refute the diagnosis of pulmonary embolism. RV and LV end-diastolic ratios, RV end-diastolic diameters, and all the functions of this valves, etc., however, can be seen on the 2D echogram. McConnell sign is one of the characteristic signs of pulmonary embolism. RV enlargement or hypokinesis, especially the free wall hypokinesis, with sparing of the apex. It usually comes as a question in the exams. So now coming to this classification or coding for depending on the severity of the symptoms of pulmonary embolism. So they have, you can see, they have classified it from A to E. A, B are in a low category, low clinical severity scores, not worrisome. C to E, they are the ones which actually there is gradual mounting of the symptoms, and D and E, they are already in cardiopulmonary failure of various grades. And these are the ones they have been again classified, which require life support and thrombolysis or interventions. So coming to interventions regarding the anticoagulation therapy, it remains the class 1 recommendations, and low molecular heparin is preferred over unfractionated heparin, which require parenteral anticoagulation therapy. Starting from C1 to E1. Starting from C1 to E1, it is the heparin of choice, that is low molecular heparin. Now for all cases who are actually eligible for oral therapy, DOACs, that is oral anticoagulants, are preferred over vitamin K antagonist, because we know that this vitamin K antagonist have many side effects and the effects are unpredictable. Coming to cases, second one, last one about the suspected acute pulmonary embolism. Like the first case I presented, obviously there is a very high probability of having an acute pulmonary embolism in that case. But patient is unstable, patient is not ventilated. Taking those patients to the radiology room for CTPA is a challenge. So those cases, if your suspicion is very high, even without imaging also, you can go for therapeutic anticoagulation in those cases. And recommendation is relatively high. Class 2A is acceptable. Now, anticoagulation, they have also specified and consolidated in special conditions. In obesity, DOACs are preferred. But in cases of pregnancy and breastfeeding, it is not recommended. You can use low molecular heparin in such cases. What about CLD, chronic liver disease? We know about this child few classifications. In A and B classifications, DOACs can be preferred. But C and D, it is not preferred because the chances of bleeding will be higher. Hemodynamic therapy, once the patient goes on to require the class C3 to DE1, patients requires hemodynamic support and cardiorespiratory support as well. They are on ventilator or vasopressors. They would require vasopressors and inotropes to maintain perfusion, blood pressure, and the cardiac output. VA ECMO in the last resort in refractory shock, where profound shock, we are not able to maintain the perfusions. Veno-arterial ECMO is advisable in such cases. What about this IVC filters? Patients who cannot tolerate systemic anticoagulations, this IVC filters can be utilized by the temporary times, and retrievable IVC filters are recommended over the permanent IVC filters because these at some stage should be removed. Because IVC filters, if they remain in place for long times, they themselves can become a trigger for causing smaller emboli, fractures and infections, etc. What about systemic thrombolysis? In eligible patients who are at low to medium bleeding risk, this must happen, especially our case 1 should go for systemic thrombolysis after risk assessment. And there should be always good documentations about this decision making and the family's consent about it because it involves cost and complications can be life-threatening and fatal. Catheter-directed thrombolysis, with now the advancement of technology, more training and the expansion of this infrastructures, we see more of this CDL, catheter-directed thrombolysis happening. Around 5 years or 7 years ago, we are not, we had just started hearing about CDL, catheter-directed thrombolysis, and we used to worry about more complications, maybe the vessels might get ruptured. But now, with more improvement in the technology, the precisions and this kind of catheters that has been invented, this is becoming more and more safe. And they're also using these kind of agents only, which are used for systemic thrombolysis. Of course, because it is just locally injected, the systemic effects of this thrombolysis is less. So altiplase can be used up to the same dose of 10 milligram in these cases, but it is just locally injected over that particular clot instead of giving a systemic injections. What about mechanical thrombectomy? Again, in cases where patients are unstable and if there is an expertise is there, center is geared up for that, mechanical thrombectomy along with anticoagulation can be considered in these cases. Having said that, we see very, very few cases across the world, not only in India, which actually just go for mechanical thrombectomy and thrombolysis together. Surgical embolectomy is more of an invasive procedure, can be devastating, and I have not seen or heard of cases being done these days. However, if you have to end up opening the thoracic cavity or the heart for any other reason, concomitant problems, this can be considered in those cases. What about, they have also emphasized on the follow-up care of pulmonary embolism because the standard duration of treatment, so far you knew, suppose there is a leg DVT, you do the acute anticoagulation systemically and discharge these patients maximum up to 3 to 6 months used to advise. But now it is said, which is rightly said I believe, that patients who do not have any other risk factors for developing recurrent PEs or DVTs, if they have developed such a case and it has been under treatment, they should be at least under follow-up for 1 year. At least 1 to 2 months they must make a visit to the OPD clinic. They should be asked about the problems of intermittent cough or shortness of breath or any other bleeding problems, and accordingly the decision for continuing this oral anticoagulant if at all should be considered. Apart from these patients who are actually oncology patients are another high-risk group of patients, I would say. Now again, We see the improvement of this chemotherapy, precision radiotherapy, immunotherapy, the longevity of these patients in the community is increasing. But nonetheless, these patients remain at, again, high risk of developing DVTs and pulmonary embolism. So they are the ones also actually during their routine visits either to the oncology clinics or to the physician clinic or whosoever is seeing these patients regularly should be also screening and assessing these patients for possibility of DVT and PEs. Because recently we had a case. He was a young guy who had a sarcoma. He had almost cure, I mean, according to his previous reports. He came to us, he was no complaint, mild thigh complaint, and there was no leg swelling, and very distractive symptoms. Within 2 days, he developed a sudden onset of hypotension and hypoxia, got into the life support system and all that, and when we investigated, we found a big thrombus in his thigh. So he was on some drugs at home, mild, and he was requiring some antipsychotic, antidepressant also, very non-specific symptoms. So these patients, along with their general assessment of the vital, should be also screened for these things because most of these cancers, including this blood risk ratios and all that, are at high risk of developing cancer, pulmonary embolism or DVTs. So coming to this first case, class 1, the first case comes from the category of class E. So clearly for a thrombolysis, suppose even if you could not have taken this patient for CTPA, this patient could be thrombolized with proper counseling and documentations. Actually, we did counsel this patient and we started the anticoagulation before we did the CTPA, but before actually thrombolysis, we did the CTPA and then we thrombolized. So anticoagulation and thrombolysis are two different things. We can start the anticoagulation by time and thrombolize. But some cases will not give you time for anticoagulation. You have to then and there thrombolize, but with again counseling and documentations. Case 2, as I said already, that these patients probably had 0 years criteria, which we discussed. So in this case, if the cardiology is insisting for to do a duplex ultrasound to rule out for the leg DVTs, we can actually avoid that investigation. We can just send a D-dimer in that case, and if it is less than 1000 nanogram per ml, we can safely say rule out, document and rule out pulmonary embolism. Why the cardiologist will ask for doing duplex ultrasound in this case? Any reasons, anything? You think it is unnecessary? Because this patient, somebody who has been there for 3 weeks immobilized, that could be thrombus, and during movement when they do the surgery, etc., it can actually dislodge and cause a pulmonary embolism. And it has happened. It has happened in peripheral case, smaller centers and patient come to us. But this is the provision and which answers our questions that we can avoid such kind of ultrasounds, because something it comes into the range of around 10 to 15,000. So that cost can be minimized. So my take on the guidelines will be that guidelines are not guidelines, and general extrapolation of the guidelines which have been contributed by from these Western and resource-depleted centers may not be necessarily extrapolated to Southeast Asian countries with varied healthcare setups. We have to have a simpler guidelines which can be actually catered to our general physicians and practitioners across the state and the society. And we must develop, it's high time, develop a DVT and PE registry in our country. Data generation is most important, because look at the third slide of mine where I said the incidence is 10 to 80%. This is no kind of data. I do not buy it. I mean, it's just for the sake of it, we share it, but this cannot be this varied. So we need to have our own data. It is not difficult. It's not gives us any medical legal problems. It does not point at our inefficiencies. It can happen. Problems can happen despite best of our efforts, but we need to have our data. And Indian guidelines, I think we had one guidelines around a couple of years ago. It is time to renew those guidelines for our context. So summarizing, I would say risk factors remain the most important first step in assessing a patient with suspected and diagnosed pulmonary embolism. And low molecular weight heparin have been uplifted in their classification. It has been very much well proof beyond doubt they are safe. DOACs in the community setting, patients who are eligible for oral therapy can be utilized. Thrombolysis for hemodynamically unstable patients is also well proven with good literature and recommendations. However, having said all this, proper documentations and counseling is very important to save the patient and save also the doctors and the organizations, because all this treatment has complications, including devastating intracranial hemorrhages or life-threatening bleeds, and almost prevention is better than cure. And DVT prophylaxis is safe. We have seen a gradual rise in the awareness. When I joined my institute way back in 2011, we did an audit, and it was DVT prophylaxis was just 16%. Now it is more than 90%, and our Apollo is actually blazed that way, that all the nursing chart has this provision, I mean, this has the column of screening for DVTs. It was not done, though it was there before also, it was not being done adequately, but now we see it's a compliance of more than 90%, which is a very good achievement. Thank you very much for your patient listening.
Thank you, ma'am,
Any
for your talk.
question?
Any questions from the audience, please?
Ma'am, any update on use of low-dose thrombolytic agent or choice of any between TPA and tenecteplase?
They have not included in this guidelines because, but we know that for safe, altiplase, retiplase both can be used, that no superiority of one over the other. Having said that, streptokinase in India, because from only and only from the cost point of view, that is being used at some of these peripheral places. Only problem with the streptokinase remains is the anaphylaxis and sometimes the side effects, but it's not that clinically significant. So literature, you see, most of the places they mention about this altiplase and retiplase. Streptokinase is probably in the last 10 years literature, you do not see mention of streptokinase. But having said that, it is available and it can be used also.
And experiences with low-dose thrombolysis?
For?
Low-dose thrombolysis with altiplase.
Low dose if you have to thrombolize it, you give the better full dose, because you cannot give a half dose and we expect, because we start suppose systemic anticoagulation, you have to give the full dose in a C1 to E1, the category if I quote these guidelines, give the full dose, because low dose things you do not know, because once the vial is open, see, it is one vial, isn't it? The money is spent, you are not giving half of that money. So if the patients do not have very high risk of bleeding, you probably mean patients who have got higher bleeding risks, like child puke CD or CKD who are on hemodialysis. Those can be, case to case basis one can try, but I do not have experience in that. But having said that, if you ask me to thrombolize a patient, I will give the full dose. Child puke C and D, there are very high risk of bleeding anyway. It's better not to thrombolize them. Only systemic anticoagulations and conservative management would you have to look for. Yeah.
Just one question. Always a confusion whether to send prothrombotic markers or not.
Yes, I think one of the cases, I think it was discussed, it is always prudent to send prothrombotic markers. Patients who have no other risk factors for developing DVTs on PE, if they develop it, it is better to give, because classically if you give heparin to these patients before sending these markers, subsequently they say all these markers, like all these typical markers, factors 5, 7, 12, 13, etc., and protein C and S, they do not come positive, you not get the true values, and you miss the train actually on that way. It is better to send, but it depends on the emergency hours. Somebody comes to the emergency department. The junior doctors are not expected to have that, that kind of knowledge. It would be on the advice of the senior admitting physician or surgeon who should do this. But it is always advisable to send that.
Most of the time, we are on that part of not sending it at the right time.
Yes, yes. I think the hematologists do it on OPD basis. But if it comes to the emergency department and intensive care unit on the first go, they would have already received something, or then you cannot send it. It is not informative on that case.
What is the efficacy of
Tenecteplase and altiplase, both can be used. Yeah. These are the agents which are approved. They are not proven superiority. If you look at the cardiology literature in terms of cardiac thrombolysis and all, they would have some numerous studies are there. But in cases, if you summarize those studies, both can be used. Now it comes to the cost and the convenience. It comes in one ampule, just draw it 1 + 1 hour, you just give it. Because nursing...
The dose is the same like what is thrombolized for the cardiac treatments? The dosage for the tenecteplase is the same like cardiac thrombolysis?
Yes, more or less. I do not exactly remember the dose. You can confirm that, but more or less it is same. I cannot exactly remember the doses actually.
Same dosage.
Same doses. It is same dose, and it's very convenient compared to streptokinase, which you asked. It is very convenient because ultimately, who gives is the nursing staff. You have to have protocol, and this is a serious drug. There's bleeding, etc. The cautions have to be taken, so it makes very convenient actually.
Things are very clear in terms of if it is a massive pulmonary embolism, but things comes to submassive pulmonary embolism, whether the
Yeah, that's a good question. That is why it is said that when you're in dilemma, always start for the systemic anticoagulation. You have a high probability of, this is probably, most of the illnesses, radiologists and critical care, we do not talk about probability. But this is one diagnosis where it comes, always we talk about probability because it's a diagnosis of exclusion. So that's why this, as a risk factor assessment, this years criteria, which I like that it gives you very important and quick clue that what is the probability of having a pulmonary embolism. Now, it's a first case. Actually, it is definitely a very high risk of developing PE. So, we started systemic anticoagulation. Thrombolysis, of course, we are not proven that CTP has not been done, and cost, etc., other things were there. So, we bought time to do this CTP and go for thrombolysis. In subacute pulmonary embolism, as you say, you can start again systemic anticoagulations. You can send your biomarkers. You can do a quick echo at the bedside just to see. It's not again diagnostic or refute, or as they rightly say. You can look at the RA-RV diameters and diastolic pressures and their PA pressures quickly. And when you have time, because subacute PEs will not be requiring organ support immediately. They may not be, very likely that they will not require intubations immediately. So those patients can be quickly healed for doing a CTPA. Do your CTPA, look for the thrombus, and if there is a thrombus in the MPA, the main pulmonary arteries, bigger pulmonary arteries, then with the evidence go for thrombolysis. So it's not difficult. Actually, subacute PE gives you time. All this, things that we talk about gives you time. Only the dilemma and the, challenge is the D and E, where you have a patient is collapsing. And I remember in 2010, when in St. George Hospital, a pregnant lady, she had delivered on the 4 or 5 a.m. in the morning. She was going to the bathroom, she just collapsed. And she didn't have any other prenatal complications, nothing. She just collapsed on CPR. Then we had to take a decision about thrombolysis. And those days, without that thing, giving thrombolysis to a lady, pregnant lady, she was delivered. It was a difficult challenge. But nowadays, the good side of this guidelines is it gives you some background, some backup and decision making. Of course, there could be pros and cons of this. And that's why I believe whatever said and done, they are not guidelines. You decide, talk to the patients, document and go for your things. Because these Indian scenarios, especially as we see where we stand, cost and implications would matter. You might have done with the best of wisdom and best of purposes, but nevertheless something happens on the other side, you're to the person who is in trouble.
Just one last, some comments. There are a lot of patients, elderly, common fractures who are on dual antiplatelets. We do give them DVT prophylaxis. Dual antiplatelets are withheld during surgery. And post-op on discharge, do you have any comments whether to use dual antiplatelets with oral anticoagulation? Because they're going to be bedbound for a couple of weeks.
Which kind of surgery?
Suppose hip surgeries or femur surgeries.
This is again a good question, because there has been good amount of literature in orthopedic surgeries, mostly the hip and the knee surgeries, where they have only using aspirins. This studies is mostly from Australia. There's a large number of patients, around 700 patients, Dr. Ken et al. Actually, I have worked with him also in Australia. My husband was doing a fellowship with their team. So they have published that paper, and they discharge these patients on aspirin only. So of course, if the patient is on dual antiplatelets, I would say that would suffice more than not.
Don't need any oral anticoagulation?
No. During immediate, if they're starting, they're usually antiplatelets, they are not very keen to start within the first 3 to 5 days.
Correct.
But at discharge, yes, definitely, it can be started. First, maybe 3 to 5 days, you can start low molecular heparin, and once the patient is ready for discharge, they would have resumed their physiotherapy, mobilization, etc. Then again, this antiplatelet would suffice.
Thank you so much. Any other?
Full dose. That's what they recommended actually, because there are some papers I was looking at why they chose this 5 versus 10 milligram. Some places, as somebody asked, have low dose thrombolysis. There is no such data. So better to go for that. And you were anyway giving a very focused, directed thrombolysis. So it's not going to have whatever you're fearing of, you're not doing that. So directed mein hai, so you can give the full dose. Thank you very much for your patient listening. I'll take this now.
Thank you, Dr. Sharmili Sinha. That was a wonderful talk. So as a token of appreciation, we would like to honor our speaker and panelist with the memento. And to felicitate our guest, I would like to call Dr. Om Prakash on the stage.
सर ये डिक्रीज कर सकते हैं? हाँ मैम
Yeah, so our next talk will be ICMO, when to consider and when to avoid. And our speaker for this talk will be Dr. Rajesh, and the panelist will be Dr. Pankaj Birud and Dr. Nikhil Varge. Please come on the stage.
So, good afternoon all. I would like to thank Dr. Ashay and Dr. Mahendra and then team Apollo Navi Mumbai for giving me this opportunity. And this is my first visit to Apollo Navi Mumbai. So I was given to talk on ECMO, when to consider and when to avoid. Its title is pretty much opt because we know ECMO involves a lot of finances, and of course we keep the patient at risk of bigger invasive procedures, so definitely we should consider when to avoid. And of course, indication of ECMO doesn't mean that ECMO is beneficial. And if it is suffice the both reasons, then we should initiate on ECMO. And disclosures, I'm an adult intensivist because it's topic of ECMO. I'm not related to any pediatric ECMOs. There's no conflicts of interest, and I'll limit myself only to the simple ECMO. I'm not going to talk about any hybrid ECMOs. So before to start, I would like everyone to remember Prof. Bob Bartlett, who's the father of modern ECMO, and then he last year he actually he died, and then in his lifespan he's saved more than 1 lakh patients with his supports to ECMO, and then he changed the complete management of modern ECMO. And this is the first case of reported ECMO usage in patients way back in 1971-72, where ECMO was initially initiated for a young male patient after a road traffic accident, where they have used for some trauma-related ARDS syndrome, which they used to call it as shock lung at that point of time. And then if you can see, they've used a big oxygenator, which is the silicone oxygenator, which is known as the Bramson's lung. And then patient was on ECMO for 3 days, and finally he survived. So this is the first reported case of ECMO usage, and of course, it's a positive outcome. And from there, this is where we are. This is the ELSO registry, especially for SWAC ELSO region, where India is also part of SWAC ELSO. So for the last 5 years, there's been around 4,500 cases. In case of adult pulmonary ECMOs, the outcome is as good as 42%, and cardiac ECMO somewhere around 45 to 50%. And in case of ECPR, it is somewhere around 24%. So overall, the chances are, I would say, flip of a coin. So that's why you need to be pretty much clear in terms of choosing your patients wisely. So this is going to be the outline of my talk. I'm going to talk about what are the rationale for considering extracorporeal life supports,
and ECMO indications for adult respiratory failure, ECMO for adult cardiac failure, and some discussion about indications in case of ECPR. And because I've recently attended ELSOCON and then knowledge from ELSOCON 2.0, so ECMO beyond conventions, where I'll discuss somewhere about some special circumstances like pregnancy, trauma, septic shock, and in case of poisoning. So we all know the general principle of ECLS is it's a bridge therapy. It's a temporary cardiac or respiratory or both support. So it acts as a bridge to recovery or bridge to some kind of destination therapy or bridge to a cardiac or lung transplant or bridge to decision making, especially when you are in doubt. And of course, the recent updated bridge is bridge to organ retrieval. This is something known as EISOR, extracorporeal interval support for organ retrieval. So basically, this is the basic principles of ECLS. So where exactly you will consider, especially being in intensivist, is when you anticipate high risk of death despite of conventional management, and of course you need to identify potentially reversible pathology, especially cardiac or respiratory, and of course there are other bridges to using ECMO. And you should not have any absolute contraindications. So the absolute contraindications differ from respiratory ECMO to cardiac ECMO. So these are the basic principles guided by ELSO, where you should think about putting the patient on ECMO. So to start with ECMO for adult respiratory failure, what are the exact indications? Basically, we come from 3 major studies. Starting from 2009 to 2018. The first is from the ECMO observational study, then followed by the CESAR trial, and then followed by the recent updated EOLA trial. So in case of an initial knowledge about using ECMO, when it came in 2009 H1N1 pandemic, so Angix have come up their observational. So this is the first reported usage of ECMO during H1N1 pandemic, where they've used in among 68 patients. And apart from this ECMO usage, they have total used mechanical ventilation in somewhere around 133 patients. What they observed among these 68 patients is 14 patients were died. So the mortality was somewhere around 21%. And at the time of publication of this observational study, there are good number of patients, around 6 patients are still requiring ECMO. When you look at the indications where exactly they used ECMO in case of respiratory failure is somewhere around the PF ratios 50 to 60, and when you are requiring relatively higher PEEP, and then when you are having something called as acute lung injury score beyond 3.5. So that acute lung injury score is nothing but the Murray score. So when you are actually in those higher ventilator requirements and significant lung damage, they've used VV ECMO and seen good number of outcomes. And one thing which actually makes this observational study a bit different from what we do of late is usage of prone positioning ventilation. In case of ECMO observational study, usage of prone position was very less, it's around 10%. We know because the ProSiva trial, the landmark trial, which came in 2013, of late we started using prone ventilation like excessively or more than it is required. So I think that's why they've gone for an relatively an early ECMO compared to what we use currently. And later on came up the CESAR trial, which came in 2009. Again, they've used in adult patients. This is for all reversible respiratory failure indications, be it is an H1N1, be it is an bacterial pneumonia or any other viral pneumonia. They've used when the Murray score was 3 or more, and when the patient is having uncompensated hypercapnia with pH of less than 7.2 despite of optimal conventional mechanical ventilation. So the key word here is the reversibility and the Murray score. So the reversibility has been assessed by 3 independent clinicians, and based on which they've included the patients into the trial. So this is the Murray score, where we have 4 components, and then each component ranges from 0 to 4, and average of these 4 components will give you the Murray score. So if the Murray score is 3 and beyond, it becomes an indication as per this study. And of course, they have a good number of exclusions, especially when you are using ECMO as late, that is beyond 1 week of mechanical ventilation, and other contraindications for using anticoagulation. What they found is the survival benefit at the end of 6 months is significantly benefit with 63% versus 47% for ECMO versus conventional treatment. So this has become like, the treatment for ARDS, especially when you have high Murray score. But Caesar trial has its own limitations, and following which to update the knowledge and then to look at the benefits of ECMO, people have started globally with this EOLA trial, which was published in 2018, where they have a stringent criteria with the PF ratio. So PF ratio of less than 50 for 3 hours, or PF ratio of less than 80 for more than 6 hours, and with an respiratory acidosis with pH of 7.25 despite of your ventilator optimization. So they've classically defined what exactly they mean by ventilator optimization, and they have also good exclusion criteria. And what they found was there is no major benefit with ECMO, and of course most of the ECMO physicians, including me, won't agree with this author's conclusions. But if you look at the further Bayesian analysis and all, ECMO is going to be definitely beneficial as per the criteria used by EOLA trial. After all these 3 observational studies and then 2 randomized clinical trials, then what ELSO has recommended, this is the recent recommendations from ELSO. So ECMO is indicated when the mortality risk is more than 80%. So what exactly they mean by it is, when the PF ratio is less than 80 with FA vote of more than 90% or Murray score of 3 to 4, it becomes an indication for using a respiratory ECMO, which is VV ECMO. And you should consider ECMO if the mortality rate is more than 50%, which is somewhere around PF ratio of less than 150 with FaO2 requiring more than 90% and with a Murray score of 2 to 3. So these are the available recommendations, and of course came up guidelines from expert opinions where everyone has suggested considering VV ECMO when the PF ratio is less than 80. And of course, ESICM has come up with the ARDS guidelines where they agreed with EOLA criteria, and then based on the criteria, we should think about initiating veno-venous ECMO. So we know there are good number of indications, that's fine, but of course we need to look at the benefits. So to look at the benefits and survival predictability, there are good number of scores available for VV ECMO. These are the 4 scores available. So the initial came up score is an ECMO net score, which was studied in H1N1 pandemic time, which actually identifies the incidence of multi-organ failure at the time of initiation of ECMO. And if you have high cutoff, which is 4.5, and it shows high mortality, and then you should rethink and think more when you are thinking in terms of ECMO, especially when the MODS incidence has been high. Following which, this is the RESP score, which has been recommended by ELSO. So before thinking about initiating VV ECMO, you should calculate the RESP score and then identify where exactly your patient is sitting and initiate the ECMO. So this RESP score is decided based on the ELSO data from 2000 to 2012, and we know there are online calculators available which can help you predict the survival probability once you initiate the patient on VV ECMO. So among all these scores, the internal area under receiver operator curve is reasonably stable. Among those 4 scores, RESP score is relatively less, but that's being recommended by ELSO, thinking in terms of whether your ECMO is going to be beneficial for respiratory failure or not. So in terms of adult respiratory failure, the indications are pretty much clear. So ELSA has given the PF ratios of less than 80 with Murray score of 3 to 4. And then the most widely accepted criteria for initiating respiratory ECMO is based on the EOLA criteria. So this is what globally people follow for initiation of respiratory ECMO, which is an adult VV ECMO. And then the contraindications are different. One of the major contraindications is if you are unable to get an axis and if you are unable to use anticoagulation. Apart from that, rest of the indications becomes relative contraindications. But it all depends on how well your RESP score is going to come. Coming towards cardiac failure, I'm going to discuss more about acute MI with cardiogenic shock. Less discussion about destination therapy or in case of an acute decompensated heart failures. So in case of acute MI with cardiogenic shock, also has given recommendations. There are different societies differently given their recommendations when to initiate cardiac ECMO, which is a VE ECMO, but of course the gist is being the same. When you have an systolic blood pressure of less than 90 and then cardiac index of less than 2 with an elevated pulmonary capillary wedge pressure, and then the most important thing is evidence of end organ hypoperfusion. It's not about hypotension, it's about hypoperfusion, which is leading to multi-organ failure despite of aggressive pharmacological interventions. So what do you mean by organ hypoperfusion? When the patient is having oliguria, elevated lactates, and your vasoactive inotropic score is beyond 20. So vasoactive inotropic score, we know there are scores for different vasoactive agents. Based on the calculations, if the score is more than 20, it becomes an indication for using cardiac ECMO, which is a VE ECMO. And American College of Cardiology, mostly it is same as ELSA recommendation. Apart from that, a bit twist in the language where patient needs to be on at least 2 vasopressors or inotropes, with or without IABP, in those scenarios where pharmacological treatment is unlikely to improve outcomes. Following AECC recommendations, and this is the most commonly accepted and used criteria by all the ECMO physicians for cardiac ECMO, which is the SCAI staging. SCAI is the Society of Cardiovascular Angiography and Interventions. So where the cardiogenic shock is given from grade of A to E. A is at-risk patients, B is beginning of cardiogenic shock, C is the classic cardiogenic shock, D is a deteriorating patient despite of your treatment, and E is an extreme group of patients. But most of the studies in case of ECMO with cardiogenic shock, they have included patients at the late, which is class D or class E, or an early patients, which is at the level of B. So that's why if you look at the evidence for VA ECMO in cardiogenic shock, we don't get any positive evidence. So whether the studies have included either an extreme group of patients which lie both on the edges of the thing, but they have never included a classic patient. So the classic indication becomes in class C SCAI patient deteriorating to class D. So how to identify that patients is given by SCAI cardiogenic shock working group, where cardiogenic SCAI CE, which is nothing but patient is having features of hypoperfusion plus shock, which is same you can identify based on your lactate, based on your AST. If the lactate is between 2 to 5, he becomes a SCAI CE. And then if the AST is between 200 to 500, he becomes a SCAI C, where not a very classical indication to start VA ECMO, but at the same time, if the patient goes to SCAI D, where the lactates are beyond 5 to 10, and if the AST is beyond 500, he becomes a SCAI D, where you may not be able to get benefit if you initiate VA ECMO. So your typical patient is a SCAI C patient who's kind of deteriorating in the next few hours to SCAI D, where you should not wait and you should intervene immediately and then start the patient on a cardiac ECMO. So identifying that patient is a bit tricky. Why? Because in case of SCAI C, you have a mortality of somewhere around 21.5%. In case of SCAI D, the mortality is somewhere around 54.3%. So that means you're almost like more than doubling the mortality. So identifying a deteriorating SCAI C patient to SCAI D is the right time to initiate cardiac ECMO. And timing is important. When you think the patient is kind of deteriorating, you should be able to initiate an ECMO in less than 6 hours. In case of a deteriorating SCAI C patient, and presence of lactates more than 10, and then the elevated SGPT, which is the AST more than 500, all these things are suggestive of an end organ hypoperfusion, and then initiating ECMO in that scenario may not be that beneficial. So this bit of kind of confusion or identifying an ideal patient for VA ECMO becomes a bit tricky. So in terms of survival prediction on VA ECMO, this is the SAFE score, which is again recommended by ELSO and Alfred hospitals, where actually you can identify, you can predict the mortality before initiating the ECMO. So having a good SAFE score and then identifying and deteriorating SCSI patient becomes your responsibility to initiate VA ECMO. And of course, there are other scoring systems which are not very much recommended. Other thing is something like an encourage score, which is not very well recommended. So that's what I was thinking about, and I was telling about why there is no good evidence for VA ECMO in case of acute MI-related cardiogenic shock. So these are the two major hallmark trials, which is the ECLS shock trial and then ECMO cardiogenic shock trial. So the problem with ECLS shock trial is they included even SCSI-B type of patients and early SCSI patients, where they couldn't identify any kind of mortality benefit if you initiate VA ECMO in case of cardiogenic shock. In case of ECMO CS trial, we included the extreme SCSI-D and E patients exclusively, and of course they were unable to identify any mortality benefit for VA ECMO in case of cardiogenic shock. So it doesn't mean that VA ECMO doesn't work for cardiogenic shock, but identifying your patient it becomes a bit tricky. Apart from acute MI cardiogenic shock, so VA ECMO is an bridge to like refractory ventricular arrhythmias, or a bridge to an acute or chronic decompensated heart failure for transplantation, and of course some destination therapy in terms of durable VADs, and of course when you are in confusion, it helps as a bridge for decision making too. So apart from acute MI, these are all the indications where you should think about putting the patient on VA ECMO, and of course timing is really important. So other indications for ECMO which is coming in a big way is eCPR, extracorporeal cardiopulmonary CPR. When you think about eCPR, when your conventional CPR becomes unsuccessful, and of course eCPR is a time-sensitive complex interventions, you need a good team, and of course like when you attend all the ECMO conferences, they say you should have a good VA ECMO program to think about starting any eCPR program, because you need to have a team who have clearly defined roles, and then of course well-defined healthcare providers, and at least you should be able to provide eCPR starting from emergency to, of course, in cath lab or in the wards. So your first area becomes your emergency, where if you have a good team and then experience with VA ECMO, you can think about starting an eCPR program. And of course, you should take a decision of converting a conventional CPR to eCPR at the end of 10 to 15 minutes of conventional CPR, where the patient is not attaining ROSC. And the recent ACC-AHA guidelines on CPR, they've not given a great recommendation, but of course you should think about, and then the world is moving towards eCPR, especially when your conventional CPR is failing. And where exactly you should think about eCPR, recommendations given by ELSO, relatively younger patients with age less than 70 years, and it has to be a witnessed arrest, and then the arrest to bystander CPR, which is called as the no flow interval time, should be less than 5 minutes. And then initial rhythm has to be a ventricular fibrillation or pulseless VT or a PEA. You should not go for eCPR for an asystole. And arrest to initiation of ECMO flow should be less than 60 minutes, which is known as low flow interval, because if this low flow interval is more, then your neurological outcome is not going to be good. And you should have a good quality conventional CPR, which is guided by your ETCO2 of more than 10. And if the patient had signs of intermittent ROSC or recurrent VF, which means your CPR is being good, your conventional CPR is good, and then you can go for an eCPR. Or if the patients are having in between any signs of life and absence of any previously known life-limiting comorbidities, and absence of any major aortic valve incompetence. So all these becomes an initial guiding criteria where if you want to start an eCPR program in your hospital. So time is really important in case of eCPR. So the first time is time to initiation of conventional CPR, which is called as no flow time, which has to be less than 5 minutes. And the decision to go on to eCPR or ECMO should start at the end of 10 to 15 minutes. and then by the end of 1 hour from the time of cardiac arrest, you need to be on ECMO so that you can avoid pretty much longer low flow time. So time sensitive intervention is eCPR, so there is definitive criteria and definitive guidelines are given. And if you deviate from these kind of guidelines, your outcomes are not going to be good. So that becomes ECMO in case of eCPR is not going to be beneficial. In case of some beyond conventional indications, so ECMO in pregnancy, like we have varied lung conditions and cardiac conditions where ECMO is recommended, and there are some special respiratory pathologies like trolley eclampsia and exacerbation of asthma for VV ECMO, and of course we have amniotic fluid embolism and then peripartum cardiomyopathy for cardiac ECMO in case of pregnancy. So in case of both cardiac indications and then respiratory indications, there are no major deviations. We can use the same criteria where we are using for an adult respiratory failure criteria for initiating VV ECMO in case of pregnancy. But one of the biggest issues will be you may not be able to do prone ventilation in case of elderly, third semester gravida. So in those situations, your indications for ECMO becomes relatively kind of low thresholds compared to a conventional patient. And there are no major differences in terms of managing these patients, pregnant patients on ECMO, especially for respiratory ECMO, apart from maintaining relatively higher flows and higher PO2s. And then you need to adjust your anticoagulation, which doesn't cross the placenta barrier, and you should have relatively higher threshold for hemoglobin and other signs of infections. There are some observational studies which are available, and they have shown relatively lower threshold to initiate VV ECMO, especially in case of respiratory acidosis. So if you are reaching an ETCO2 or PaCO2 of more than 50, you need to go on to ECMO, especially if a patient is in third trimester gravida pregnant patient. For septic shock, we know ECMO is for cardiac failure, we know ECMO is for respiratory failure. Of course, ECMO is not for capillaries, which are the problem in case of septic shock, but off-label, after the systematic review and meta-analysis by Ramanathan and al., where they have included VA ECMO for septic shock, included around 14 studies, around 500 patients. What they have identified is if patients with septic shock were associated with some septic cardiomyopathy with LV ejection fraction of less than 20%. In those patients, if you are initiating VA ECMO for septic shock, your outcomes are really good. Otherwise, the outcomes are less than 30%. So again, the same forest plot where if the EF is less than 20%, the forest plot is showing the survival benefit. But if patient is having moderate to normal LV where EF is more than 35%, VA ECMO is not going to be beneficial in case of septic shock. Rest of the criteria is being the same. Only thing is if the patient is having severe LV dysfunction in case of septic shock, VA ECMO is going to be beneficial. So this is the diagnostic algorithm where you need to identify the ventricular dysfunction. And of course, if the ventricular dysfunction is bilateral or unilateral. So bilateral means both LV and RV failed. With LV EF of less than 20%, of course, there is definite role for VA ECMO. But in case of isolated right ventricular dysfunction, you can manage hemodynamics. If you can able to manage hemodynamics and optimizing the ventilation, and then if you can reverse the respiratory acidosis, if that is the reason for RV failure, you can get away without initiating ECMO. But if the patient is still deteriorating with moderate to severe RV dysfunction, then you should consider about VV ECMO. And if the patient is still not improving in terms of shock, then you can convert it to VAV ECMO. So this is the diagnostic algorithm in case of septic shock. In case of trauma, again, this is one more beyond conventions indications. There are again indications for VA and VV. So VV is for more of an respiratory trauma where you have tracheobronchial disruptions or big lung contusions, or patients who requiring some kind of pneumonectomy or receiving massive transfusions and went into ARDS. In case of VA ECMO, it's the patients with refractory hypotension with possible traumatic cardiac arrest. The problem with initiating VA or any kind of ECMO in trauma is access might be difficult because there might be trauma and you may not be able to cannulate percutaneously, and you might need people help. And because trauma, there will be amount of blood loss, you may not be able to initiate the flows. All these things are with logistics, but not with indications. If you have elderly male patient with severe thoracic trauma and massive transfusion with baseline coagulant dysfunction, these are the predictors of mortality in case of initiating ECMO in case of trauma. So these 4 or 5 are the big no's for initiating ECMO in case of trauma, where you have an severely uncontrolled active bleeding with intractable intracranial hemorrhage, or patients with ICP of less than 20, or major abdominal and thoracic hemorrhage which is not amicable for surgical control, or patients who is actively bleeding at a rate of 1 liter per hour. And of course, if patient is at more risk of bleeding than thrombosis, in those scenarios where you should not think about initiating ECMO, because these are the high predictors for mortality and ECMO is not going to be beneficial. In case of head injury, it is bit of an edge because as we know, head injury with ARDS, permissive hypercapnia is not an option. But at the same time, TBI has itself, when you start with anticoagulation on ECMO, there's a risk of expansion of hematoma and expansion of ICP, increase in the ICP. So it becomes a tricky decision again. To conclude, in case of head injury TBI, ECMO is not an absolute contraindication, so you need to weigh the balance and see where exactly you are. You are worried with more of permissive hypercapnia versus risk of expansion of hematoma. And of course, now people are talking about and using without anticoagulation ECMO or heparin-free ECMO. Those things, especially when you are maintaining high flows, can be managed for a couple of days until your bleed gets stabilized. In case of ECMO in hypothermia, because we recently had this Everest Kumbh issue where the glacier has fallen and there's a lot of hypothermic patients. So ECMO is indicated especially when you encounter any hypothermic patients. So there are specific indications for initiating ECMO in case of hypothermic patients where the core temperature is less than 30 with significant hemodynamic instability and ventricular arrhythmias. Or if the patient had an hypothermic cardiac arrest, you need to prognosticate based on the HOPE score. If the HOPE score possibility of survival is more than 10%, then only you should think about initiating ECMO, especially VA ECMO, in hypothermic cardiac arrest patients. So there are definitive indications and contraindications given for initiating ECMO in case of hypothermia. In case of poisoning, because we see a lot of, because ours is in kind of industrial area, we see a lot of poisonings, and of course there are pharmacological agents like beta blockers, CCBs, anti-epileptics, antidepressants. Poisoning require cardiorespiratory support, especially when the conventional measures fail, and some recreational agents. And there's good amount of data about aluminum and zinc phosphide from Ludhiana around Punjab area where VA ECMO has been extensively used. And we've seen some cases of carbon monoxide and cyanide toxicity which are requiring ECMO support. So in case of any acute severe poisoning, once your conventional measures fail and there might be a thought about starting an antidote, you should think about initiating VA ECMO. So in case of patients who are severely intoxicated with an indication of VA ECMO, who had an cardiac arrest or refractory cardiac failure, you should initiate VA ECMO, where this VA ECMO can be used as bridge to recovery or bridge to getting your antidote or bridge to continuation of renal replacement therapy, which is kind of clears your drug. And as a bridge to transplant, suppose in case of poisonings where you will have a severe lung fibrosis like paraquat. But if the poisoning is causing severe refractory vasodilatory shock, in those scenarios, ECMO is definitely not indicated. So I would conclude by saying that in case of respiratory ECMO, the indications and then benefits are very clear. Based on the ELO criteria is the indication, and you should look at the benefits based on the RESP score. In case of VA ECMO for acute MI and cardiac failure, you should identify a SCAI C2 deteriorating SCAI D patient, and then SAFE score will be your scoring, which will give you whether the ECMO is going to be beneficial. And of course, beyond convention, once you start using for conventional indications, I think you will become more expertise. What makes your ECMO is successful is time to initiate. If you are delaying the initiation of ECMO, then the outcomes are not as good as we expect. Thank you.
Thank you, Dr. Rajesh, for your detailed deliberation on these complex topics of ECMO. I think it's a modality of future, and I think Apollo Hospital Navi Mumbai is one of the pioneering institutes that has brought this facility in Navi Mumbai city. So if the audience has any questions.
Yes.
About the feasibility indices of that, what do you think about the timelines? Because the compression and this cycle speed cycling, practically it appears to me, I mean, from a clinician and I'm working in a that phase. What are the global numbers of if you have any data about this?
Ma'am, I mean, ELSO data registry, it will have their data, like, for ECPR. The outcomes are not good. It is somewhere less than 30% if you look at the outcomes. But I think there are few scenarios where I think Charan is also with us. He is an ECMO physician and he's done good number of ECPRs. But especially when you are witnessing a cardiac arrest in case of a cath lab. Okay. And yeah, exactly, ma'am. Like, to reach that. I mean, like in India, like, we are optimistic, maybe somewhere in future we might reach. So that's why, like, if you're thinking about ECPR, they say you should have good VA ECMO program. So if you have done good number of VA ECMOs, then only think about starting an ECPR program, because it becomes too optimistic to start straight away an ECPR program. So I think the area where we need to concentrate is something like an ER and then cath lab, where there might be an cardiac arrest which is happening in front of us, which is a witnessed cardiac arrest. Maybe those two are the initial areas we need to concentrate, and then maybe beyond which you can extend it to the inpatients. Yes, sir. Yes, sir. Agreed. 100%. Oh, thank you, sir. Thanks for asking that question, because so I can share you, there's a bit of big algorithm given. So it was actually an update on Twitter, which I have seen by Ramnathan and Dr. Pranay Oja, who are kind of pioneers for ECMO. So what they're going to do is, if I remember, because 2 days back only I have seen it, because we thought we use something like an EISOR for one of our patients, but the declaration of a brain death becomes a bit tricky, where you need to go on to the full flows and ventilator has to be fully on 100%, and then you need to reduce your flows to something like 1 liter, and then reduce your FAO to on ECMO, and then again look at the gas. So this is a big flow chart. I can share it with you personally and with Dr. Akshay, so that I think we can look at it. This is not kind of recommended for brain death. So EISOR something like where you have already declared the patient's brain death, but patient is kind of deteriorating secondary to some kind of LV dysfunction. So that is different, and declaring a patient for kind of brain death declaration on for organ retrieval is different. Yes, yes. Yes, yes. This thing, like, if you want me, it's in my mobile, I can read. Yeah, we need to reduce your flows and reduce your sweep class and FDO2 on ECMO, and then look at the get gas and look for the movements. Yes, there are steps which are clearly given. Maybe it's more of an institutional basis, but yeah, there are no definitive things. It all depends. Like, we know there are no major recommendations. But when you think about irreversible brain damage, where, like, complete absence brainstem reflexes, maybe that is one point where I would definitely think about, or some financial reasons, or families pressurizing. There are no definitive hard and fast rules.
Thank you, Dr. Rajesh, for such an informative talk. To felicitate our speakers and panelists, I would like to call Dr. Sumant on the stage. Vaishali. So our next talk will be acute ischemic stroke, the current concept. So the speaker will be Dr. Ranjit Unnikrishnan, and the panelist will be Dr. Sumant and Dr. Vaishali Lokhande. So please welcome our speaker and panelist with the big round of applause.
Can I start? A very good afternoon, dear friends. Greetings from Kochi. Kochi is sizzling hot nowadays. Thanks, Akshay and the organizing team for this opportunity. Nice to be here, the Apollo family. Great feeling, actually. So I would be looking at the early management of acute ischemic stroke, and I would be restricting myself to predominantly these guidelines which have come recently in March, which are very elaborate, and my talk is in line with these guidelines. So the major, the shift in paradigm in the recent time is understanding that stroke management is more of a systematic, it's a system-based management rather than an individual management on one side. So actually, the system has to be in place, because if you think time is brain, the system has to be managed. the machinery has to be well oiled and the system has to be in place. That's one understanding, especially in the pre-hospital scenario, as we are pretty lacking in that part in our country. That's one area. And the other thing is, again, understanding that the pre-perfusion therapy has come in a big way. The hands of the interventionist really matters, and to get this machinery, to get optimal results in the persons who could actually benefit from endovascular treatment. So these are the two kind of opposing things which looks contradicting things, but to put them in place is the challenge. So this is the golden pathway. The awareness in the population, the shifting to the hospital, the right place, the place which is actually ready for endovascular treatments. The Western literature, Western guidelines gives us mobile stroke units, etc., which are having portable CTs, which have telemetry, which could liaise with your emergency department. Even in such situations, there are scores which we'll just mention from the EMS could actually do a raise score and think of a person who could probably be having a large vessel occlusion. These patients could be taken straight to the angiography suite without much of delay, DTAs or direct transfer to angiography suites. These are things that have come up in the Western world, which will take time for us, but we'll be probably looking more towards the second end of it, the reperfusion as well as the management in the neurocritical care. So this is the recommendations given by the HASA. Of course, stroke scores are not difficult to be done unless your EMS is aware of it, and notifying your hospital, the emergency department and your cath, as well as your imagology departments about the arrival of a stroke. This could reduce your time and ease your, like if an ASAP, that's something, a protocol that we do in our hospital where the emergency is ready and the imagology is cleared of other things. Such small things actually can improve outcomes. What doesn't work is any heroics on the field, like reducing BP, ischemic reconditioning, where they actually try to give ischemia to the limb or some other place in the belief that the systemic response to distal ischemia could be helpful for ischemia in brain or heart. So that doesn't work as of now. And lowering of BP in the field doesn't work. Not recommended as of now. That may change. As of now, the recommendations are not there. Now, coming to the core thing of our discussion here, that when it comes to reperfusion, we all know that stroke could be divided largely into two areas, which is the core area and the penumbra. The core area, they already started necrosing and they're non-salvageable, and you're going to lose that much tissue. And then the penumbra, which is a salvageable tissue where the perfusion is maintained not just by the artery of culprit artery, but it is maintained by some collaterals also. So the idea would be to reduce the conversion of a penumbra into a core and to salvage the penumbra. So that is the idea. So quite an interesting slide, because we have discussed multiple things like knee CPR not working in our country. The catheter-based therapies not exactly reaching the prime time when it comes to pulmonary embolism. These similar things have happened when you look at the stroke management in the initial part of maybe last 2 decades. But generally what I feel is, if your theory is good, you mean to say that you have to open the vessel, that improves your perfusion. It's only a matter of time to find out the sweet spot. So it's only you did not ask the right questions, or the time has not been ripe. So if you look at the journey of stroke management, you can see that the NINS TPA trial, the landmark trial in 1995, has proven that alteplase in the first 3 hours definitely improves outcome, the functional outcome in acute ischemic stroke. And it was ECAS-3 which has extended the window to 4.5 hours. Sorry. So initial management of stroke largely depends on the quantification of stroke. This is one classical scale, the NIH scale, which is used to quantify stroke. So one of the major problems with this is not a scale to diagnose stroke, especially post-circulation strokes could totally be not represented here. But another drawback here is if you look at suppose a person has a left lower limb weakness, the score just adds to 2. So looking at the eligibility for something like IV thrombolysis, they may not be exactly eligible because they come to a minor stroke criteria. So this actually has led to the concept of clearly disabling stroke. So when you have a low NHS of 0 to 5, there's a clearly disabling symptom, like if it affects your ambulation, eating, your toileting, your daily activity or your ability to return to work, that comes to a clearly disabling stroke, where it is eligible, that's in the recent criteria, it's eligible for the reperfusion, thrombolysis. Like if you have severe aphasia, the score would be 2, but it is clearly disabling, and you could thrombolyze. And one of the earliest thing to do in stroke management is a non-contrast CT or a plain CT. So the fundamental idea is to reduce time to reperfusion. So with the lot of advancements that happens, there are vascular studies, angiograms, CT angiograms, MR with MR angiograms. Even there are perfusion studies which are coming up to find out the salvageable area. But the core remains that if the patient has a classical stroke, especially like an anterior circulation stroke clinically, and your CT is not showing a bleed, the patient has to be thrombolyzed on the spot ASAP, with the use of tenecplase coming up significantly, or alteplase, which requires a push only. It could be done on the bedside. So you don't have to really drip and ship the person on alteplase. You can just push tenecplase. So for that, in a classical scenario, you don't have to have any more imaging. Now, what about the extended window? So we're talking about 4.5 hours. What about somebody, last known well is not clear, or patient wake-up strokes? Here, the extended window, the concept of extended window. So actually, a subset of people, they may not be having, they may be having significant leptomeningeal collaterals. So that could actually be perfusing your penumbra pretty well. So the small core, large penumbra, slow progressors could be a disadvantage if you don't really consider them for the extended window period. So that is a concept that has come up in the last decade. So this is one situation where a diffusion, an MR diffusion image versus a flare image. As you can see in the upper panel, you could see that the diffusion, the hyperintensity in the diffusion is not seen on the flare images. So that generally means this flare versus diffusion doesn't really choose between the core and the penumbra or the salvageable tissue versus the lost tissue. What it looks at is the timing, because diffusion brightens up pretty early and flare takes a decent time. So you could arguably presume that when there's a diffusion flare mismatch, you could be having a stroke onset which is not very old. So it could be something like 4.5 hours. So that is one indication to go ahead with reperfusion therapy or thrombolysis when you don't know the exact timing. Now the other concept is perfusion mismatches. So we already mentioned there's a core which has been lost, and there's a penumbra, and there is a oligemic periphery. So how do you differentiate between these things? So we already know that the diffusion, this is a simplistic presentation. This is a very complex thing, perfusion studies. What I thought is simple, I just putting across. So when you have a diffusion restriction, that area is lost. That is actually a core of the stroke. So if you can actually do a perfusion study by giving contrast, like in CT angiogram as well as an MR angiogram, and do perfusion-based studies, we could find out areas with low cerebral blood flow, cerebral blood volume, as well as the transit times across that areas, and they can be colorimetrically depicted. So when you see that the transit time is more than 6 seconds in a large area, like in that picture, you can see the diffusion versus the perfusion. If you subtract that, if that area is pretty large, so that is salvageable area. If that area is significant at any point of time, to a reasonable time, they could still be, reperfused. That is hot concept of perfusion imaging. There are two trials, extend and wake up. See, these are the two trials which have proven that extended window thrombolysis is feasible. The wake up trial used the diffusion versus flare mismatch, whereas the extend trial used the perfusion mismatches. So both of them actually gave the impetus to go ahead with the extended windows. So as of now, extended window could be used till maybe from the midpoint of a sleep to 9 hours or even 9 hours post last known well to be thrombolized. If you could prove that, if you have an automated perfusion techniques in your imaging, which should be there in most of the centers, and you prove that the salvage tissue is significant, you could go ahead and reperfuse or thrombolize. If you have a patient coming even later than 9 hours, till 24 hours, and the center doesn't have an EVT, endovascular facility, it won't be a bad idea if you can prove that with perfusion trials. If you have a large volume center who does a lot of thrombolysis, you could still think of going and doing a thrombolysis on a case-by-case basis, even till 24 hours. There is a recommendation there in the ASA guideline. Now, what about tenecteplase versus alteplase? You all know alteplase has been the classical drug, even for pulmonary embolism. So there has been a change because the pharmacokinetics of tenecteplase is pretty favorable. You can push it. It is more clot specific also. So there are significant number of trials in this area that this can be used for large vessel occlusions, even non-large vessel occlusions, in the classical 4.5 hours, as well as the late window, so that now the go-to drug for thrombolysis should be tenecteplase. I'm not saying the recommendation, that is the practical thing. So 0.25 milligram per kilogram, IV push has to be given. If that is how tenecteplase is. And in general, brain is a different beast. So whenever you use multiple antithrombotics, antiplatelets, antifibrinolytics, you have to be extremely careful about a stroke brain, which is extremely sensitive to bleeding. It could just bleed. So usually when you use fibrinolytics is used, thrombolytics is used, addition of antiplatelets immediately. Antiplatelets is a bit controversial because there is some, suppose you have another reason to use antiplatelet, you could use, but using other, I'm talking about routine antiplatelets. IV antiplatelets as well as antithrombotics are generally not used because the harm is significant, bleed harm. Now coming to the endovascular thrombectomies or endovascular therapies, the classical window from, there are multiple studies, as I was mentioning, we've seen the journey of endovascular therapy coming, just like what you're seeing in ECMO and other things which evolved and it's trying to get its place. So now it's a very standardized treatment modality. So these are the few trials that has really changed the scenario for endovascular therapy, especially its 5' trial, the stent retrievers. Again, this all depends on technology too. When stent retrievers are used significantly, the results became much better. And I think overall care improved, overall technique improved. Maybe all these things have put it into the prime space. So obviously it is currently recommended only for large vessel occlusions, which practically means that either it has been internal carotid or M1 MCA or a basilar artery occlusion. That is a classical thing. Going a bit into the middle vessel and distal in the middle vessel is an excretion of the operate, generally not in the larger recommendations. One of the ways of selecting a person for endovascular therapy is the aspect score, the Alberta stroke scale. This is like there's a classical one is described for the anterior strokes, the MCA areas. You can see that there are 10 areas that are mentioned at the gangliar level as well as the coronaradiatal level, and it adds up to 10, the areas. So the number of areas which have hypodensities in them are added up and then subtracted from 10. which means that the score of 10 aspect is meaning there's no stroke, no obvious hypodensity, not no stroke, no obvious hypodensity on the plain CT, and something like 1 or 2 means it's extensive hypodensities in multiple areas, and that could be, but hypodensities come into the areas of interest. If there's a clinical stroke of a left MC and the left MC areas are showing multiple hypodensity areas, that probably should be taken as core. The hypodensities on CT is probably lost areas. So when you have a stroke aspect score of less than 5, probably you're looking at a large core, and your potential of salvage comes down significantly. The similar thing has been put forth for the posterior circulation also, with more weightage to the brainstem areas, that is the midbrain and the pons. So again, this adds up to 10, and basically aspect score is done on a CT, on a plain CT, and you can decide on endovascular thrombectomy based on a plain CT, based on the aspect score, without going into the perfusion studies or angiograms. That is a recommendation, but probably that's not practically done, because many places the angiograms are done at that point of time along the CT angiogram is also done, and so that the decision of a large vessel occlusion becomes much more easier. So these trials, definitely what we know is anterior circulation, large vessel occlusion within the first 6 hours, the paradigm has shifted from just intravenous thrombolysis to intravenous thrombolysis plus endovascular thrombectomy. So the continuation of intravenous thrombolysis to endovascular thrombectomy has been well defined now. The patients who have already been thrombolized are pretty good eligible candidates for thrombectomy. Now, what about the late window? So we're talking about 6 hours of the thrombectomy period, the classical period. So DAWN and DIFFUSE 3, these are 2 trials which have actually pushed the boundaries a bit. And the DAWN trial looked at clinical core mismatch. So they did perfusion studies to find out the core volume, as well as they looked at the NIH score. So if somebody had a large NIH score, means clinically bad stroke, with a large small core, they could probably go in for a thrombectomy. And DIFFUSE looked at a perfusion mismatch. So both of these trials has proven the benefit of extending the window of thrombectomy till 24 hours. So till 24 hours, if you can prove that there is salvageable tissue, you could still extend. Same thing as we mentioned in the thrombolysis. So basically, reperfusion has now shifted from the classical window to an extended window, and is generally acceptable if you could prove that there is salvageable tissue. Now, what about large cores? We are talking about small cores with large penumbra. Suppose you have a large core. We have been talking about the salvageable tissue being less, but there are trials which are coming up in the last couple of years where large core strokes have been reperfused with reduced disability, like modified Ranskin score at 3 months or 6 months, being significantly functional improvement has been shown. So this is another area of interest where a large core has been large core strokes have been subjected to reperfusion. The only problem is when you open up such a large core stroke with any of these techniques, the reperfusion injury is going to be big, and we'll have a tough time managing such patients post the intervention, because the complications will be pretty higher. What about posterior circulation stroke? Here there is now no doubt about there's no ambiguity there. The significant high NIH score more than 10. In first 24 hours, basilar artery occlusion is there, or a posterior circulation stroke is seen. These patients have to, an aspect score of more than 6. These patients have to be taken up for reperfusion therapy, because their functional outcomes are significantly better when you go for reperfusion. So this is a very strong recommendation, because the effect of posterior circulation stroke is catastrophic, and the functional improvement can be significant. These are the trials in GIST. So generally, this we already mentioned, the normals, the baseline large vessel occlusion, even for a large core as well as the basilar artery, till 24 hours, in the right patients, you could go for reperfusion. So what about the other things like blood pressure? How do we go about that? So we know that generally strokes have a hypertensive response, the sympathetic response, The concern is if you reduce that, will the penumbra suffer? Will it get, they get more hypoxic and this core will increase in size, or there will be hemorrhage into the stroke areas? So there are trials like Enchanted, which has used tried less than 140 versus less than 180 systolic blood pressure post intravenous thrombolysis. And there are trials like BP target and optimal BP in post EVT patients. The endovascular, both these trials could not actually show benefit when the systolic BP was reduced significantly, or it was reduced to normal numbers like less than 140. There was potential harm in both these trials. So basically, if there is no intervention planned, not very sure that hypertension has to be treated at all. Having said that, we don't know, suppose it's a significantly high blood pressure, whether that has to be brought down. In that situation, maybe we could use titrable drugs with monitoring and maybe 10-15% reduction in the first 24 hours, something like that, which are all anybody's guess. There is no standard recommendations. Other things like there are standard recommendations for pre-thrombolysis and post-thrombolysis, something like 180, 100, and post-EVT, again, reduce it less than 180, maybe 140 to 180 systolic BP. So the idea is to maintain perfusion. Suppose you have a CT angiogram with a very tight stenosis, and you think that post-stenosis, the stroke area, the autoregulation may be lost. Maybe you may have to augment the BP, because after the initial surge in BP, the BP hypertension may be lost. So such things like increasing the mean arterial pressure or systolic blood pressure with medications, and then targeting a higher augmented BP for improved perfusion, because we see that some of these patients, they real time they deteriorate when the BP falls. So they are kind of managed on an individual basis also. So glucose control, again, these are very similar things. Extremes has to be avoided. So the BP targets, especially SHINE trial that has come a couple of years back, which has targeted a tight control. Of course, tight control is not recommended in any areas nowadays. So the target is to maintain between 140 and 180. Again, even to summarize these two things, the BP target and the sugar targets are kept in the near normal range. The extremes are avoided. Very tight control is avoided. That doesn't mean that you don't have to look at both these things, because both these things are very well known to damage and implicate the outcomes of stroke. Even with the TICI 3 flow, that's excellent flow after reperfusion, evidence is lacking that tight BP control to reduce reperfusion rebleeds are not there. So even in such reperfused brains also, the BP targets are to be less tighter. About antiplatelets, there is ample evidence that aspirin in the first 48 hours reduces death as well as dependency in acute ischemic stroke. In minor strokes and TIAs, there is a case and there is evidence to use dual antiplatelets. The chance and point, the two trials it's shown that aspirin plus clopidogrel post-loading dose is what is recommended for the initial part. Extending them to more than 21 days, on some studies like 30 days, is not beneficial, and then probably that we'll have to continue with a single antiplatelet. Now, if you look at ticagrelor versus aspirin as a single drug, studies have been conducted. There is no real advantage of ticagrelor over aspirin. And ticagrelor plus aspirin as a dual antiplatelet versus clopidogrel and aspirin has also been trialed. There are, especially in tight stenosis and large vessel atherosclerosis, there are some advantages, but at the risk of increased bleeding. When atrial fibrillation and stroke, the idea is to anticoagulate, it is not to use antiplatelets. And adding antiplatelets in such a situation to the existing anticoagulation doesn't improve outcomes, may worsen, may harm. So it's not recommended. When you have a vertebral artery or sublunar artery dissection, there's another scenario where you're really worried about it's a taking time more with a stroke. So these studies have looked at anticoagulation versus antiplatelets. And as of now, there is no difference in the outcome between these two interventions, and either of these things can be used as per the recommendations and as per the individual's discretion. And again, anticoagulation, full anticoagulation is generally not indicated in stroke because and it's basically an acute thrombotic phenomena which is dealt predominantly by either fibrinolytics as well as antiplatelets. So anticoagulation is generally not indicated in a stroke, except for situations like cardioembolic strokes or the embolization phenomena is ongoing and the recurrent stroke risk is still there. So the old rules like 1, 3, 6, 12, which means that severe stroke you start on 12th day, that has been replaced after the ELAN trial, which actually has shown that earlier use of anticoagulation need not be associated with increased bleed in a stroke. So obviously you have to look at how large is the stroke and the individualized, and you probably have to look at serial imaging also. But in a severe stroke, currently the guidelines recommend an anticoagulation to be restarted or started on day 6 or 7. Now going to other things, the standard management in the ICU, the anti-edema measures, looking for deterioration, when to do a repeat CT, especially when interventions are done. These are all routine things that comes in the management. Seizure management, primary prophylaxis for seizures for stroke is not recommended. When you have a seizure, secondary prophylaxis is definitely recommended. In the initial part of stroke, the seizures that happens may not recur, but that is not the case if the seizures actually start or they possess beyond a week. Generally, they are called post-stroke seizures, and they may require significant prolonged antiepileptics. Neuroprotective agents, there have been quite a few numbers we have seen over the years. As of now, there is no evidence that any of those help. There has been a mention about solo therapies and assessing solos, because aspiration, especially bulbar dysfunction, is quite a common phenomenon in stroke, and there has been recommendation about pharyngeal electrostimulation, etc. in the recommendations, which I am not exactly sure, but assessing swallow is probably one of the fundamental things and in managing a stroke complication. Thank you.
Thank you, sir. Thank you for a wonderful talk. Any questions? Sir, I have a question. So what we generally say is a practical thing. BP should be not less than 140. So what is the time period? Like how many days we should keep BP more than
what I understand is that over several days or couple of days is what is mentioned. I think the chance of a stroke area bleeding or transforming into hemorrhage is actually in the initial part of the stroke. No? Once the stroke sets in, it probably if you look at the bleed transformation, even after an endovascular therapy or even when you use IV or intraarterial thrombolytics or fibrinolytics, they are in the initial 24 to 48 hours. So I have not seen exactly what I seen mentioned is in the initial several days. That's what has been mentioned, if I remember correctly. So basically, I think the first day is what we are really bothered, first or second day, where we put an arterial line and you look at this BP. And practically what I see is very personalized, because each neurologist has their own whims and fancies about what a BP could do to the stroke. So I think it's properly personalized, but anything less than 140 would not be a great idea. Anything more than 180 systolic BP would not be a great idea. That's what I feel. How badly, how intensely you want to treat it. Like if you want to put somebody on arterial line, put them on labetalol, and then you want to fine titrate, and then hold it, that may be on a day or two. Beyond that, it doesn't make any sense. No? Maybe that time, they don't exactly know whether if somebody was on antihypertensives, whether they all should be started at that point, that is unsure, and they are skeptical, like the ASA guideline. No? So basically,
any study in that we have to save that penumbra. So how many days, how many time it should take to save and to BP?
BP, I'm not sure of that. I don't think there is a study that has looked at the perfusion benefits of tight BP. I'm not sure, but I not come across where they looked at the perfusions over BP control. I'm not very sure of that. Practically, I think it's initial couple of days where you have a tight BP control. After that, you can look at what is happening to the hemodynamics per se, and maybe start somebody on antihypertensives over next couple of days, because the transformation or the penumbra loss and all is in the first 24, 48 hours. Now, then probably the stroke is set. It cannot have that the penumbra is converted into the core over many, many days. So that concept is more of a day. Or I think there is no recommendation to go for any procedures beyond 24 hours. But some of the experts I've seen using even up to 48 hours window, especially in basal artery occlusion and all, because the catastrophic effects of brainstem infarcts. I don't know if I answered.
And that Tyvaldi, sir, most commonly people are using Tyvaldi, sovaltetide.
I'm not very. I've not seen a recommendation. I understand that is what is that actually?
Sovaltetide.
Yeah. What does it use for?
Neuroprotective.
I've gone through what is the. I've seen my critical care neuroanesthetist using that in certain strokes. I have not personally used because I have not seen a great recommendation. As of now, neuroprotective agents they don't recommend. But I think it's like. We're not really that bothered about somebody starting drugs. I'm not very sure. So if the neurologist wants that, it's up to them.
Thank you, sir.
Thank you. Thank you so much. Yeah.
Regarding the BP, on a monitor patient is showing typical case of Cushing's triad. The pulse is low, the BP is reaching 190, 200 on arrival. So we can't use labet. So how do we control? Other than that, neuro is using mannitol and all that to control other things. But for the MD is recommending to control the BP, and the neuro is opting not to make it lower.
No, you're talking about Cushing's triad means somebody has to be doing certain things into the brain. No, you're not going to reduce BP when somebody has a Cushing's triad. No, that is the only way your cerebral perfusion pressure is going to be maintained. That means you have to either open up the brain or skull or maybe inject with a lot of hyperventilate. If you're talking about Cushing's triad, it happens in the late phase of a very high ICP. So I think the reducing BP, you kill the person immediately. So it's no question of, I don't know exactly whether did you mean that. In situations which are critical, reducing BP is not the priority because it will immediately cut off the perfusion pressures. So I think you can forget about what others say and probably look at maintaining. See, I think you have to think of perfusion. No? As everybody is mentioning here, we're not looking at numbers. We're looking at perfusion to the area of interest, whether it can get perfused there. If you can fine tune with your anatomy, like there is an anatomical either severe stenosis or there are tandem lesions, then probably you should be more worried rather than, or if you're high ICP, of course you're not going to reduce your BP unless you reduce the ICP. I think you're traumatized by one of your MDs. Relax. Leave it. Thank you.
Thank you for such a great talk. Now it's time to felicitate our speaker as well as our panelist by giving memento. So to felicitate them, I would like to call Dr. Manoj on the stage. Please give them a round of applause.
एक सेकंड. ये छोटा है बड़ा है? Sorry. You are happy now? Vaishali, you remain on the stage only.
क्या
After discussing so many guidelines, now it's time to discuss a case. So for presenting case, I would like to call Dr. Shrikant. Moderator will be Dr. Sudeep Sen. The panelists for this session will be Dr. Vaishali Lokhande, Dr. Sharmili Sinha, and Dr. Ranjit. So welcome them all.
Good afternoon, everyone.
Hello. Okay, so we have done a lot of guideline talks and everything. Guidelines are not guidelines. That's a very good punchline, to be very frank. So I like that. So we have already talked about this topic, but maybe we'll talk about a little bit of kind of more case-based discussion where the guideline becomes a little blurred, where some amount of experience comes in handy. There are a lot of MDTs comes in handy. A lot of experiences we conglomerate took together. We'll discuss one such case where we need to prioritize people's something on the other, although there are guidelines are there, and we'll discuss this case. Dr. Shrikant is there, who is our DNB resident over here. He's very enthusiastic, very academician, good academicians. So he'll discuss this case. I'll come in between whenever he's in a little trouble.
Yes.
So otherwise, all rest on Dr. Shrikant.
Good afternoon, everyone. Presenting a 46-year-old male who is an executive manager by occupation, presented initially in Orsay Hospital with the complaints of bilateral leg swelling with a pain since 10 days and cough with blood-stained sputum since 5 days, fever was present since 5 days, breathlessness and exhaustion since 5 days, and chest discomfort since 3 days. On evaluation, initial diagnosis on venous Doppler was done. It was found to be bilateral DVT. So he was further referred to the Apollo for further evaluation. There is no history of prolonged immobilization, and there is no history of travel history, no recent surgery, and no history of trauma, no history of prior thromboembolic episodes, no history of active malignancy, and there is no history of loss of appetite and no history of weight loss. And patient has no known comorbidities. He has a history of COVID infection in 2020, which was managed with the oxygen support, and there was no ventilator support was required. On admission, the vitals being, the patient was afebrile with tachycardia of heart rate of 121 and respiratory was 22 cycles per minute. BP was around 140/90 millimeter mercury. Saturation was 88% on room air. And on local examination, his lower limbs were warm, was with some redness present, tender and swollen with chains of cellulitis. and no sensory deficits present. Pedal pulses were palpable. Systemic examination, bilateral normal vesicular blood sounds are heard with occasional crepes present. S1 is to present with no murmur. Per abdomen is soft and non-tender. CNS he was conscious, oriented, time, place, and person. This is the X-ray at the time admission, which was showing left lower zone there's a wedge-shaped opacity. And on arrival, the ECG was taken. It was just showing sinus tachycardia with no features of showing strain pattern. Investigations at admission, his HB was 12, total count being 61,000, platelet count was 31,000, and renal parameters were normal, liver parameters were within normal limit, the electrolytes are normal, the inflammatory markers as a CRP was raised 103.2, the procal being was 0.26, D-ram was elevated with 8.22. Tropi was 10, NT-proBNP was 643. 2D echo was done, which was showed initially there was no RV dysfunction with TAPSE score of 23, and there was no D signs with EF of left ventricle EF of 60%. ABG showed with type 1 respiratory failure with a PA out of 67, pH 7.48, PC out of 31, bicarb 23, and lactate of 0.9. So
what are the kind of, so first things comes that this patient has come to the ER and admission. So it is easy to think retrospectively. So now if we want to think the prospectively, somebody in this kind of clinical picture has come to the ER. Dr. Vaishali is there in a kind of the panelist. So he's the very senior physicians in our hospital. So what are the possibilities we will normally think in this kind of conditions?
If that Doppler had not been documented, there could have been many differential diagnoses. But with the documented venous Doppler suggestive of bilateral lower limb DVT, the only thing that comes to mind, first thing is pulmonary embolism. But what was the trigger is what probably will the workup tell us.
Sure. So the commonest DD that comes in the mind is the pulmonary embolism. It is a fever, so we had kind of other DDs for the sake of discussion, so we kept all those things. But P is a kind of discussion that we'll navigate. So we know that mostly it is P. Next, please. So we did a CTPA.
CTPA was shown, there was a lumen filling defect was noted in the left upper and middle lower branches of the left pulmonary artery, and also in the right upper lobe branches of the right side, and central filling defect was noted in the left lower subsegmental branch of the right side. Initially, since there was an increased leukocyte count, where thrombophilic profile was not sent in our patient.
So again, this is a kind of very common things. I think Dr. Sarmili has already discussed in his presentation. So we do not send the thrombophilic profile most of the time in acute setting. So any reasons, madam, why do you think that is this a condition so we should have sent a thrombophilic profile? We have not sent it over here, so that is why I mentioned. Or
yeah, see this case actually, if you do not have the ultrasound finding from outside, any case, any day this patient comes to the emergency department or presents to the intensive care unit, you will do a sepsis workup, and there will be several cardiac and non-cardiac differential diagnosis. So in that case, though pulmonary embolism for that patient with no other comorbid conditions will come last in the list on the differential diagnosis, because then it becomes a diagnosis of exclusion. So probably it won't strike about sending a thrombophilia profile in this case. And I would not blame anyone, because even for seniors also it won't strike us in that case. But with this background of ultrasound done outside with an established diagnosis of bilateral deep vein thrombosis in the lower limb, I would definitely think of sending this thrombophilia profile out at right at the admission. Because once we start the anticoagulation and other therapies, many factors, like if you see both the intrinsic and the extrinsic pathways, more than 20 factors are there, and which could be, and at least 10 of them could be attributed to inherited or genetic causes, which will be missed out.
True.
So it becomes makes the task difficult for the hematologist and subsequent follow-ups as well.
True. So as Madam has rightly said, that the major role of having a thrombophilia profile to send is that we need to know that whether there is any provoked cause is there or not. So if there is a provoked cause, probably they might require a kind of lifelong anticoagulation. So ideally it needs to be sent for all patients where we do not have an apparent cause. Here we didn't send it. We'll go by the subsequent slides. But one important thing is that after giving heparin or LMWH, it is better not to send except blurring few things. Yes, sir.
Yeah, you can discontinue for some time, but at that right acute setting, you cannot immediately
True.
send. Afterwards, yes, you can.
So
Sure.
one
Sure.
thing I just want to add on in terms of your choice of anticoagulation. Okay, so like we have the role of sending thrombophilia profile in terms of your choice of anticoagulation. Suppose if you're starting heparins or low molecular heparins, then things are fine. But if you want to directly start something, comes with an outpatient setup where you want to directly start Novax. If it is something like an APLA positive related thrombosis, then your Novax is not going to work. Maybe that is the only scenario where sending an early thrombophilia profile, especially ruling out APLA, is going to help. Because APLA, Novax is not going to work. You need to give something like, if you want to treat with orally, you need to give either acetrom or warfarin, something like that. So maybe that is the only scenario where early sending of thrombophilia profile is going to work.
True. So absolutely, probably right, absolutely rightly said. So applies the conditions, NOACs are not recommended so far. So for all practical purpose or for all theoretical purpose, probably it is better to send. Most of the time we often miss. So we end up waiting for 3 months, and then after 3 months we stop the anticoagulation and then do the thrombophilia profile and then decide. So that is for APLA, usually we get a history. So most of the time we get a kind of typical history. So we get to know whether it is APLA or not. So, but ideally it needs to be sent. Okay, next. Okay, so looking at the current clinical profile, is this a provoked or unprovoked DVT? So it looks like a kind of, we do not have any provoking factor so far. So it looks like to be an unprovoked DVT over here so far, because there is no other provoking factors. Next.
See, here I would like to mention something about DVTs or the Ps as a very important sepsis mimic. See, this TLC count was
61,000.
Yes. There was no history of fever, no?
Yes, he has a
He
history.
had a fever.
Old
So
history.
there was fever, there was a high TLC count.
Yes.
Of all this, of course, platelet count was also strikingly low for a patient who does not have any other comorbid conditions, no medicines. So it's an important sepsis mimic.
Yes,
So
so
in that context, actually, that always has to be kept in mind. And because it is so the other way around, now we are evolving in terms of knowledge and this assessments literature. So this actually gradually coming up with the more diagnosis, picking up with this malignancies, etc. Gradually it is coming up higher. It's not exactly at the bottom list of differential diagnosis about DVTs or unprovoked DVTs maybe.
yes, definitely. So that is why we first talked about the differential diagnosis, where the sepsis was one of the, because he had a kind of red cellulitis kind of features in the legs. So initially we thought it is sepsis, only we started in the broad spectrum antibiotics. How do you evaluate it? So how do you evaluate the cause? So again, we look for the provoking factors or the genetic factors, thrombophilia profile. We discussed about this. Next. So how do you do the risk stratifications? Madam has already discussed in details in her lecture, so I'm not going into details that part. But again, it's very important to know the previous all such subjective things, massive P, submassive P, those things have gone. So it has become a little complex, but at the same point of time, it has become very, very objective. If you are in any doubt, put these things in this chart, and you know that which stage he is, and then you decide. At least your guideline will not fail you. So that is why it is very important to know. There are so many categories they have made. Next. So now what are the criteria of thrombolysis? Yeah, you please continue.
Okay, sir. As per the latest guidelines, we know that it's categorized into category A to category E. So the criteria for thrombolysis are only the category D with the category E1 and category E2. Those are patients who are considered for thrombolysis, who are hemodynamically unstable.
So usually D and E onwards thrombolysis is favored. A and the C usually thrombolysis is not very favored unless it is very strong risk and all. So Madam again already has discussed. Next go first. So this patient is on admission was C2R. So clearly this patient didn't come into the purview of going on a systemic thrombolysis. We didn't thrombolize this patient. So did this patient require thrombolysis? No. Done. Now come to the therapeutic dilemma where everything starts. So this patient, although didn't require any thrombolysis, so there is a need for anticoagulation is there. But again, the dilemma was that his platelet count is too low, 32,000 is the platelet count. So we didn't know that what is the cause of this low platelet count. Sepsis was definitely on the card. We sent a kind of test to find out what the cause of the platelet count, but again we had a kind of MDT. So as per all these MDTs that happened with the hematologist and everybody, we transfused platelet, and then once the platelet counts kind of went up, then we started him on LMWH. I do not know, again, we do not know whether we did right, wrong. I want to know that from the panelist whether we did right or not. Whether
I just have a question. Could you take help of tag or rotem analysis in this case?
Excellent, very good. So we didn't do it over here. Obviously, how many of over here has an idea of take over here? Take is we often do for most in such cases. I do not know whether take is very standardized to take decisions in this kind of scenario or not, but yes, probably.
I'm just thinking.
Yeah.
So
So
these cases are not so common as
it's not very common.
I'm just thinking because it tells you about these are the cases actually. Even that's on the literature, and that's why guidelines are not guidelines. We always give it to Yeah. So I think we do not know. I mean, here the worry about not doing therapeutic anticoagulation. Yes, working. Therapeutic anticoagulation was the low platelet, which is a right concern, isn't it? So in that context, I think if you can do a tech, I mean, it's not foolproof. Nothing, it gives you may not give you absolute directions, but it can give you some direction, at least what other component of this, this coagulation cascade pathways are either prolonged or deranged or not deranged. So it gives you some background, and I think it helps decision making easier than not. Yeah.
True, absolutely.
What
agree.
you have done is, I agree with that, because
Is the dose of Clexane right? Was he a very frail gentleman?
Again, all these MDT discussions, I do not know. We do not know that whether did right or not. So that is the entire discussions we are taken up this case whether we did right or not. We do not know basically what is the dose is right or not. No, mostly for it is not therapeutic. It is not subtherapeutic. It is subtherapeutic. Bleeding. Bleeding. So kind of we didn't think of. I don't think we have thought of heat over here because. So this is the first platelet count. So this patient came to the ER. We got the first set of labs. The platelet count was 32,000. Smear counts are the same, and we did a CTPA. CTPA so documented pulmonary embolism, and he is hypoxic. So we are in a kind of urgency to give him some anticoagulation. But at the same point of time, we were worried at the time of for the low platelet count. So that is why we conducted a kind of, we talked to 4 different people in the 4 different, and then took opinion. And they all agreed to that, like, okay, you give platelet, decrease the risk of bleeding. At the same point of time, after platelet goes more than 50, you give a LMWH. Again, do not know whether that is a right decision, wrong decision. So idea over here, whether we can get anybody else dealt with the kind of similar kind of scenario, so that we get the kind of more knowledge from somebody else.
So on day 3, the patient was become worsened. There is a worsening of tachypnea. So the patient
was at the ICU with the oxygen and next.
The peripheral smear shows are here very high immature WC counts with blast cells, and flow cytometer was sent in view of that, which suggests you of.
So again, it's a very high. So we didn't expect it to happen, but again, when we run through the peripheral smear examination, we found there is a lot of blast cells. So he's a kind of undiagnosed AML, which came in the diagnosis and the subsequent flow cytometry, and probably that might be the cause. Most of the time with the sorry. One of the problem of having an AML in the diagnosis and with a PE. Hello. Anyway, we cannot. So I'll speak a little louder. Actually, even the mic is not there. So one of the problem of having an AML in the kind of diagnosis over here. Hello. Yeah. One of the problem of having an AML in a kind of diagnosis over here with the background of PE is that I hope all of you know that there is a one variety of AML, M3 variety of AML, which is associated with a very high incidence of DIC. So that is one important thing that always we remember, because somebody on an AML having thrombocytopenia, we always need to rule out DIC, because M3 variety of APML variety, which is a kind of the sickest part of the AML, they are associated with the DIC. So that is why. So it is a kind of retrospectively again it becomes very easy.
Initially, the report of it is the further.
So diagnosis was like that. So acute leukemia was favored, but again we didn't get a kind of flow cytometry diagnosis at that point of time. And again, we just need to remember that we are running at that point of time. So we are still within 6 hours of admissions, we do not have any flow cytometry report. We are just thinking, okay, this might be a possibility based on the blast cell report. Okay, this might be an AML. So this is the kind of situations we are in, and we need to take a decisions. The reports will come probably a week later to have a confirmatory, to have a which type of AML and all. But okay, it might be an AML, and now that the patient has presented with the pulmonary embolism, we need to anticoagulate at the same point of time. He might be coagulopathic. So that is the entire dilemma in the entire discussions. So next day probably the PET CT that showed kind of quite spreaded AML, spreaded to the bone marrow and all. Continue the case day 3.
So on day 3, the patient became worsened. There was worsening of tachypnea and hypoxia. So the patient was supported with the HFN support with 40 liter of flow at 40% FiO2, and injection Clexin of dose of 40 mg subcutaneous BD was continued after keeping the platelet count more than 40,000 with regular platelet transfusion as per the hematology advice. In view of worsening oxygenation, the 2D echo was repeated, which showed now that there is RV dysfunction and with EF of 60%. And repeat troponin was sent, it was elevated with 130, and 90 pro PNP was also 1157.
So again, what should we do now? So we do the same management, we continue the anticoagulations, we take for thrombolysis, we do for any catheter-directed therapy. So this is the dilemma we're sitting on the day 3, because the patient, somebody is worsening in front of your eyes, and you need to do something. And that is a kind of desperation probably all the intensivist has all the time whenever they work in the ICU. Somebody is, especially when you see that the day 3 he's with you and he's deteriorating. And most importantly, you did an echo, we found that his RV is now getting strained. So that means some amount of RV dysfunctions are happening. So probably the PE-wise it's progressing. So probably whatever we have done so far is suboptimal. So madam, probably your question is the dose of the Clexin was subtherapeutic. So it was not optimal at that point of time, and that is why he was deteriorating, right?
So what about the onco treatment? Is it going on?
So no, we referred them, they're waiting for the subtypes, the treatment has not started. So those things have not started also. Steroid we have started later, so on day 3, day 4 after this, but still he is in a kind of acute life-threatening conditions that we need to know that whether we will be able to salvage him or not. The cancer part, everything steroid they can start, but usually it's not true. They usually start treatment after having a kind of flow cytometric diagnosis. So at this moment we are in a situation where we need to know that whether we can salvage this patient, this gentleman or not. So that was the kind of more imminent thought process. So what we did a kind of CDT over here because we found that the anticoagulation is not helping. Thrombolysis is a kind of out of questions all the time because his platelet count is very low. So we are basically transfusing platelet and giving anticoagulations that might be counterproductive as well. The only choice we are left with is a kind of catheter-directed thrombolysis. So this is the kind of things that we have done.
So on day 3, we did the thrombosuction of the left pulmonary artery through the right femoral was done, and IVC filter placement was done through the right femoral vein, and multiple small and large cords were suction out through the aspirator.
I just want to make a comment, like this case actually most of the PEs you see a one-sided, some obstructivity symptomatic. In this case with the CTPA we saw there were bilateral thrombi in both the right and left PA, pulmonary arteries. So that is an indication actually though this patient was deceptively hemodynamically stable and respiratory was not compromised, because of the sitting on that edge to come to this side where you cannot lysis is required. So very predictably on the within 24 hours I think he has moved on to deteriorate. So this was probably I would have anticipated, and I mean it is obviously easier to say retrospectively just for our discussion's sake, and it is better to engage with this multidisciplinary team discussions made with the interventional radiologist to stay prepared for CDL in these cases. They are the perfect and ideal candidate for catheter-directed thrombolysis. That's what has the new guidelines also emphasized that compared to before 10 years ago where CDL etc. was because its lack of expertise in infrastructure expansion. Now that we have developed, this is the case of probably little preemptively. If I have become wiser in the hindsight in future, I would think of earlier intervention.
Yes, absolutely. Maybe in the first of day 1.
You have an PROP positive and you have an...
No, first day TROP was negative. The first day TROP was negative. ProBNP was positive.
So that also becomes like if you look at the previous listing, it comes something like an submassive PE, although it is 2026 update doesn't talk about it, but in case of submassive PE, definitely catheter-directed therapies are like, you will reduce the incidence of
Absolutely agree. Absolutely agree. Again, so that is why we tried to make it a little objective. So we told that it is a C2R. C2R, what does guideline says? No. It's only anticoagulations. Previously, probably submassive PE, probably yes. Retrospectively thinking, probably I would say probably we should have done a catheter-directed thrombectomy on the day 1. So when they came, because we found that there is a kind of bilateral PE and is hypoxic. Yes. Yes, definitely, definitely.
Following mechanical thrombectomy, the patient thrombectomy procedure done, sir. Following the mechanical thrombectomy, patient shortness of breath was reduced and HFNC was weaned off, and
Mechanical thrombectomy or a CDL?
We did
catheter.
Yes. And thrombosuction we did. And we put a DVT
Yes, IVC filter.
IVC filter.
And HFNC was weaned off and started on oxygen.
So again, we do not know. So again, we discussed with the cardiologist. He said his argued that the clot is still there there is still amount of some chunk of the clot is there. So we'll do a catheter-directed thrombolysis. It's a bilateral DVT. Yes, yes. Yes. There will be space. And they.
It's quite a capacious way.
No, one was popliteal, another was iliofemoral, if I am not wrong. One is popliteal.
Yes.
One is popliteal, one is iliofemoral. Yes.
And patient was weaned off from HFNC after thrombectomy. I started on oxygen therapy, minimal hemodialysis, and cuff with minimal expectoration. And injection collection was continued with that targeting the platelet count more than 50,000 as per the hematology advice. On day 6, the flow cytometry confirmed the acute myeloid leukemia, and he was continued with the targeted therapy, sir. How do we decide a therapeutic plan in pulmonary embolism in presence of coagulopathy?
So again, it's a question to everybody what to do. So whether we should do a take, whether we should make the take more popular, we should do a kind of systemic study over here, plan for a study. So what is the experience to the other centers? So I'd like to know. So a lot of other centers, madam, you can comment. So suppose there is a kind of presence of coagulopathy is there, and we need to. So suppose there is a kind of coagulopathy is there, in presence of coagulopathy, and we need to know the kind of, the patient is having a PE, so how do we decide about the anticoagulations? Even though we put a IVC filter, you will require anticoagulations because even it's a retrievable filter, some form of anticoagulations he will require. So what kind of modalities we use? Is there any kind of standardized things are there? So what we would use?
Most of the time, the clinical status of the patient will guide you. Here, basically, the patient had deteriorated, he became hypoxic, he started requiring HFNC, and then you had to take the decision of actually subjecting him to the lab test from the problem. But the ideal plan would be actually the rheumatology people also have to have actually a good test, because even the WBC count of 70,000 would cause pulmonary leukostasis syndrome that would worsen hypoxia. So something, maybe steroid to reduce the leukocyte count. And obviously with bleeding this, it is a difficult decision to decide whether we should go. But then we generally do like, we always every day follow the PT, PTT, INF, fibrinogen, the conventional. Sometimes they take. Then depending whether the patient is bleeding, I mean, what is more predominant manifestation of the DIC? Is it the bleeding or the
versus right.
Depending on that, we generally actually channelize the treatment. And for most of the time in this scenario, we actually keep the platelet count above 50,000 and then anticoagulate. So that is a common practice what we follow.
Okay. Sure. Thank you, madam. Any difference in the practice in your center?
Yes.
Same. Some PO2. PO2 will go down, right?
Yeah, and as I think I also commented already, if this patient will be demonstrating bilateral PA, pulmonary artery thrombus, it actually comes from the other side. Without just as we predictably moved out, he deteriorated. So these are the cases, you know, some kind of clot lysis is required. Systemic versus directed. And this kind of platelet count precludes systemic thrombolysis. So mechanical thrombectomy and lysis, as you have done correctly, I think that is the right approach.
Sure. No, we have not done. Definitely.
So in our patient.
And right time RV dysfunctions, just because the guideline was too vast, everything I could not have. Right RV dysfunction is an important marker of a patient who is either deteriorated or hemodynamic cardiorespiratory deterioration or is going to develop soon.
True.
Because that is why, though they say that they have made a strong statement that 2D echo neither is necessary for diagnosis or refuting the diagnosis or establishment of acute pulmonary embolism. Nevertheless, but RV diameter itself is a very important indicator of decompensation, either decompensated or on the verge of decompensation. So that should be picked up on that, both on the CTPA and on echo, and that also gives you kind of a preclude about your next steps.
True. This is indeed a kind of very important message to all PE. Even sometimes they become hemodynamically stable. If there is some evidence of RV dysfunction, probably you should consider some form of thrombolysis or either systemic or catheter directed.
What are the indication of IVC filter in patient with pulmonary embolism? The absolute indications are the acute DVT, venous thrombosis embolism with contraindication to the anticoagulations. And relative indications are recurrent pulmonary embolism with interruption, and there is an interruption of anticoagulation and large residual clot burden. What is post-thrombotic syndrome following DVT and the role of catheter dietary therapy in post-thrombotic syndrome?
So again, this is one of the very important topic. Probably it's not very well discussed in ICU. Suppose somebody comes on a DVT, bilateral DVT. Post-thrombotic syndrome is one of the important syndromes that we always ignore. We start them on the therapeutic anticoagulation and then we leave them. Over the 3 months of time, the thrombus gets diluted. But what the people ends up having, they ends up having a kind of destroyed leg vein, valves of the leg vein. And they suffer from the long-term venous incompetency. So to prevent those things, so there are a lot of, especially the Intervention Society guideline, they say that to do a catheter-directed thrombectomy of the bilateral lower limb, to prevent the post-thrombotic syndrome. Because if we do not do it in the acute stage, in the chronic stage, once it reaches to the kind of 1 week, 2 weeks of time, then the clot becomes very firm and the valves becomes destroyed. So, do you practice this kind of catheter-directed thrombectomy?
My experience is I have seen in postpartum lady, same nursed baby for prolonged periods, developed DVT, then some SOB, she had kind of an pre-sentinel PE. So where the legs are fully loaded with lot of clots, where our vascular surgeon who does even interventions, so what he did was exactly the same. He did some catheter-directed thrombectomy of pulmonaries, put an IVC filter, and then the catheter was kept inside the popliteal vein and femoral vein, and then he infused altiplase infusion for around 8 to 12 hours post-procedure, just to prevent this post-thrombotic syndrome.
So this is one thing, probably one important thing we should discuss.
Yeah, this is important as well for the morbidity point of view. Because, for a patient who has, usually in the young reproductive age, in the active age of phase of their life, it adds a lot of morbidity.
True.
If you have a swollen leg, you cannot mobilize. So, and this is possible with greater advancement of technology and precision. This is possible. So, I think we should be doing more often than not. And that's why there has been emphasis on the follow-up. Say, earlier we used to talk about the duration of therapy, like 3 months, 6 months, but it has been now emphasized up to 1 month. During the OPD visit, they should be asked about it, and it is one of the aspects that should be also inquired upon, along with dyspnea, chest discomfort, and this swelling and pain also.
Sure, yes. Thank you.
What is CTEF and what is the role of repeat CTPA following the diagnosis of pulmonary embolism? CTEF is defined as a chronic thromboembolism with pulmonary hypertension, with persistent symptoms of more than 3 months, with leading to the pulmonary hypertension with pulmonary pressure of more than 30, and with RV dysfunction and persistence of symptoms. That is progressive dyspnea.
So again, PE is a kind of, everybody knows that PE is a kind of very acute complications and acute things, but it has some two important long-term associations. One is PTS, post-thrombotic syndrome in the leg, and another is CTEF in the lungs. If you do not correct the PE or DVTP correctly, probably, in that case, the CTEF is a kind of very definite probability, and that is why you should all know it. So again, is there any role of having a kind of subsequent follow-up scan after one documented diagnosis of PE? Suppose we have diagnosed a PE we have started on anticoagulations, or we might have thrombolized, we might not have thrombolized, we have done started on anticoagulations. After how many months or after how many days will you do another CTPA to understand that your clot burden has gone down or going down? Do you do it or do you not do it?
Usually, in our part of India, we don't have any post-ICU follow-up clinics, especially for 3 months or 6 months. So no specific experience. Once they are out of ICU, maybe they come for a couple of visits, maybe for 2 to 3 weeks, and then that's it. We don't have any long-term follow-up clinics. Maybe
Madam can say. So how do?
No recommendation definitely, unless there's a clinical symptoms that the patient has another source and possibly is a thrombophilic case. In that case only, otherwise.
It's not required.
It's not required. I think as a clinical, and always 4 scores I showed, few are negative, on the low probability, there is no need of repeating CTC because it's an invasive thing and you're giving a contrast, not necessary.
Sure. So again, why I have brought up this topic, because we have seen there are some few practices are there. People repeat CTPA to document that whether the clot burden has reduced or not.
Yes.
So the routine remains. I think it's not.
This is about we are discussing.
Okay. So. Okay. Thank you very much.
So there were 2-3 things about this case. First is the counts were high and the platelets were low. The patient had no comorbidities. The PT-INR was deranged. In fact, if I look at the first slide, I thought whether it's a DIC, the trigger may be something, either an infection or some occult malignancy. The INR was deranged, so probably it was a DIC presenting as a clot somewhere, and the solid tumors are more known to cause DVTs than the hematological. That's one thing. Second thing was if this patient had as she mentioned, there are bilateral embolic episodes. Both the sides were involved. So probably he was the one who was going to go into RARB dysfunction eventually. If this patient had come with the acute hypotension, either D1, D2 or even E2, I mean even E2 category, you would have thought of the CDT directly. It was probably a sensible waiting. The first day was logical, nothing.
I hope all of you have enjoyed the case discussions. Anybody has any input from your end? Any other hospitals? Otherwise, we'll wind up this scenario. True.
But the argument about protein C, protein S actually going low in acute thrombus setting is also known. So that would probably interfere and probably misinterpret the reports.
So, anybody wants to give an answer? So, so protein C deficiency, protein S deficiency, they are one of the most common inherited thrombophilia disorders in all across the world, even in India. To be very frank, probably what we feel that we underdiagnose it. Because if we see the incidence of protein C deficiency, it is in general population, it is quite high. Few of them, they present with some thrombotic episode, few of them may not develop any thrombotic episodes, but otherwise, there is the most common inherited thrombophilic disorders. This is almost 40 to 50% of all thrombophilic disorders are protein C, protein S deficiency. And in fact, the protein C, protein S deficiency is quite high in general populations. So only problem of protein C, protein S deficiency assay is that after you have given heparin, you will not be able to assess it because it will cause, and suppose somebody has a liver disorder, they will be having acquired protein C, protein S deficiency, so those things you will have to rule out. So most of the time we end up not checking those things because again it's an acute stage, we end up treating the patients first, we give heparin, we give LMWH in the first go, we suspect, we give LMWH, and then most of the time we do scan after giving first dose of heparin or LMWH because on the basis of suspicion only. So most of the time, but again it is logical to test this. Even if you have missed at the first time, probably after 2 months, 3 months down the line, you stop, patient is otherwise clinically got better. Stop the anticoagulations for 2 weeks and then do the test and then decide. Most of the time find out. We had a kind of acute virtually with the protein C deficiency, he ended up having a liver transplant in our hospital. So it's common, it's not very rare, and it happens. Not very Which is right. I think that is inherited. They are inherited. So most of the time, the family member also have the same problem. Okay. So I think with these things we'll wind up this case. I hope all of you have enjoyed. Thank you very much.
Very good case and well managed.
Thank you, sir.
Thank you, Srikanth.
Thank you, sir. Thank you, everyone.
Thank you all for this wonderful case discussion. To felicitate our speakers and panelists, I would like to call Dr. Ameya Gude on stage. Qualification done? We have done. Okay. Srikanth. Ameya sir. Dr. Sudeep, please come on the stage for felicitation. पहले लंच करें क्या? लंच कर आफ्टर
Please.
Now it's time to have a lunch. Next talk will be at around 2:30. Good afternoon, everybody. Please settle down so that we can begin with our next topic. So the next topic of the day will be Surviving Sepsis Guideline 2026. So to update our knowledge of Surviving Sepsis Guidelines, I would like to invite Dr. Anuja Kulkarni. And the panelists for this talk will be Dr. Ashwini Khandekar and Dr. Pallavi Patekar. Please welcome them with the big round of applause.
Very good afternoon. Is my voice clear? Okay. I thought it's echoing. Okay. First of all, thank you, Dr. Akshay, for inviting me for this wonderful feast. I hope that everybody is enjoying it, and thank you, panelists. Yeah. So we'll start with this post-lunch session of Surviving Sepsis campaign. And what is new. So as everybody is aware, just a minute. Can I use this? Hello? So as everyone is aware, Surviving Sepsis guidelines have been helping us to treat innumerable patients over a period of last 20-25 years. 2004 was the first year when Surviving Sepsis guidelines were published, and this is almost sixth time they have actually done the amendments, and every guideline, every new guideline is actually helping us to treat and understand the sepsis in a better way, and also to manage and to improve the overall quality of treatment, to improve the mortality. The ultimate goal is basically to save their lives. So this is the latest guideline 2026, and so what is new is we will go through it, but I want you to actually concentrate on those strong recommendations. Conditional recommendations are they will vary case to case, and it is more of a clinical diagnosis, and along with that you have to take a call. Good practice statement also help in actually take decision, and the yellow capsule is new for 2026. So what is the burden actually? If we actually see the overall number of patients which get affected because of sepsis, this is actually US data where the worldwide affection of patients with sepsis is almost up to 49 million. And the mortality rate, if you see, is 13 million. When I was going through the literature, Indian literature, so this is a nice study by Dr. Subhash Todi et al. That was in 22-23, and it was actually conducted across 19 ICUs, and almost like 1,000 patients were evaluated. More than 1,000 patients were evaluated. So what was the incidence? in India, the number of patients get affected by sepsis are almost up to 11 million. And the mortality is around 2.5 to 3 million per year. So 2.5 to 3 million patients are dying every year in India because of sepsis. And when they actually compared Indian studies with the Western population, the demographics were more or less same. But what they found was the mortality rate was much higher as compared to the Western population. So what were the reasons why the mortality in Indian patients is high in spite of our healthcare system being so proactive? And so there are reasons what they thought were, and what they found after studying 1,000 or 1,100 patients were, first thing is, many times the patients were admitted directly with the septic shock. So whenever you have a high Apache 2 score, the chances of survival goes down, you know. So by then the multi-organ dysfunction is already established. Then the time to first dose of antibiotic, again it was, ideally it should be within 1 hour, there was delay in giving the first dose. Source control has to be very prompt within 6 hours as per the new guidelines. Again, if there is delay in source control, the mortality would go high. And whatever blood cultures were sent, 50% of the blood cultures were gram negative, and out of that, the 90 more than it is not 50% GNB, it is almost I would say majority were GNB, out of which more than 50% were CRE. So the organisms which were commonly encountered in India were Klebsiella, Acinetobacter and E. coli, and majority of them were CRE. So these were the reasons, like that is for higher mortality in India. The name of the study was Sepsis India, and that was in 2022-23 by Dr. Subhash Todi. So beyond acute mortality, sepsis, and what is actually important about this guidelines 2026, it looks beyond the survival. So all these years I never found the guidelines covering post-discharge from the ICU, what is the quality of life the patient is leading. So many times it is found that the patient has become very weak, the patient has suffered a critical care neuropathy, there is cognitive decline. So these aspects, even some mental disturbances, PTSD, so these aspects were never covered in the guidelines. And nowadays, now they have started, like we should be actually giving importance to these factors also. Sorry, how do I go back? I'm sorry.
If you want to move the slides, you can speak
Okay,
here.
okay, fine,
That's
thank
fine.
you.
I'll do it.
मैम I'll do पीछे जाओ
हाँ. So the methodology of 2026 guidelines is there were almost 69-person multidisciplinary team, and so look at the geographic diversity of this guideline, and 38% of the panelists practice in low or middle income countries, so ensuring resource adaptable protocols. So that is actually a good part of this guideline. And the great framework, we know that the strong recommendation to the weaker recommendation. In 2026 guideline, the guidelines only work when they match clinical workflow. So your the clinical spectrum and the guidelines should go hand in hand. And depending on that, the committee was divided into 6 subgroups depending on the clinical domain. So the first one subgroup was actually analyzing the screening, the early diagnosis part. Then the one subgroup was analyzing the therapeutics part, mainly hemodynamic monitoring, then the respiratory monitoring, the adjunctive therapy in the ICU, then the transition from ICU to the ward and from ward to the home. So that was important part. Then second thing about the critical, so whenever you have a sepsis patient, the management actually starts right at the diagnosis. The earlier the diagnosis, better is the outcome. That is the dictum. So whenever you have a patient, if suppose you get a call by ambulance service that so and so patient is coming to your hospital, the history taking or at least some clues to the diagnosis if you get, then that post sepsis is supposed to be a very good idea, or sepsis huddle, what we call it as. And the thing is, it will actually put the diagnostic momentum right in place. So first is have a good sepsis code identified in your hospital or sepsis huddle. Then it is like a multidisciplinary team with a clinician, with a clinical pharmacist, with the ER person. So sepsis code is a important the recommendation of this. Then second is quality improvement plan. So whenever you have a sepsis patient, always do auditing. Sepsis being a very time sensitive disease, you should actually do auditing, like how early the diagnosis was done, how early the patient received first dose of antibiotic, how early was the source control done. So quality improvement is very important, and they have stressed a lot on quality improvement programs as far as sepsis is concerned. Next. So what is the strong recommendation about the screening tools? Initially, a lot of importance was given to QSOFA. But subsequently, it was observed that it has low sensitivity and specificity, and they came up with a new scoring system like NEWS2. Almost a cohort of 2 lakh people was tested with these parameters, and they found that NEWS2 has a very good sensitivity as well as specificity. So now this is shifting towards new screening tools, out of which NEWS2 is a better tool. So it is actually very simple, and it's like more of a temperature, how's the mentation, how's the blood pressure, how's the respiratory rate, and very easy to calculate. But yes, nowadays they are recommending NEWS2 score. Biomarker trap, again, there is no single biomarker to actually label it as a sepsis or there is no evidence of sepsis. Nothing can replace a good clinical history and good clinical examination. So bedside, whenever you have a multidisciplinary sepsis huddle or sepsis code, these two things will never replace your biomarkers. So they have not come to a single biomarker as such. They have not even mentioned about procalcitonin. Many of actually clinicians prefer sending procalcitonin, but if you ask me, the guidelines mention that clinical examination without procalcitonin is a better tool to diagnose sepsis. Procalcitonin, will come to that, what is actual role of procalcitonin in sepsis guidelines. But then what are the other, there are 2 or 3 in the pipelines to diagnose the sepsis, so out of which one is monocyte distribution width. This has not yet come to the standard textbook, but again, if there is a certain, this has to come on the hemogram, the regular CBC what you get in the lab. And ideally, we should ask them what is the monocyte distribution width. And actually, there's many things to be done on this parameter. But you should just know that these are the parameters where they are probably working to see the feasibility whether this particular parameter can be used as a tool to diagnose sepsis. One is monocyte distribution weight, then messenger RNA transcript, sometimes the leukocyte count, sometimes the lymphocyte and neutrophil ratio, or lymphocyte platelet ratio. So there are certain parameters, but nothing is yet finalized. Next one. So for 0R, again, everybody is aware that blood culture has to be sent. After the first set of blood culture is sent, then only antimicrobial therapy should be done. But if the culture bottles are not available, patient is in septic shock, you cannot delay the antibiotic dosages. So that is for sure. But as far as possible, try and send blood cultures In resource limited setting, sending just 2 bottles, that is one set of blood cultures is also acceptable. Ideal would be 4 bottles, from 2 different 2 sites. If the patient has central line in situ, one set should go from the central line, the one set should go from the periphery. But even 2 cultures are also adequate. Many times it is asked whether aerobic, anaerobic, and so aerobic has to be sent, but anaerobic, only 15% of times you will have a positive blood culture in anaerobic bottle. So if you don't feel it is anaerobic infection, so what are the criteria where you would suspect anaerobic infection? Patients who with abdominal sepsis, patients with necrotizing fasciitis, or obstetric or gynecological deep-seated abscesses, so empyema. So where the chances of having anaerobic infection are high, then yes, you may send anaerobic cultures. Otherwise, aerobic cultures are also good enough. But you have to send blood cultures because today's blood cultures are going to lay foundation for your antibiotic stewardship. So in Sepsis India study, when they actually realized the organisms like Klebsiella, E. coli, Acinetobacter, that was possible only because the cultures were sent, and then we could actually assess that it has a very high carbapenemase resistance incidence in the blood culture. So unless and until we send blood culture, we are not really going to, it's otherwise a blind game. So, so first is sending a blood culture, then the resuscitation engine. The engine has 3 pistons, and all the 3 pistons should actually start working simultaneously. It is not one after another. So your hemodynamics, your resuscitation with crystalloids, managing, monitoring the lactates, monitoring the CRT, then simultaneously starting the vasopressin. So all these 3 pistons should move together. What is the first? First is to you start with peripheral access. This particular guideline mentioned that noradrenaline can be started concomitantly with the fluid resuscitation, provided your patient is in septic shock and there's at least some amount of fluid is gone. Directly starting with vasopressors like noradrenaline is not a good idea, but again it is a conditional recommendation where wherein the crystalloid the resuscitation is already ongoing, and you always start with a smaller dose of vasopressor because it is a phase of vasoplegia. All endotoxinemia is all it is. So septic shocks are vasoplegic shocks. So to have control on your fluid resuscitation, you don't want these patients to go into fluid overload later. So over resuscitation is also not a good idea, right? So our aim is to give appropriate amount of fluid. Along with that, maintain the mean arterial pressure to have a good end organ perfusion. So the first question is, then how do we actually monitor whether the resuscitation is adequate or not? So the lactate clearance, ideally we know that within 6 hours, at least 10% reduction in the lactate, that means you are in the right path. But again, in resource restricted environment, CRT is equally good. So Andromeda shock trial, which compared the capillary refill time versus the clearance of the lactate, and that showed that the CRT was better than lactate clearance. Sometimes lactates take some time to get cleared, and CRT is a better tool. The organ perfusion was adequate, there was no over-resuscitation, and less interventions were. Mortality-wise, there was not much of a difference if you compare lactate clearance with CRT. But yes, in resource limited, CRT is a good tool to know that your organs are getting perfused. Then second is initiate within first 3 hours, fluid dynamics. At least 30 ml per kg. Again, this 30 ml per kg, there was, in the last sepsis guideline, there was discussion from where have they got this magic figure of 30. But it is again, over a period of many years and many cohort studies, even the ARISE, PROMISE, PROCESS, the 3 basic trials, even before randomization, those patients had received 30 ml per kg of fluid as a part of resuscitation. So at least 30 ml per kg, provided your, obviously the patient is not in, I mean the lung profile is clear, the cardiac function is good, and obviously there are no signs of fluid, that the patient is going into fluid overload up to 30 ml. So it is again a dynamic process, and the monitoring, ongoing monitoring is very important while you are resuscitating the patients with LV dysfunction. And third, this is again sepsis being a very time sensitive disease. The target mean arterial pressure is 65, and norepinephrine concurrent with fluids for life-threatening hypoperfusion that we have already seen. So optimizing the fluid dynamics, the conditional recommendation is 30 ml per kg. What was observed that sometimes even the resuscitation up to 50 ml, 70 ml per kg was done, and that had actually caused more harm than good. So this figure. Then the balanced mandate, that is use balanced crystalloid. For obvious reason, we know that using too much of normal saline causes hyperchloremic acidosis, so more of an AGMA, and higher chances of patient probably going or progressing to acute kidney injury requiring RRT. So this is proven beyond doubt that balanced salt solution, ringer lactate are better than using only normal saline. Then this is a new recommendation as far as weight is concerned. For patients who are overweight, obese patient with BMI more than 30 ml per kg, ideal body weight or adjusted body weight has to be calculated, and then accordingly you can give. So suppose a person who is 6 feet tall and the weight is 120 kg, if you go as per actual body weight, then you would be giving him almost 3.5 to 3.7 liters as a part of initial resuscitation. As against, as per this recommendation, the ideal body weight or the adjusted body weight would be between 80 to 90 kg. There are formulas even for adjusted body weight, wherein the ideal body weight plus 0.4 into the difference. These are standard formulas. And so if you give according to the adjusted body weight or ideal body weight, the resuscitation fluid is almost a liter less than what you would give with actual body weight. So again, the chances of hyperperfusion are less. And the stop sign, avoid harms of over-resuscitation, assess fluid responsiveness, and using dynamic parameters. So everybody is aware what is static, what is dynamic parameters, and nowadays we have been using POCUS a lot. So POCUS is almost replacing stethoscopes. So if the lung profile is now getting converted from A profile to B profile, if the cardiac function, suppose the patient has stress cardiomyopathy, then the LV dysfunction is worsening. So in that scenario, definitely you have to cut down on the fluid, and the other parameters like dynamic parameters are stroke volume variation. Suppose you have an arterial line with Vigilio, or if you have a bedside echo with non-invasive hemodynamic monitoring, like if the patient is intubated and paralyzed, doing LVOT VTI. With respiration, with the respiratory variation, you can actually check whether the patient is still volume responsive or the patient has now reached to the point where more fluid would actually do more harm. So the hemodynamic targets, we know that the 65 was the recommendation as per the previous guidelines. Because at that mean arterial pressure, it is assumed that the end organ perfusion is adequate. But now the new guideline mentions that if the age is more than 65, the MAP can be adjusted from 60 to 65. Initially, this thought process was with elderly, with chronically hypertensive patient with acute kidney injury, maintaining a MAP of maybe 70, 75 would be more beneficial. But nowadays it is proven in the trials that maintaining MAP between 60 to 65 for patients with age more than 65 actually shows a better survival, it has a survival benefit, and definitely less exposure to vasopressors. This vasopressin increases the chances of patient developing atrial fibrillation. So arrhythmia, chances of developing arrhythmias, exposure to vasopressin is also reduced without compromising the mortality. So with elderly age group, accept MAP between 60 to 65. This is the new recommendation. So vasoactive, there is not much of a change. First drug of choice is norepinephrine, second is vasopressin, then third is epinephrine, and fourth is you can consider stress steroid, provided the patient is on 2 vasopressors. And the strong recommendation, the norepinephrine remains the same, the first drug. And conditional recommendation is, yes, you can start vasopressors from the peripheral line. So no need to wait for the central line to be inserted, and then starting the noradrenaline. So up to 5-6 ml, it is safe to give through a peripheral line. Yes, we know that extravasation can be disastrous. It can cause necrosis of the tissue, but still the smaller doses can be given. But so you start with the vasopressors peripherally, and by the time the central line is done or the patient is more stable, then definitely you can switch over from the peripheral line to the central line. So now the antimicrobial timing matrix. This has a direct impact on the mortality. So this has to be taken very seriously. Again here, the definitive or probable sepsis with shock, antibiotic should be given within first hour. As against patient, if the shock is absent and still, if there is no shock and you are not very sure about the sepsis part, up to 3 hours is acceptable time window. But patients with probable or definitive sepsis and shock, antibiotic should be given within first 1 hour. So antimicrobials and source control. Source control has to be very, priority should be given to early source control. For example, you have a patient with perforated appendix, so perforation peritonitis. The patient has to be taken for early exploratory laparotomy. Or patient with obstructed system, like obstructive uropathy with pyelonephritis. Patient with CBD stricture with ascending cholangitis. Patient with devices, infected devices, like patient has a central line which is infected. So get rid of these devices which could be the source of infection. The source control has to be done very early. Many times the surgeon would want the hemodynamics to be stabilized, and they would decide about the intervention. But in that case, you have to actually convince them that unless and until the source control is done, the patient is not going to stabilize. So this tug of war always goes on. Then the empiric stratification, whether the patient should be given antibiotic coverage, how would you decide? So again, there are categories as class 1. Generally, we divide them as class 1, class 2, class 3. So community acquired is typically class 1. So no exposure to healthcare system in last 3 months, or no exposure to antibiotics in the young patient, not many comorbidities. So these patients, definitely you can get away. Suppose patient has community acquired pneumonia, you can just get away giving ceftriaxone with either macrolide group of drug or doxycycline. As against a patient who is like a CKD patient in and out of dialysis center. So there's frequent contact with the healthcare system. And patient, suppose patient has PUMCAT in situ, and patient has had recently Klebsiella isolated from the PUMCAT. So in that case, it is again a case-to-case basis decision, whether you would be directly starting with MDR coverage, or you would again, and how sick is the patient. Suppose the patient is hemodynamically stable, patient is not showing many signs of sepsis, then you can wait for the cultures. You would expect probably MDR drug, but wait for the cultures if the patient gives you some time. If the patient is critically very sick, patient is clinically very sick, and if you feel that patient has, we have a recent culture, then sometimes you have to directly start with MDR pathogen cover. Then what about the anaerobic coverage? Again, as I told you, the anaerobic, whenever you are suspecting anaerobic infection, then only, otherwise it is not to be given routinely. And this carbapenems, piperacillin, tazobactam, they have good anaerobic cover. So you don't have to actually give a separate anaerobic cover for these patients when they are on this beta-lactam or BL-BLI combination. But patient with cephalosporins generally, and if you're suspecting the anaerobic infection, then they need a separate anaerobic coverage. About the antibiotic, this was covered well in the morning lecture, that we have to give a loading dose followed by a continuous infusion to improve the MIC, to improve the drug level and to keep the drug level well above the MIC throughout the day. So whenever you have a patient who has received standard bolus, then most of the time the drug level would be below MIC, as against a patient who has received the loading dose and then continuous infusion. So for most of the time we give carbapenems over 3 hours, we give piperacillin tazobactam over 4 hours, and that basically improves your bioavailability of the drug, as well as it keeps actually the drug level above the MIC level. So chances of developing the resistance or even the drug failure are less, provided you are giving appropriate antibiotic. So the loading dose is must, and prolonged infusion, you can always discuss with the clinical pharmacist about the shelf life. And up to 3 hours is definitely carbapenems are stable, and piperacillin tazobactam can be given up to 4 hours infusion. So antimicrobial stewardship, as we discussed, if we send cultures, then only we will come to know what is the epidemiology of our own ICU. And then empirically, if you have to start certain antibiotic, then you know what is the most common bug in your ICU and what is the resistance pattern, whether more of us ESBL or it is more of a carbapenemase producer, then accordingly the antibiotics can be adjusted. Every day there should be assessment whether you can de-escalate. So when I was going to the India sepsis study, what I realized, only 30% of times the antibiotics were de-escalated. So we are probably very poor as far as de-escalation is considered. Why to stop the winning combination? You know, that is the anxiety generally the physicians feel, that patient is improving, why do you want to stop it? Why do you want to de-escalate? So, but then in long run, we are doing more harm to the society by not de-escalating. So you have to maintain that that every patient, whenever the shock is better, whenever you have actual antibiotic sensitivity, the MIC levels are there, you have the break points, then accordingly this can be stopped. I mean, this can be de-escalated. Many times meropenem targocid is started as a broad spectrum antibiotic. But how many times we do get gram-positive in our ICUs? Very less. So by giving ticoplanin, we are actually inviting trouble. The chances that a patient, the ICU would start growing Enterococcus faecalis in the long run. So again, think twice before you start a gram-positive. So again, to start gram-positive, there has to be certain criteria, like patient is admitted for prolonged time, patient has received multiple combinations of antibiotic, or the patient is post-influenza. So there are again, for every new addition of antibiotic, you have to have a logical explanation, like why you are starting anti-anaerobic therapy, why are you starting anti-MRSA therapy, why are you starting even antifungal therapy. Again, in sepsis, routinely adding antifungal is not a good practice. So when to suspect the fungal infection in ICU, again, if the patient has received antibiotics for prolonged period, patient has some intra-abdominal infection like pancreatitis, or if the patient has isolated candida from 2 different sites, even though it is colonization. So in that case, maybe you are justified in giving, or sometimes even beta-glucan. Again, it is a conditional recommendation, sending beta-glucan, but then again, with the clinical background, that you have this history that the patient is probably a candidate to develop candidemia, and then you want to prove that yes, because again, this in resource limited setup, sending beta-glucan is going to be not very cost effective investigation. Sorry, can you please go back? About just short take on this TDM, therapeutic drug monitoring, we don't do it routinely. But again, it is a conditional recommendation. Certain antibiotics, actually they should be monitored with TDM, especially patients who are on dialysis, CRRT, ECMO. The volume of distribution is totally altered. It is unpredictable. We don't know whether the patients are hypoproteinemic. We don't know whether the drug is hydrophilic or hydrophobic. So there are a number of that it is difficult to actually know whether whatever antibiotic you are giving is actually working and whether it has adequate level in the blood. So though it is not available, it is generally advisable to do vancomycin trough levels, or even for posaconazole, voriconazole, it is recommended that you should be doing TDM. So what not to do? Now this is this where the guidelines very clearly mentions that there is no role of IV immunoglobulin in sepsis. I have not given, but I just remember one case where the patient had streptococcal septic shock syndrome, toxic shock syndrome, and patient was admitted with blood pressure of 40 systolic with severe ARDS, and it was like a desperate attempt. But then it was again a very conditional, but guideline doesn't really recommend about IV immunoglobulin. Sodium bicarbonate, many times this is the mistake what we commit, for high lactate we give bicarbonate. That is not the drug. Lactate, the reason the lactates are rising because your noradrenaline is going on, there's a hypoperfusion of the organ. So giving bicarbonate is not going to solve the problem. It is not going to reduce the lactate levels. So correcting the underlying pathology is the treatment to reduce the lactate level. Bicarbonate is indicated, yes, when you have a gross acidosis with pH 7.2 and if there is simultaneously renal injury, then in that case bicarbonate can be given. Again, liberal transfusion, restricted transfusions are better. Only there are few, there's recommendation. One is patient with cancers, or patient with the cerebrovascular or cardiovascular conditions, there you can consider. Otherwise, below 7 is the threshold where in sepsis you would give transfusion. Otherwise, it is not a liberal policy to be followed. So beyond survival, again the first goal is address goals of care and prognosis, early prognosis, and then the second most important part is handover, giving handover from one over to other person, and from one intensivist to other intensivist is pivotal, and you should not be missing out on those. And the key stone is pharmacy-related medication reconciliation at the time of admission to the ICU and discharge from the ICU. Again, the iceberg, we are coming to the end of this. So this is just a tip of iceberg, and the new and worsening functional disability should be identified. Many times this physical impairment in the form of muscle wasting because of hypercatabolism, chronic fatigue syndrome, organ dysfunction. Sometimes they get discharged with creatinine of 2.5. Cognitive decline, so patient do have memory loss or executive dysfunction. You should evaluate for that. And mental health crisis like PTSD, anxiety, so all these problems should be addressed. Again, the clinical follow-up, the physical rehabilitation, the discharge summary has to be very thorough. So we generally make it a point that whatever has happened in the ICU, how the stormy course or whatever, it should be written in detail before the patient gets shifted to the ward. So then only that will convey the patient's overall status in the ICU. So, time? No? Time is over? Last 5 minutes, okay. So quickly, one case, this case was recently admitted with us on 7th of January. She was a 50-year-old lady with diabetes, uncontrolled diabetes, hypertension, recent CABG. So she was hospitalized, and that time she was catheterized. Then this was some GI symptoms. She had taken Lomotil, then she had abdominal pain, altered sensorium, and fever. So the patient was dull on admission. Patient had heart rate of 120. Patient was already on noradrenaline. Clinically, she was looking dehydrated. There was reduced urine output. CRT was 5 to 6. So all the signs of hypoperfusion. The ABG did show the severe metabolic acidosis. The lactates were high. Anion gap was high. BSL was in the range of 548. So she had diabetic ketoacidosis. The echo showed global LV dysfunction, and she had ejection fraction of 35%, already in DIC. This was the X-ray. So these are the X-ray where giving a fluid up to 30 ml per kg is a little scary. You know, again, so it is case-to-case basis, and dynamic parameters has to be done. I think this is so. Actually, that's a wrong slide. I wanted to show this particular patient underwent CT because we were suspecting pyelonephritis, and it was emphysematous pyelonephritis with entire left kidney was almost studied with gas. So it was gas-forming organism and emphysematous pyelonephritis. So she and obstructed system. So source control. This particular patient underwent stenting, and that was the essential actually step to treat her sepsis. So so this is the last hymn. QI measures for sepsis in hospital. So what is new in 2026 is, yes, you have to monitor the quality indicators. News 2 is a better tool to diagnose sepsis. Then blood cultures before antibiotic administration. Do send blood cultures. MAP of 65, especially if the age is more than 65. Antibiotics within 1 hour if there is definitive, probable or possible sepsis with shock. And antibiotics within 1 hour in definite probable sepsis without shock. So up to 3 hours is okay if the patient doesn't have shock. Prolonged infusion of beta-lactams. De-escalation when infection is proven. Infection is ruled out. Crystalloids, first line. Then strong against the use of starches. Then norepinephrine is your first drug. Then low tidal volume, yes, ARDS management. P-plateau has to be below 30, that low tidal volume 6 ml per kg. Strong recommendation against incremental PEEP, so no role of recruitment maneuvers. Then insulin therapy, when the blood glucose is more than 180. Then use of pharmacological thromboprophylaxis in the form of either enoxaparin or UFH. And LMH, low molecular weight heparin is better than UFH. So, last time. Thank you. Queries? Thank you.
I was going to ask them. If anybody has any questions. No, I would like to thank Madam for a very informative and a lucid presentation. Your slides were very beautiful, Madam. Very nice. And like a true teacher, she's revised everything. Yes.
To felicitate our speakers and panelists, I would like to invite Dr. Nikhil Varge on stage.
Sorry.
So next we are going to discuss a very interesting topic, that is personalized nutrition. The speaker for this session will be Dr. Swarna Deepak, and the panelist will be Dr. Varsha Gore and Dr. Smriti Tiwari. Please welcome them.
Thank you, organizing team, for having me. It's been every year, it's been a pleasure to come here and meet all of you, as well listen to the interesting lectures also. And talking on nutrition, post-nutrition in the afternoon is not a simple thing. So can you all lift your hands once? Do like this, just to wake you up, so I'll finish up. So I'll promise to finish in 30 minutes, so stop me if that is there. So this is us in the ICU trying to match the nutrition needs of the patient. We all know we are not going to do the perfect job, but at least if you could try it. End of the lecture, we'll see if the fox can catch the grapes. So it's not an absolute stage. As you know, critical illness is something which evolves over a period of time. So as you can see, the first 48 hours is an acute phase where the catabolic phase, the middle phase changes, the third phase which will require much more calories, the protein requirement changes, the calorie requirement changes, the muscle breakdown changes. So it depends on phase, it depends on the requirement of the patients. We need to change ourselves. So this is my regular patient. As you can see, there are so many pumps, so many machines, so many tubes, everything, no? So among them, do you really think the nutrition is an important thing? So many of the times we think that nutrition is just something which is supplementary where the dietitians take care of it. But more and more we know that it is a therapy. Nutrition is as equally important as any your ECMO or as your IV fluids or a vasopressor for that matter. So coming to that, the most interesting thing is when to start the feed, what to start, and how to feed the patients. End of the time, this slide would be your take-home message. So if you can answer these questions at least a bit better than this 30 minutes, my job is done. So my patient is in middle. So when I'm seeing this patient, these are my questions. Do you need to feed through the enteral route or parenteral? Do I need to start a formula feed or a kitchen feed? Most of us doesn't have a luxury of indirect calorimetry. So can I use my predictive equations? Is it okay or not? Do I need to start it at a hypocaloric feed or hypercaloric? Is it a continuous feed or is it a bolus feed? All these questions, no? We keep on having these questions every day, day in and day out. Somehow we brush it out to the nutritionist end of the day. So two case scenarios. So this is our regular patient, like madam has told, no? Pancreatitis, septic shock, requiring vasopressors, the lactate is high. So she has not been taking, the patient has not been taking intake. So why do you require a personalized nutrition prescription here? You know, the shock, obviously shock involves your gut as well. So there's a lot of splanchnic hypoperfusion. If you increase the feed, all your gut flow, that diversion will be towards the gut, right? More important organs will supply. If you're not feeding, what will happen? Your gut will become more disintegrated. You will have a gut translocation. Your sepsis may worsen. But how much time are you going to wait? At what cost? So you need to have a precision strategy here. So this is always about a perfusion, not about the number. So we all agree we are not going to feed fully in the initial septic shock. You obviously observe the trend of the vasopressors. As you improve in your perfusion, you improve your volume of the feed per hour. And the whole point is not to give the calories to the patient, but preserve the gut in the early period. So your take-home message, at least in this case, is perfusion, but not a specific protocol. The second question, again, we saw the same respiratory case. The patient is being prone 16 hours. How many of you feed on a prone patient? The first hour, second hour, maybe, once you prone it. So you see, I can see all the hands are down. So it again, and how many of you regularly see for the extra calories, like maybe a propofol? Many of the times we miss it, the sedation. We all know, no, propofol trisodium citrate, dextrose saline. In fact, the dilutions where the drugs are diluted also can cause the calorie intake. So all those things will contribute, and especially these patients where propine and supine, you can have a calorie debt because of the feed interruptions. So all these things need to be considered. So obviously in this specific patient where you have a respiratory failure, you don't want your carbon dioxide to be high. At the same time, your muscle should not be wasted. So in this situation, this is how your prescription should be. You initially start with a continuous feed, maybe a trophic feed. You see the patient's shock, how it evolves. You try to minimize the interruptions of the feed, whether you go for a CT, whether you prone or supine, and you always account for the nutritional calories. So hidden overfeeding also is very dangerous when you compare with an underfeeding. Both sides are dangerous. So once you see these two case scenarios, why do you need to individualize? My group, that patient which I have shown, is a heterogeneous group. You cannot equate a septic shock patient with a patient on CRRT, with a patient on maybe a ventilator. Each of them are different. And as we saw the profile, no, the first 48 hours are different from the next 72 hours are different from the next 7 days. And most of us, we don't have what is major knowledge about the metabolic profile. So you don't know how the genetics of the patient, the same patient, same NARED you will keep, same meropenem you will keep, but one patient deteriorates, other patient improves. You don't really know how the patients will behave with the that particular situation. And variable expenditure. The patient may have an overnight 104 fever, your expenditure may be different. So each of them changes. And obviously the prior nutritional makeup, a patient who has not been eating since last 1 month, is obviously a different guy when you compare with a de novo patient, right? And most of us, we don't have a reliable way of understanding the monitoring parameters. So this is what I was telling, the acute phase, middle phase and the rehab phase. Most of us try to miss this rehab phase, as one of the previous speaker pointed out. This phase comes when you have a follow-up clinics in the ICU. So once they come back, that is the phase they require most of the proteins and the calories. So this is the basic next 10 slides. So you are going to assess the patient with the proper gadgets. You are going to at least understand what is the average energy expenditure. Most important thing is the protein prescription, and look for the gut failure. So, and whether you're tolerating the particular feed, glucose tolerance, and you need to adjust for the extracorporeal interventions, and don't neglect the micronutrients, electrolytes like phosphate, potassium, magnesium. So this is the main thing. And is it important really, this topic? This is absolutely important because it can be a causative agent as well as as you can see in the Britain itself, the people entered is that much, where the people who left is more than the people entered with the malnutrition. So all these patients, there is a we will not going into this much busy slides, but the take home point is it has a significant effect on the mortality and morbidity of the patient, the level of malnutrition. And one of the most important thing is apathy, to recognize the malnutrition. You don't really look for the nutrition daily. You all look for the DVT prophylaxis. We look for the tubes and lines, de-escalation of antibiotics. But how many of you actually daily calculate the calorie protein requirement, discuss with your dietitian in the huddles? So we usually try to undermine it. So most of the factors contribute to the malnutrition. And obviously the diagnosis is very important. So this is a very gray definition. How much is the actual appropriate calorie intake? There is no definite definition. It depends on, as we saw, no? It's a heterogeneous description. Most of our predictive equations, you name any predictive equation, it will fall less than the indirect calorimetry. We all know. But unfortunately, we don't have much choices. But nowadays, we have different gadgets, different ventilators, which we can use, maybe come out. So again, the same thing. So it's a moving target. Your resting energy expenditure differs on the first day and it differs on the 7th day. So you need to have an understanding and you need to have a daily sheet with you. So the best approach is when your patient is sick, start slowly and slowly go up in the calories. We'll go through this. And optimal energy, there is nothing like an optimal or ideal energy target. It's an illusion, but you need to have some idea. Most important thing is repeatedly assess the energy expenditure and keep correcting it every day. And as I told, the proteins is the most important thing in this one. If you don't replace the protein in the early part, they'll go into a sarcopenia, they'll go into a muscle wasting, and all your ammonia, everything, the detoxification organ is the muscle. So your ammonia builds up and the patient will become worse. And you can see here, no, in the first 7 days itself, almost half of the kg of the protein in the body is lost. And if you allow it, more than 2 grams of protein is lost. And believe me, it is extremely tough to regain this protein. So the greater protein and energy intake, obviously this is, I think, self-explanatory. The more the protein, can you give protein safely? It has been proved that you can give it, but having said that, you need to understand. We'll see another 3-4 settings in the last and we'll close it. Please stop me if my time is over. Coming to the third one is, are you tolerating the feed? How do you assess the feed tolerance? Obviously, the obvious things are daily checking of the GRV, looking for the loose motions, looking for the abdominal distensions. These are a couple of things which you can regularly monitor. And any presence of feed intolerance in your sick patients, which is very common, can have an impact on the mortality and morbidity. How do you improve the feed intolerance? As we saw, understanding the phase of the patient. Is in the acute phase, middle phase, or the late phase. And you need to keep monitoring your electrolytes and keep supplementing it. Good prokinetics, continuous feeding, and the most important thing is early mobilization. Every day you need to ask, can we get him out of the bed and make him sit in the chair? So as we all know, glucose tolerance. So most of these patients' insulin resistance goes up. So suddenly there will be something called as stress hyperglycemia. So you need to keep a watch on your glucose, and the better the glucose tolerance, obviously the patients will be better. How many of you keep the supplements, micronutrients? Hands up. Okay. What do you keep? Just what do you keep in your micronutrients? Right. So it has been. Yes. True. So most underappreciated, but again you need to understand what setting are you keeping the micronutrients. Your Burns patient is not equal to the sepsis patient, which is not equal to the something else like a patient who was on CRRT. So you need to understand the setting and replace it. Especially the patients who are on extracorporeal therapies like your CRRTs, ECMOs, they tend to lose the lot of micronutrients through the membranes. The patients who stays more than 48 hours, make sure that you replace them. So as we discussed, dextrose, propofol, citrate, all of them contribute to the non-nutritional calories. So coming to the last couple of slides, disease-specific nutrition. This is the personalized nutrition. So there's a common misconception that any patient who has an acute kidney injury, patient who goes on to renal replacement therapy, you need to curtail the protein. But it's not the way around. You don't actually decrease it. But when you're increasing the protein, you need to assess what type of CRRT is going on, how much is the protein loss, what is the indication for CRRT. So you calculate and understand that and replace. In fact, most of the times your CRRT patients, they'll become sarcopenic. We have done a study, I think just last month on a CRRT patients. Most of their quadriceps is almost weakened. It's lost on the ultrasound. So protein is extremely important. The same thing applies. There's a fear of adding protein in a patient with a CLD and liver failure. But again, these patients, as we discussed, the detoxification organ for the ammonia is the muscle. If you lose the muscle, your ammonia will persistently be high. The patient will never come out of the encephalopathy. And Burns patient, extremely high resting energy expenditure, you need to match that. Obesity people, very difficult to manage with multiple, even on a ventilator, everything. So you need to remember, most of the obese people will have a very less muscle mass. So the one which you see is different from actually what it is. So you need to have a high protein and low calorie diet. So this is a simple busy slide, but the whole take home point is again the same thing what we discussed. So this is our prescription. So you should be sensitive to your importance. Obviously we all do that. That's the reason we are listening to this. And your nutritionist, you and your nurse are a team. So you need to have a huddle and you need to understand the patient. Just like your antibiotic dose, which you adjust based on your creatinine and liver function, the same thing, your dose of the protein should be adjusted based on your clinical condition. Every day you need to calculate the calorie debt and try to match up the previous calorie debt. Otherwise, you always will be in a debt. And make sure that your bowel moves. So this is going to be the future of prescription. You've seen that first patient, so many gadgets, so many monitors, you have ventilators, you have ECMO machine. Just imagine a world where everything is linked by an artificial intelligence, which is going to come, right? Where it automatically calculates your indirect calorimetry, it calculates it. It identifies your heart rate, it identifies how much is the energy expenditure, and it will give an alert that you are underdoing the protein, you are underdoing the calories, or maybe overdoing sometimes. Just imagine how it would be. So that is how it is going to be once you integrate. Most of the new hospitals have the electronic EMRs where they integrate it. So this is going to be the overall. And metabolomics, this is going to be the future. You have two different patients. One is a hypercatabolic patient, one is a hypocatabolic patient, right? Both can be having a same sepsis. Both you cannot give the same nutrition, right? So future would be to understand the metabolomics of this patient, and same thing. So one may tolerate better, one may not tolerate the same amino acids. And genomics and nutrigenomics. So I may react to a different way to the lipid supplementation, I may react to a different way, whereas you may react different. So genomics is going to be whether it's an antibiotic, or maybe a cholesterol agent, or maybe an antiplatelet, or maybe a diet. So your genomic analysis is going to be the basic thing. And you can predict the family's genomics also, the same thing next to it. So this is going to come in the future, definitely. So this is the same example which I am quoting. And AI is going to stay, I think, either it's a PowerPoint or it's going to be your nutrition. All of us are going to use. And it's better to train yourself and better not fall back. So final conclusions, I think after this I'll keep two case scenarios and I'll sign off. So it is never a static nutrition. It's the personalized nutrition is always a moving nutrition. You need to improvise yourself. Proteins are the key. And metabolomics, genomics, and AI is going to stay. So this is how you need to be. You start slowly. This is the acute phase. You start at 25% of the requirement. Your first goal in the first 48 hours is avoid overfeeding. Start the feed, specifically a continuous food preferably. Understand the patient, how the admitting condition behaves. Slowly reach the target of 75% by the day 3. Then you take a break and again assess the patient situation. Then by the day 5th, you reach the 100% target. During this 100% target, you should be watchful about the electrolytes, especially the phosphates, potassiums, magnesiums. This is the stage where they fall. And once the patient recovers, they go into the early post-ICU phase and post-hospital discharge. This is the phase where you may need to overshoot the 100%, specifically proteins. So all the muscle you lost here, you need to gain in that. And the last phase, the post-hospital discharge phase, is the phase many of the people you will have in a cars where you'll have immunity will be low, your protein will be low. This is the situation. Again, we all will be very much interested if they come for the follow-up clinics. So last two scenarios before I sign off, as we discussed, 60 year on CRRT, your urea is rising. How many of you are going to curtail the protein and how many of you are going to give, or how many of you are going to increase the protein? Now that I told everyone, how many of you will stop the protein, high protein? Yeah, true. So as we discussed, the extracorporeal therapist removes the protein, so you need to actually supplement it. And if you don't do it, the patient is going to be worse. And micronutrients, don't forget in this condition. So don't think that rising urea is just because of kidney. Rising urea can be because of your loss of the muscle also. So liver failure and encephalopathy. This I think we have discussed. So don't stop the protein just because your ammonia is rising. At least keep the protein around 1.5 grams. And again, your ALF on CLF, ALF, fulminant, each of them is a moving target. You need to individualize the patient. And always, especially the patient who is being shifted from the ICU, late morning, late night snack. There's a lot of evidence that it improves the chances of hypoglycemia in the midnight. 10 o'clock, ask them to have something, especially good protein bar or something, and branched chain amino acids. Last one, this we have discussed. So overfeeding obviously worsens your carbon dioxides and your glycemic control. You assess the lean weight, not the actual body weight, which includes it. So refeeding, I think all of us know about it, isn't it? Refeeding, don't think that only lean people can have refeeding syndrome. In fact, the extremely obese people can have, and in the era of Mongeros, Ozempics and Wegovy, so it's extremely common. We see refeeding syndromes very underappreciated. In fact, recently we saw 2 cases where there's a liposuction performed on a patient who was on Monjaro, and they had an arrhythmias and they had a cardiac arrest in the post recovery room, right? Liposuction is supposed to be a simple procedure, shift to recovery. But this patient phosphate suddenly falls, and imagine a patient who on 140 kgs to do a CPR in the recovery room's nightmare, right? Thiamine. So final take-home message is a simple thing. Protein is the standard. Don't aim for the calories aggressively. Both under and overfeeding kills the patient. And always be dynamic, not a static target. Precision nutrition, including your AI, is going to be metabolomics and genomics is the standard of care. And you need to have multiple people for the result. Don't think only you can do it. Unfortunately, kept it on the Rakshasa side, but we can be on this side also. So can you catch it now or not? We still cannot catch it, but at least we can try it. Thank you. I think I finished in time.
Hello. I just wanted to ask regarding the total parental nutrition. So whether routinely we should give total parental nutrition to patients who are having a high requirement, that is the question. And for the patients who have a contraindication for enteral feeding, when we should start the total parental nutrition.
Correct.
It's also important.
Yeah, very pertinent question. There's a fancy, especially in the surgeons, which I saw in, I don't know, in other setups, to start a TPN very early. TPN has a lot of electrolytes. It is directly being dumped into the system in the direct veins. So it's an inflammatory agent. If you are already in a SARS, the SARS is going to be worsened. And second point is you should have a classic indication. The only indication is their abdominal surgeries, especially the gut surgeries, where you can't start a feed at least for a week or so. Or the patient's fistula, you can't start it. There should be an absolute indication. If it is not there, obviously every time you try to start an enteral feed. And you should at least, if it's a robust guy, you should wait at least for 48 to 72 hours before even thinking about it. And once you start, we saw the phosphates and all of it. In fact, TPN we keep quite low unless.
So the take-home message is within 48 hours we should start nutrition, and we should make your goals to achieve within 7 days.
Yes.
Yes.
And in a slow way.
In a very slow way.
Yes.
Thank you, sir.
Post recovery we go up, sir, more than 2, I guess. Yeah, it again depends on patient. Follow-up clinics, sir. The only way intensivist is going to survive in the other primaries is get a follow-up clinics. That's my strong belief. You need to own the patient, both for the nutrition or for the practice.
Sir, also wanted to ask a question. If there is a high protein diet, high protein feed which we start, sir, many times there are diarrhea which is occurring.
Yeah,
so
true.
I just wanted to ask
True.
you whether there is a contraindication if the diarrhea is occurring, or should we continue with the
No, ma'am, no. That's what the third point is, gut tolerance. Only if it tolerates will otherwise.
I'll add something to that. Thank you, doctor. It was a wonderful presentation, because talking about nutrition is everybody's business, but when you actually do it,
Nobody's
it's very difficult. Being in this premises, we have a very supportive team, and Dr. Akshay Chalan is always there, and the entire fraternity, I know a few of them. So wonderful, because you could really do it in a small time. Few things what you would like to add is, yes, about protein, we'll talk it later. Reading the label is important. Giving a slow delivery is important. Selection of protein type. Most of the protein supplements also have an added enzyme, so we could check on that. And one component what I think we have missed is about the fiber. So when we select the formulas, we'll be looking at the fiber content because the patients are in sepsis or different critical conditions. So fiber requirement is a point which we can just look at it.
True. Absolutely.
So these are the few things. Maybe we connect again and then learn and take it more from there.
Thank you.
Thanks a lot, sir, for a great talk. To felicitate, I would like to call Dr. Suman Gosavi on a stage. इसमें सौरभ पटेल सर का ऐड कर So our next topic of the day will be the most challenging situation in the ICU that we are facing, which is severe acute pancreatitis. And the speaker will be Dr. Jay Kothari, and the panelists for this session will be Dr. Saurabh Kothari, Dr. Bhakti Balwant, and Dr. Kumar Vivek.
Good afternoon, everyone. Next minutes, I'm going to speak about severe acute pancreatitis. Before that, I would like to thank Dr. Akshay for inviting me. And to begin with, let's just remind ourselves that in the last 3 decades, probably whatever we were doing on the subject of acute severe pancreatitis is changed significantly. We were doing early surgeries, we were giving a lot of fluids, we were using octreotide, somatostatin, we were keeping the patient fasting for a very long amount of time. Pain was not adjusted and addressed aggressively. All this concept that we were doing in the last 3 decades has changed significantly. At the same time, evolution and evolving critical care is shaping up the management of critically ill severe pancreatitis patient. So something which is seriously important is what you do in first 72 hours in the management of severe pancreatitis. Severe pancreatitis involves serious knowledge of evidence-based, guideline-based, new critical care, and along with that experience. The patient stays with you for a couple of weeks, 4 weeks, and 6 weeks, depending upon the severity. But this severity is seriously influenced not by the disease process, but what patient has received in first 72 hours by the primary physician or by the team of doctors involved in the care of pancreatitis. In another 25 minutes or so, I would try to highlight that evidence-based medicine to deal with the severe pancreatitis. All of us know how to diagnose the severe pancreatitis. Patient came with severe epigastric pain radiating to back, and there is amylase lipase which is high. And we do perform sonography, which may suggest that there is pancreatic swelling. Sometimes there could be other condition which will mimic, which will present with the same kind of symptoms and same kind of biochemistry. So patient has pain, patient has high serum amylase lipase, and patient can have, apart from pancreatitis, other diagnoses like cholecystitis, cholangitis, biliary colic, gastritis, hepatitis, peptic perforation, mesenteric ischemia, so on and so forth. When we cannot differentiate clinically between pancreatitis and other condition, at that point of time, early CT scan is necessary, because sonography may or may not pick up the pancreatic edema in few of the patient. If they are very obese, if there is serious abdominal distension, if there is gastric dilatation, if there is intestinal dilation. In this patient, we may require early CT scan to diagnose and establish the diagnosis as severe pancreatitis. We understand the symptoms: severe abdominal pain, nausea, vomiting, anorexia, abdominal distension. Fever also is one of the presentation of severe pancreatitis. Be careful about all fever are not sepsis, and fever can be a part of the pancreatitis presentation. How do I remember what all can cause pancreatitis? Is the manomics. Eye gets missed, idiopathic, Goldstone-induced pancreatitis, alcoholic pancreatitis, stroma, steroid, malignancy, hypercalcemia, hypertriglyceridemia, autoimmune, of course, scorpion bite we don't see, and post-ERCP and post-drugs. Most of these cases can be identified by proper history taking and by understanding the context of the patient from where the patient is coming. So by and large, the etiology of the pancreatitis would be known to you if you take the proper history. How do pancreatitis evolves and what happens in acute pancreatitis? So any insult or injury which causes ductal obstruction, which causes direct pancreatic acinar cell injury, or which alters the metabolic pathway or intracellular metabolic pathway of pancreas, will lead to acinar cell injury, and that would lead to inappropriate activation of proenzymes to enzymes. These pancreatic enzymes are very notorious, and they would further damage the acinar cells, would lyse the nearby cells and create the onset of pancreatitis with pancreatic swelling. This further cascades into more and more release of proenzymes and lysosomes, and these lysosomes and proenzymes are again converted to active enzymes, which will lead to the further worsening of pancreatitis. This acute pancreatitis will create a lot of pro-inflammatory markers, which would create the surge response and the organ failure at the end of the day. That's how acute pancreatitis would lead to the consequences, which is very different. A patient may come to you walking with some abdominal pain, couple of vomiting, and next 48 hours patient would have shock, AKI, or multi-organ failure if not dealt appropriately. And that's the kind of rapidity and severity that the pancreatitis may evolve. This is one of the most important understanding, morphological classification of pancreatitis. So one side, pancreatitis can have acute interstitial pancreatitis without necrosis, and on the other side, patient can have necrotizing pancreatitis. Both this have a significant different way of working or different presentation or different dynamic course during the next few weeks. Well, interstitial pancreatitis does not have necrosis, so there the fluid collections would be more homogeneous, more manageable, and probably may not require intervention at all. And if the wall formation happens beyond 4 weeks, they are called pseudocyst. Well, within the necrotic pancreatitis, Most of them have solid debris. Most of the management would differ, and that's what we face the challenge managing this necrotic collection which have significant solid debris. And if they develop walled off around that necrosis, it is called walled off necrosis, which happens beyond 4 weeks. And both this presentation, necrotic pancreatitis, as we all understand, would have a more severe, more prolonged, more complicated, more delicate course during the next 4 to 6 weeks. How do we define the severity of pancreatitis? In three manner, by the revised Atlanta classification: mild, moderate, and severe. Mild does not have any organ failure. Moderate have an organ failure which is transient, which recovers with the primary care. It can have local complication in terms of collections. And severe acute pancreatitis is if the organ failure persists beyond 48 hours, then it is called severe acute pancreatitis, and this would have a significant complicated course during the treatment. So if I get a patient on day 1 and my registrar writes severe acute pancreatitis, is it right on the paper? No. Patient should have more than 48 hours with the organ failure, and that has to be careful while we manage our notes. How do we investigate the patient of pancreatitis? We all, so that there is no question about it. I'm going to highlight what is the importance of each investigation. The patient can present with altered LFT, and this could be related to pancreatitis, gallstone pancreatitis, or this can be related to persistent cholangitis also. High SGPT, OT, alkaline phosphate, and high bilirubin is very common. If it persists, patient have persistent cholangitis or patient have persistent biliary obstruction. So you do it today and you do it tomorrow, rising, escalating liver enzymes would tell you that patient have significant or persistent cholangitis or persistent biliary obstruction. Lipase, we all know, would be high. Lipase would be high in a lot of other conditions also. Keep on repeating lipase has no sense, because lipase may be high and will persist high for quite number of days. And lipase is not the prognostic or severity marker for the pancreatitis. Once the peak lipase that you have understood that this is my peak lipase. So that would help, but not serial monitoring of lipase. ABG on admission would tell you about the hypoperfusion and metabolic acidosis. It tells you that the patient has already started developing organ hypoperfusion or organ failure. The most important is hematocrit, and that is what a fluid resuscitation of pancreatitis would define. A patient presents to you with an X hematocrit tells you that this patient is how serious. If the patient's hematocrit is more than 45, this patient has significant low intravascular volume, requires more rapid, more aggressive, more vigilant care, and you'll have to try and bring this hematocrit to a lower level. So monitoring of hematocrit in the pancreatitis patient for resuscitation is paramount important, and trying to be between 35 to 44 is the understanding. We'll run that again in the management of fluids. Very high CRP says very high burden of pro-inflammatory markers. This patient would be serious, may develop organ failure. At the admission, at the ER, one can understand, depending upon the level of CRP, whether this patient is how serious. Sugar and HbA1c should be documented, and triglyceride and calcium should be documented, so that we can learn whether patient has disease because of hypertriglyceridemia or hypercalcemia. But most important thing which is to be identified on admission is hematocrit and BUN, and we should follow it up like we follow ABG for any other patient. In severe pancreatitis, we should follow hematocrit and BUN in the ongoing resuscitation. Which other two conditions you will say that I will follow hematocrit for resuscitation? Burns and dengue. In these two conditions, if the hematocrit is high, you're going to chase the hematocrit, try to achieve the resuscitation accordingly. The next investigation would be sonography, of course, which should be done as soon as possible or within 24 hours. to understand gallstone, cholecystitis, CBD pathology, CBD dilatation, IHBA dilatation. And if it is there, this kind of problem is there, then patient may require ERCP or ERCP for removal, for managing the situation. CT scan is not necessary in all the patients unless you are in dilemma about the cause of abdominal pain and high lipase, unless you want to rule out some other condition. So do not try to chase CT scan if your diagnosis is confirming pancreatitis by sonography, lipase and the clinical scenario. Try to do CT scan after 5 days to 14 days to understand the local complication of the pancreatitis, to understand the site extent and size of the collections. And how do we manage collections? So on later part of the game, you can keep on doing CT scan every weekly 10 days to manage those difficult to treat collections. What is the role of MRCP in case of acute severe pancreatitis? MRCP is diagnosed where the sonography is elusive or not conclusive about the CBD pathologies. At that point of time, one should do MRCP to understand what is the problem, and if the problem is found in CBD, then patient can go for ERCP. Idiopathic pancreatitis or suspected ductal disruption, MRCP is the choice of investigation. For idiopathic pancreatitis, patient can wait for 4 to 6 hours, for 4 to 6 weeks for MRCP. For ductal rupture, the MRCP should be urgent to understand the significant seriousness of the problem. Sometimes you see ductal disruption in trauma patients, and this would require MRCP to understand the grading of duct injury. And the timing is 24 to 72 hours if there is CBD stone, and 4 to 6 weeks for idiopathic pancreatitis. Where do you place ERCP in the management of acute severe pancreatitis? So within 24 hours for acute severe cholangitis, within 48 to 72 hours for persistent obstruction, ERCP should be done. And in later part of the game, if the patient develops complication, biliary duct problem or pancreatic duct leak, then this patient would require ERCP2 and the stenting of the leakage to manage such kind of situation. But for initial management, only if there is cholangitis, only if there is persistent obstruction, you may need ERCP. There are plenty of scores which is available, which would tell you about monitor this and monitor that. And all these scores are designed and defined to address some other problem, some other scenario. Mortality, severity, and organ failure. These are three main headings which we try to monitor, and none of them are perfect in the way of working, and none of them are significantly useful in the clinical practice except at the ER level, which patient should go to ICU. I guess most of the serious patients whose heart rate is more than 110 or 100 should go to ICU for first 48 hours. As I explained, first 72 hours defines the seriousness and the mortality and the duration and the collection and the intervention. So everything is decided in first 72 hours. Trying to put this patient in unmonitored scenario is not the right game. Let's focus on management of SAP. These are the pillars of the management of severe pancreatitis. Fluid resuscitation, as rightly mentioned in the previous lecture, nutrition is not supportive here, nutrition is therapeutic here. Analgesia, management of the cause, antibiotic, glycemic control, management of local complications. These are the pillars of severe pancreatitis management. And if somebody is sharp, somebody is adequate within this group, then he would probably have much better outcome. If you read the literature, the outcome of pancreatitis is 10 to 85% mortality. And why this wide variation is, the disease profile remains the same. What patient received at the early phase and how the decision making happens in the late phase has significant difference between two units, between two states, between two hospitals, the outcome difference for pancreatitis. So what happens with pancreatitis? Pancreatitis causes SIRS syndrome, it causes leaky capillaries, there is extravasation of fluid, there is relative intravascular hypovolemia, This would create pancreatic microcirculatory hypoperfusion and failure, which would create necrosis, which would further create surge response and inflammatory markers, further necrosis of the gland, further organ failure. This perpetuates, and that's how fluid matters, and that's how intravascular fluid restoration is the paramount important strategy in managing the acute severe pancreatitis. Early, adequate, appropriate resuscitation is most important. Fluid resuscitation in pancreatitis has a narrow therapeutic window. So over is very harmful, under is very harmful. If you do under, you keep on continuing the ongoing inflammation, necrosis, organ failure. If you overzealously transfuse the fluid to the patient, patient can have pulmonary edema, patient can have pleural effusions, ascites, acute lung injury, ARDS. And one of the notorious complications would be intra-abdominal hypertension and acute compartment syndrome. That happens. You must have seen some of the patient has significant abdominal compartment syndrome or significant tenderness of the abdomen, or the abdominal wall have accumulated significant amount of fluid. So this happens with the overzealous fluid resuscitation or multiple high volume bolus fluid administration. Even if patient requires fluid, you need to increase the speed of infusion rather than giving the bolus dose of the fluid. So what is the current recommended strategy for the fluid management is avoid aggressive fixed volume boluses. So don't give bolus fluid, goal-directed resuscitation. And what are the goals? Hematocrit, BUN, MAP, and so on and so forth. Frequent reassessment, 4 to 6 hourly. Use balanced crystalloid or RL. Normal saline should be avoided in the resuscitation of the pancreatitis patient. This landmark waterfall trial, which required to be stopped because of the negative outcome, so that the overzealous fluid therapy or resuscitation of the pancreatitis patient was not recommended, and now we don't suggest, the guidelines doesn't suggest the high volume resuscitation. So moderate volume, goal-directed resuscitation to restore and maintain the effective intravascular volume and to prevent and avoid the hyperperfusion by fluid overloading is the game. For somebody who wants to understand at the bedside, it is 1.5 to 3 ml per kg per hour, and bolus to be given as 5 ml per kg or 50 to 30 minutes. Most of the patient may require about 250 to 300 ml per hour of fluid within first 48 hours, and we monitor the hematocrit. The hematocrit should start decreasing and it should reach near to between 35 to 40, and that's the end point of the resuscitation. So urine output, hematocrit, BUN, lactate, MAP, and with newer critical care, dynamic parameters can be monitored to understand the adequacy of the resuscitation. So nutrition in the first we understood the fluid, which is the one pillar. Now is the nutrition, which is the another strong pillar, not supportive, it is therapeutic. What happens with the pancreatitis is severe hypercatabolic state. Patient requires a lot of calorie, protein and energy. Second thing is patients are kept NBM for quite some amount of time. You give carbapenem, all anaerobes, all good bacteria in the gut dies. What remains in the gut is fungus. While you feed them, while you start them feeding, while the gut moves, all this fungus gets translocated in the blood and patient develops candidemia. So gut, to maintain the gut barrier and to prevent the translocation of bacteria and fungi, the nutrition, enteral nutrition is paramount important. Even trophic feeding is something that would improve outcome and mortality. Nutrition, early nutrition would improve the outcome and mortality. Very few conditions would say and stamp that by the guidelines, this is how it is. So early enteral nutrition should be prescribed. If patient can take orally, patient should take orally within 24-48 hours. If he cannot take orally, then nasogastric tube. If patient cannot tolerate nasogastric tube within 3 to 5 days, do not delay insertion of nasojejunal tube or nasodiodinal tube and try to feed the patient with the nasojejunal tube. If patient cannot achieve 60% of his nutritional requirement by means of oral or enteral nutrition, partial parenteral nutrition or supplemental parenteral nutrition should be prescribed in terms of calorie, protein and fat. Do not worry about the complications of the TPN. Complication of TPN happens if the patient is in active surge phase with high inflammatory markers, with hemodynamic instability, when the metabolic milieu of the body is towards creating endogenous production of calories and protein. At that point of time, when my body is producing from within, trying to give from outside would create a clash and hyperglycemia and a high protein where body is not fit to utilize such kind of high metabolite or high structures. Key targets are known to everybody and anybody. I will not go into detail of that, but it's a game of 4 weeks. And every other day there would be one more challenge as far as the nutrition is concerned. Make sure that you try to manage the nutrition appropriately, and if you cannot provide adequate calorie, try to supplement it with parenteral nutrition as and when possible or as and when needed. If the patient has diarrhea, if the patient has to have NBM, if the patient requires CT scans, if the patient... So there would be a lot of calorie depth or nutritional depth. At this point of time, supplemental parenteral nutrition would be of paramount importance. Pain management, again, is a therapeutic pillar in the management of pancreatitis, and fentanyl infusion or fentanyl patch is the preferred mechanism. Of course, one can use paracetamol, one can use morphine, one can use morphine, one can use tramadol, dexmedetomidine, everything, but fentanyl is the choice here. For years together, opioids were considered not to be given in the pancreatitis patient because of the potential chance of biliary colic, which is now refuted by most of the guidelines. If patient is on pain management, adequate pain management, and now develops again refractory pain, then try to think about other causes, which is bowel ischemia, perforation, acute compartment syndrome, or biliary obstruction. So if patient is stable on pain and now has worsening pain again, there could be new pathology cooking. Either it could be hemorrhage, either it could be biliary stenosis, or either it could be mesenteric ischemia. Sugar control, of course, as pancreas is gone, beta cells are going to go, and patient would have hyperglycemia. Hyperglycemia is bad, so it needs to be treated. And insulin is therapeutic in presence of hypertriglyceridemia. So that we will learn with the hypertriglyceridemia, but every patient who is hyperglycemia with pancreatitis should receive IV insulin and not the sliding scale and not the oral hypoglycemic drug for the time being during the acute phase of there. In spite of every other guideline telling us not to use prophylactic antibiotic, I guess myself and most of the people sitting here would still be using the antibiotic in the pancreatitis case, and it is difficult for all of us to refrain and restrain ourselves when there is fever. So we have developed a knee-jerk reaction like a monkey. If we see a fever, we want to prescribe antibiotic. For pancreatitis, that behavior should be controlled as far as possible. The only indication for antibiotic in case of pancreatitis is cholangitis or suspected or proven infected necrosis, proven blood culture positive, or a new onset of fever, leukocytosis, worsening CRP, increasing procalcitonin, gas in the collection in the second, third week onwards of the pancreatitis. Or if the patient has multiple lines and ventilator, we have to rule out the extra pancreatic site of infection. For this extra pancreatic site of infection, one can of course have to give. For years together, this love and belly of surgery and all surgical textbook initially wanted to differentiate whether the collection is sterile or infected by doing fine needle aspiration, which is now technically been removed from the guidelines. So nobody is doing FNA for the proof of infection. Duration of antibiotic, of course, depends on the site and depends on the adequacy of source control. Most of the time in pancreatitis, source control adequacy can never be achieved significantly and seriously for quite some amount of days or quite some amount of weeks. We have to balance the care along with the ongoing persistent source. And as I explained, translocation of fungi are very common in the case of pancreatitis, especially who are in ICU for longer days, who are on meropenem, who are on ventilator, who have central lines, who have TPNs. This creates the ideal scenario for fungal infection. If at all patient develops fever, try to look for fungal infection, try to send the blood culture with mycoF bottles and special fungal media so that the yield is very high. How do you manage the hypocalcemia? Again, this was knee-jerk reaction. All severe pancreatitis patients received IV calcium, and this is very bad, not justifies. If there is hypocalcemia, please do ionized calcium, and if ionized calcium is less than 0.9 or 1, then only give IV calcium. Giving IV calcium is hazardous for the pancreatitis, so please avoid that in your routine practice unless you have numbers of ionized calcium with you. How do you manage hypercalcemia? We know hyperparathyroidism creates hypercalcemia and it creates pancreatitis or malignancy, and some other multiple myeloma sometimes can present along with the pancreatitis. And again, ionized calcium is to be monitored. Primary treatment is hydration. Target urine output is more than 100 ml per hour. One can use diuretics when you want to achieve this much of urine output along with the high fluid resuscitation. Calcitonin is the other drug, but beyond 48 hours, calcitonin gets tachyphylaxis. If you need to use, then you'll have to use zoledronic acid, pamidronate, or denosumab, depending upon the primary diagnosis. If this is malignancy, then you have to use such kind of drugs. And if the patient is severely symptomatic, either neurologically or either cardiac-wise, then this patient would require CRRT and dialysis. If the patient's ionized calcium is more than 14 and 15, then this patient may require dialysis to manage the hypercalcemia, not the urine output in AKI. So it is for hypercalcemia management. How do you treat hypertriglyceridemia, which is causing the pancreatitis? So first of all, what are the risk factors? There are few patients who have familial dyslipidemia, chylomicron syndrome, and so on and so forth. All these patients are at high risk of developing pancreatitis or recurrent pancreatitis. Diabetic, alcohol overuse, obesity, metabolic syndrome, all this can cause hypertriglyceridemia. And if the TG increases more than 1000, and then there is a chylomicron formation, this chylomicron traverses through the pancreatic duct. It is viscous, the flow becomes sluggish. This triglyceride gets converted to free fatty acid, and this free fatty acid is directly toxic to the acinar cells, and which then initiate the pathophysiology of pancreatitis, and then further organ failure and so on and so forth. The management, of course, is nil by mouth, IV insulin. If your sugars remain low, one has to use IV dextrose along with insulin. You have to supplement potassium at this juncture of time. The target minimum dose of insulin is 0.1 unit per kg per hour. And by doing so, if the hypoglycemia happens, you will have to use higher amount of IV dextrose. By doing so, you will develop hypokalemia and hypophosphatemia. One needs to monitor both of them to do so. And if the triglyceride is more than 2000, 5000, and if it does not get controlled within 24 hours by this insulin and NBM, then one can do plasmapheresis, which is a very short solution of removing hypertriglyceridemia from the plasma. The One more important complication that most of us overlook and don't monitor is intra-abdominal pressure. We need to monitor the intra-abdominal pressure and try to keep it less than 20. And like cerebral perfusion pressure, we need to maintain our blood pressure so that the intra-abdominal pressure and the perfusion of organs are well maintained. Anything above 12 is intra-abdominal hypertension, anything above 20 is approaching acute compartment syndrome. And if this happens, the gold standard of monitoring is bladder pressure monitoring. One needs to learn the technique a bit and master a bit or practice a bit, rehearse a bit before trying to do so. And if we see intra-abdominal pressure is high, then we'll have to have nasogastric decompression. Trying to feed is going to be useless at this point of time. So on one side, every day early enteral nutrition is happening. On other side, we forget the intra-abdominal pressure compartment, which is not right. So if the patient has intra-abdominal hypertension, should not be fed, nasogastric decompression, rectal enema, flatus tube, prokinetics, sedation, analgesia, paralysis, and trying to remove the fluid from the abdomen by percutaneous drainage, even in the early phase of pancreatitis where in otherwise it is not indicated. So when you have hypertension intra-abdominal, one can be aggressive about removing this removing this extra fluid from the peritoneal cavity. Patient should be put on reverse Strandlinger position, and occasionally, and probably most of the surgeons would not do it, here is the role for surgery. Decompressive laparotomy, like decompressive craniotomy, is suggested in the literature, but I am yet to find a surgeon who's going to be so courageous to do decompressive laparotomy for abdominal compartment syndrome. At least I have not seen. Most of the times, whenever you read a CT scan of pancreatitis or acute necrotizing pancreatitis patient, you will find that the CT scan says splenic vein thrombosis. No anticoagulation for this. You may see portal vein thrombosis. Anticoagulation may be considered. But if this thrombosis extends to superior mesenteric vein, anticoagulation is must in such situation, and 3 to 6 weeks heparin and low molecular weight heparin should be given. The other dreaded complication of severe necrotizing pancreatitis is development of pseudoaneurysm in splenic, gastric, gastroduodenal, pancreaticoduodenal, or hepatic artery. This pseudoaneurysm can bleed at any point of time torrentially, and I have seen patients dying in the ward when they are about to get discharged. So any pseudoaneurysm of the artery needs to be angioembolized, even if they are stable, asymptomatic, because they have a very high chance of and a serious chance of bleeding, and the bleeding can be unpredictable and unpreventable. So they can die of this kind of bleeding. The last question in the pancreatic management complication is how do you deal with the kind of collections? As I discussed previously, acute interstitial pancreatitis versus necrotizing pancreatitis both differs in the two different manner. So interstitial nephritis would create acute peripancreatic collection and pseudocyst. The fluid in this is very homogeneous versus acute necrotic collection and ward-off connection, which happens in necrotizing pancreatitis, which is very solid debris and which is very complicated thing. So for most of the collections on the first side or interstitial pancreatitis, for longer amount of time, you may not need to do anything unless they are compressing on the vital organs or they are compressing on the stomach and there are compression symptoms. Then you aspirate them or then you do percutaneous drainage of them, otherwise leave it and they would probably resolve. Versus necrotic collections, it would require some amount of procedure at some amount of time whenever these are feasible. So most of the time, these collections are very diffuse and you see them on CT scan and you can't do anything to them. You'll have to wait for this phlegmon to become more drainable, and at that point of time, one needs to intervene depending upon the site, size and the entry through the CT scan, one can take a call about which procedure would be helpful. So fluid content, location of collection, timing of collection within first 2 weeks, unless there is serious compression, there is no need to do aspiration or there is no need to do drainage of this kind of collections. And if they are infected, of course, it requires drainage of that collection by way of percutaneous manner, not the surgery. So management of pancreatitis in this fluid collection, the principle is delay. Even if you see them, even if you are tempted to do so, delay the intervention, drain them, and debride them as a last resort, not at the first resort. As long as you go in the journey 4 to 6 weeks and beyond, the surgery becomes more safe, more easy, less complicated, and patient can have better chance of survival of coming out from the surgery. So initial first 7 days is the primary pillar that we discussed, is the way of management. From 7 to 14 days, this is the phase where necrosis or the collection starts appearing, start coalescing, and at that point of time, the collection can be sterile, creates fever. It creates fever does not mean it is infected. So be careful between the second week, depending upon whether there is gas and depending upon the other sites, depending upon the parameters, one needs to take a very dynamic and very experience-based call whether this patient has developed infected necrosis or the fever is because of sterile collection or the fever is because of the other site infection or the fever is just because of the inflammation which is ongoing. And once you have suspected or confirmed infected necrosis, you've ruled out other sites, you've ruled out that there is no candidemia, you need to do drainage of such situation. And the intervention of this drainage is step-up procedure or step-up approach. How do you do that? So you do endoscopic drainage through the stomach with the metallic or plastic stents if the collections are near the duodenum or stomach. Then this can be manageable through the endoscopic drainage. If this collection has significant solid debris, and if your gastroenterologist is experienced enough, they can do endoscopic debridement of these cavities, which is lying near to the stomach and duodenum. For most of the other collections, which is away from stomach and duodenum, you need to have percutaneous drainage depending upon the thickness of the fluid and the interventional radiologist finding a way to reach there. The size of the catheter needs to be placed and this thing should be drained. And beyond that, if this doesn't work, then video-assisted retroperitoneal debridement. Very few surgeons would be doing it. Laparoscopic debridement, again, very few surgeons would be doing it. And open neck resectomy. So between the percutaneous drainage and the time frame where the patient becomes eligible or qualifies for the surgery, there is a significant amount of time where patient continues to have catabolism, patient continues to have fever, patient continues to have ongoing difficulty, patient may not tolerate enteral fields and patient would have significant ongoing difficulty. And intensivist job is to sustain the patient for another such few weeks till he qualifies for the surgery. Timing of cholecystectomy, if the patient has no organ failure or no necrosis, early laparoscopic cholecystectomy within 48-72 hours. Once patient has developed necrotizing pancreatitis, the cholecystectomy goal differs and becomes 6 to 8 weeks after once the patient stabilizes. If the patient has cholangitis, ERCP is the treatment of choice. What is the adjunct therapy? We as a critical care therapy specialist wants to do everything to salvage that difficult to treat multi-organ failure. And these are the strategies which world has tried over a period of time. Only 2 things I would like to mention. Ulinastatin, which theoretically is a very great molecule, it's a protease inhibitor, which inhibits the enzymes of the pancreas and has a hypothetical advantage in treatment of early pancreatitis. Most of the studies are retrospective, observational, have come from Japan, have come from Korea, have come from China. So the Western world has yet to approve the role of ulinastatin, but in Japan, yes, ulinastatin has been approved. 1 to 2 lakh unit 8 hourly is the dose in such manner, and cytosorb if the patient has significant amount of pro-inflammatory shock, pro-inflammatory vasoplasia. At that point of time, anyway, patient is receiving the renal replacement therapy. At this point of time, there are few case series, not the recommendation. There are few people who believes in cytosorb and uses cytosorb to cut the peak of the cytokine storm and to allow the patient to have lesser amount of depth of organ damage. Cytosorb is indicated. So these are two things: rest, thymosin alpha, anticoagulation, selenium, NEC, octreotide, somatostatin has no role in management of necrotizing pancreatitis as of now. So I will finish with that key message: persistent organ failure defines the severe acute pancreatitis. Avoid under and over resuscitation. Nutrition is disease modifying, improving the mortality, life-saving thing in pancreatitis. Do not use prophylactic antibiotic. Delay intervention whenever possible. Step up minimally invasive approach, and multidisciplinary ICU care improves the outcome. Thank you very much. This is just a CT scan for you to define your strategy. Till, if there is any question, I would be ready to answer. So what do we do with that? Is take-home message. Thank you very much. I'm out of work now.
Thank you, sir, for very informative talk. To felicitate our speaker as well as our panelist, I would like to call Dr. Mahendra Bagul on a stage.
Sir? Yes, sir. हाँ एक मिनट कर रहा हूँ
Thank you. So our next topic will be the most controversial topic in the critical care, that is ventilation in the ARDS. And our speaker will be the K. Yasasvi Sri Charan Goda, and the panelist will be Dr. Sagar Sinha.
Specifically, I just want to thank Dr. Sri Charan Goda because he accepted the invitation at the 11th hour. I really appreciate it and thank you very much.
Good evening, everybody. I thank the organizers for giving me this opportunity to speak about this rather controversial topic as we have discussed before. So coming to the mechanical ventilation in ARDS. So we will be actually discussing these based on some of the strategies, namely the low tidal volume ventilations, low plateau pressures, FiO2s, PEEP requirements, prone ventilations and other non-invasive methodologies. And I'm sure that ECMO has already been discussed, so I will not be going in depth into the strategies of extracorporeal membrane oxygenation in patients with ARDS. So coming to the basic definition, so there are definitions which were recently modified in 2023. So the non-cardiogenic pulmonary edema which can take up to 7 days with known risk factors, which is edema which is not explained by cardiogenic shock or intravascular volume overload, and radiological features. The one thing which actually differed from the classical Berlin definition to the new global definition in 2023 is that they have actually added lung ultrasound by a trained professional as one of the diagnostic criteria where we can probably diagnose ARDS in these patients. And in case of hypoxemia or the PF ratios, so we have 200 to 300 mild ARDS, 100 to 200 moderate ARDS, and less than 100 as severe ARDS. However, for 200 to 300 mild ARDS, we have actually taken into consideration PEEP of more than or equal to 5, or if the patient is on HFNC support with flows greater than 30 liters per minute. And in resource limited settings where we cannot get regular arterial blood gas analysis, hypoxemia with a SF ratio or SpO2 FiO2 ratio of less than 315 with concomitant saturations of less than 97% can be actually considered as a patient with ARDS. So coming to the mechanical ventilation aspects proper. So what are the various key parameters which actually constitute lung protective ventilation? So lung protective ventilation has been described as the cornerstone in the modality of ventilation in ARDS. And what are the various parameters which include lung protective ventilation are low tidal volumes, that is target of 6 ml per kg body weight of predicted body weight. Then low plateau pressures, tolerable up to 30 to 32 centimeters of water. Low plateau pressures are much better, but avoid plateau pressures more than 32. Then comes the PEEP titration, probably the most controversial aspect in mechanical ventilation with ARDS patients. Higher PEEP has got important effects in patients who are having can actually improve the oxygenation in these patients, but however, majority of the trials which we were going to discuss subsequently are not have not shown any mortality benefit. So along with this, we titrate the fraction of inspired oxygen to maintain the saturations of around 88 to 92%, avoid hyperoxia, avoid hypoxemia. So failure to comply with the lung protective ventilation strategies or the parameters of lung protective ventilation increases the risk of ventilator-induced lung injury. Coming to the trials which have actually made us understand how do we ventilate a patient with ARDS. Probably one of the luckily for us, one of the very early trials which was performed in patients with ARDS is the ARMA trial. ARMA trial is considered so much gold standard that if you actually try to design a trial now by disagreeing with what ARMA trial says, your trial is essentially unethical at this point. So the results of ARMA trial are so universally accepted, so though they have become the standard of care. So this includes lower tidal volume. So we can actually see as the lower tidal volumes, the survival is improving, and it is not just the survival to liberation from the mechanical ventilation itself, but it also to survival to discharge. You can actually see in this various quartiles of ml per centimeter per kg of water, you can actually see as the lower tidal volumes, the mortality is less in all the quartiles in various lung compliance brackets. So we can actually, each quartile can be considered as a patient with one aspect of ARDS with a specific lung compliance bracket, and in each lung compliance bracket, irrespective of it, we have actually seen that there is lower tidal volumes are actually improving the outcomes. So coming to the final results of the ARMA trial, we know that the death before discharge has got statistically significant in the statistical significance in the lower tidal volume group. Breathing without assistance, that is liberation from mechanical ventilator, has a statistical significance. Number of ventilator-free days has a statistical significance. Number of days without failure of non-pulmonary organs or the multi-organ dysfunction syndrome has got statistical significance. So this is the trial which has shown universally improved outcomes if we are using low tidal volumes in the range of 4 to 8, an average of 6 ml per kg body weight. The ARMA trial has also taken into consideration plateau pressures which were not so emphasized in the trial per se, but we will be able to see that plateau pressures come into a big play in the subsequent trials. Now that we have established that ventilating a patient with ARDS has to be done with low tidal volumes of around 6 ml per kg body weight, now what is the ideal positive end expiratory pressure? ARMA trials or the ARDS night trials have actually prepared a pre-existing sliding scale for FiO2 and PEEP called the low PEEP FiO2 tables as well as the high PEEP FiO2 tables. So these are so as to say they are a little arbitrary at the moment, and people have tried to find out what is the best ideal method to identify the PEEP scenarios. So even though this particular slide should show so noisy in the slides, we can actually understand the thought process of how ARDSNet has tried to understand the modality of PEEP or the extent of PEEP which has to be applied to a patient with ARDS. Now, initially, you have a low PEEP table and a high PEEP table. So, what did ARDSNet try to understand is that he tried to compare the low PEEP FiO2 table to the high PEEP FiO2 table to understand what is the optimal amount of PEEP which can be balanced in patients in ARDS. However, between low PEEP FiO2 and high PEEP FiO2, the so-called alveoli trial did not actually give any mortality difference. Now that the low PEEP FiO2 and high PEEP FiO2 has not shown any mortality difference, so they have tried to understand what is the upper limit of the PEEP that we can give at this point. So we do know from the previous trials that as the PEEP increases, the oxygenation parameters of the patients increase, but we also have to keep in understand to prevent the complications of higher PEEP. So this upper or higher PEEP, as we are describing, should have one ceiling, should have one limit beyond which it should not improve. So what are the limits they try to understand is based on the EXPRESS trial. So in 2018 EXPRESS trial, they have tried to titrate the PEEP to target the plateau pressures of around 28 to 30 centimeters of water to a conventional lower PEEP FiO2 table in the ARMA trial. So unfortunately, we did not have any mortality benefit even in the EXPRESS trial. So now that we have actually established that neither the tables nor the plateau pressures have actually has gotten a difference. So they have come up with a concept called open lung ventilation strategies, where the open lung ventilation strategies include opening up of the alveoli with the help of a recruitment maneuver and keeping them open with the help of an optimal amount of PEEP to keep the alveoli open essentially. So this is called the open lung concept. So there is called an OLR trial which has actually come for as a proof of concept trial, no mortality benefit. However, they have tried using the open lung open ventilation strategies. So these are larger trials, like 983 ARDS patients. They have recruited the patient with higher PEEP and the comparator is a lower PEEP FiO2 table. However, there is no mortality difference nor is any harm in trying to establish a open lung ventilation strategies. The major problem came with when they did an ART trial. ART trial is also the trial which has tried to explore open lung ventilation strategies in ARDS patients. However, so as to say, retrospectively speaking, based on the results of ART trial, it has been a little over-aggressive in its approach. In lung open ventilation study of 2008 has actually accepted the airway pressures of around 40 when they are doing an airway recruitment maneuvers. ART trial has taken 60 as an upper limit for airway pressures. So they are much more aggressive in their PEEP strategies. They have used higher PEEPs and they have used higher airway pressures in their recruitment maneuvers. And unfortunately, it has showed higher mortality, higher incidence of barotrauma in the intervention arm. So we have come to know that recruitment maneuvers, even though we are using a higher, even though you are using airway pressures of 40 or 60, are not going to help in these patients. A similar trial which has actually happened is the FARLAP trial. It has investigated in the similar scenario. There is permissive hypercapnia. They have tried to increase the tidal volumes or limit the tidal volumes with permissive hypercapnia, and they also tried to use staircase recruitment with higher PEEP with conventional ventilation. However, this also did not show any results. But there is a meta-analysis which was published by Briel et al. In 2010 based on the then available data on the higher PEEP versus the lower PEEP trials, and they have actually said that the higher PEEP is actually causing relatively improvement in the refractory hypoxemia. So there is some severity dependent benefit, but that is just likely it did not reach statistical significance. Now that they have actually identified and compared between arbitrary tables, it did not work. They have compared between open lung ventilation strategies with recruitment and PEEP, it did not work. So there are certain trials called the Villar et al. In 2006 actually. He has tried to use the PEEP as the lower inflection point in your pressure volume curve of the respiratory system. So in this particular trial where he has used the recruitment maneuver and he has used a PEEP based on the lower inflection point of the pressure volume curve, he has shown some mortality benefit, but that did not get reproduced in the subsequent trials. Now these are the now people have started to shift towards more physiological approaches to PEEP. So what if we are trying to identify the opening lung pressures so as to identify an optimal PEEP in these patients? So because the alveolar opening pressure is a difference between the pleural pressure as well as your plateau pressures. So because the pleural pressures can be identified with the help of an esophageal catheter, they try to understand or they try to calculate the alveolar opening pressures, and based on the alveolar opening pressures, they try to put PEEP in such a way that the alveolar opening pressures remain positive, ideally 0, so that the alveoli remain open. So they have designed 2 trials. First trial is called the EPVENT-1 trial in 2008. The EPVENT-1 trial, it has actually put a esophageal catheter, measured the pleural pressures, tried to put the pleural pressures of around 0, and then compared it with the low PEEP table of the ARMA trial. So it actually showed mortality benefit, which was promising at that time, and so they have designed a larger trial with 200 moderate to severe ARDS patients with EPVENT-2 trial. However, EPVENT-2 trial, instead of using the low PEEP FiO2 table of the ARMA trial, they used the high PEEP FiO2 table of the ARMA trial, which again, unfortunately for us, showed no mortality benefit when it comes to the EPVENT-2 trials. So there are certain other trials which are recently coming with where we have calculated the recruitment to inflation ratio, and there are other trials which are trying to identify an optimal PEEP with electrical impedance tomography based endotracheal tube so as to identify the collapse or hyperinflation of the lung, to identify the optimal PEEP so as to prevent overdistension and to maximize the recruitment. So this is still in investigative phases, and we are just yet to identify what is that ideal amount of PEEP. So given the n number of trials what I have enumerated in this particular slide, we come to know that there is no clear-cut evidence, and even ESICM right now in 2023 guidelines says that it cannot give any robust recommendation on how the PEEP has to be titrated in these patients. So this is just a timeline of that PEEP trials in ARDS. So this is an interesting slide because they try to differentiate on what basis the trials were done, based on only on the fixed high PEEP and low PEEP trials, or they did it with recruitment, or they did it with much more physiological guidance like esophageal guided guidance and or EIT, electrical impedance tomography induced. But we don't have a single consensus statement on what is the ideal method or what is the ideal PEEP for any ARDS patient. Now coming to the picture of plateau pressure. So now that we have completed, or we have gone from the tidal volumes and the PEEP, now the next step is the plateau pressures. The plateau pressures are the actual opening pressures in the lung. In a heterogeneous lung or in a normal lung, when the pleural pressures are considered significantly negative, you can equate plateau pressures to the alveolar opening pressure. So that is what the concept of plateau pressures initially came about, where the difference, so if in a patient on volume control ventilation, with zero airflow across the lung, the pressure across the respiratory system is what is defined as the plateau pressure of the system. So then, what are the upper limits of the plateau pressures? As we have known, the ARMA trial has tried to limit the plateau pressures, but it did not give as much importance as it should. With the EXPRESS trial had tried to titrate the PEEP with the upper limit of the plateau pressures. However, there is a meta-analysis where what are the upper limits of the plateau pressures? You can actually see on the day 1, day 3, and day 7 of this meta-analysis, so which has said that 32 centimeters of water, 32 centimeters of water is can be considered as a reasonable upper limit, because beyond 32 centimeters of water, even on day 1, day 3, or day 1 and day 3, we can actually see that there is statistically significant increase in the incidence of short-term mortality if the patient's plateau pressures are increasing beyond this level on day 1 and day 3. So what next? now that we have established that there is some upper limit of plateau pressures, is there any some refinement in the plateau pressures? What can be done is the driving pressures. The driving pressures or the delta P is given by the ratio of tidal volumes to the total compliance of the respiratory system, or it can be said as the P plat minus PEEP. So driving pressures concept was actually put forth by this very legendary paper by Marcelo Amato et al. However, we have to make one thing very clear here is that this particular paper was not a randomized control trial. It is just a collection of the data from the 7 previous randomized control trials, and he actually had done a statistical analysis by taking the plateau pressure into the question. So we have made some very interesting, they have made some very interesting observations in this particular trial. So if the PEEP is matched so if this is the P plats, and even if the PEEP is matched and the P plats are increasing, there is a linear increase in the mortality. And even if the P plats are matched and the PEEP is really increased, there is significant decrease in mortality. But you have actually see if you combine both of them, where the driving pressures or the delta P is kept constant, the mortality rates remains fairly constant. So this simply says that the higher plateau pressures is not always risky, nor higher PEEP is not always beneficial. So you can say that as the delta P remains constant in spite of incremental PEEP, the mortality remains constant. So probably if you actually rephrase it in such a way that it is the delta P which is directly proportional to the mortality of patients while we are actually mechanically ventilating them in an ARDS patient. So to actually say that if you look at the multivariate relative risk of death in the hospital, the delta P, and if you actually see that plus or minus 2 standard deviations, they were able to form a regression analysis, and this regression analysis shows it's almost linearly related to the risk of mortality. The driving pressures are linearly related to the risk of mortality. Next, coming to prone ventilation. The physiology of prone ventilation is that in a patient who has gravity and in the matter of gravity with alveoli, we can say that the upper parts of the alveoli are over distended and the lower parts of the alveoli are underventilated because of the weight. And actually by proning these patients under the effect of gravity, we can redistribute the airflow in such a way that the ventral aspects of the alveoli are not over distended, and because they are compressed by the weight, and the dorsal aspects of the alveoli are actually aerated. So we can say that there is more homogeneous distribution of ventilation across the lung in patients who are prone. So this has given actually the question of improving or of proning the patients, and even though there are certain papers before the known ProSaver trial which have not shown any mortality benefit, it is a ProSaver trial which has actually protocolized the proning scenario and has given a very robust evidence that proning in patients of approximately 16 to 18 hours a day in patients who are having moderate to severe ARDS has actually shown significant mortality benefit. So this particular trial is the one which has gotten the proning as standard of care in ARDS patients. Coming to neuromuscular blockade, we have 2 major trials in neuromuscular blockade. So should we paralyze the patients or should we not paralyze the patients? The first trial is the Accuracy trial, in which their patients received cisatracurium infusions which showed mortality benefit, and however it did not actually translate it into a mortality benefit in the subsequent ROSE trial. However, there are certain methodological differences between Accuracy trial and ROSE trial, where in ROSE trial the control group has received lesser sedation, whereas in Accuracy trial it is only a question of muscle relaxation versus no muscle relaxation, but both the sides of the patients have received significantly deep sedation. So if we actually take the meta-analysis into question, neuromuscular blockade is associated with reduced risk of barotrauma and improves the oxygenation. But there are the worsening in ICU acquired weakness is not statistically significant, but it has to be individualized. So if you look at the meta-analysis, you can say that the 28-day mortality is not so statistically significant with p-value of 0.1 here, but the trend is towards improvement in mortality where it favors neuromuscular blocking agents. Probably neuromuscular blocking agents have the affinity to decrease the patient ventilator desynchrony, which might have caused improvement in the oxygenation status. However, the major question which we have if we use an NMBA in an ICU is the ICU acquired weakness and barotrauma. You can say that the ICU acquired weakness, there is not much statistically significant difference between the 2 groups, as well as in barotrauma, it is definitely less in patients who have received neuromuscular blocking agents with reasonable statistical significance. So coming to fluid therapy in ARDS, the ARDSNet trial which has actually worked on the fluid therapy is the FACT trial. So there is no significant difference even if you have taken it between conservative fluid strategies and liberal fluid strategies. However, ventilator-free days and ICU-free days are much better in conservative fluid strategies. So a dry lung is always the best lung in ARDS. So other ventilation strategies which were initially worked out or initially tested upon are the high frequency oscillatory ventilation. So there was initial trial called the META trial, which was initially showed that there is some improvement in HFOV, so which subsequently paved the way to open two large trials called the OSCAR trial and the OSCILLATE trial. However, while OSCAR trial has showed no mortality benefit, OSCILLATE trial has showed increased mortality with high frequency oscillatory ventilation. So because now it is said to be a potentially harmful intervention, and now it has been removed from any guideline where we don't use HFOV for ARDS. Coming to APRV, adjusted pressure release ventilation has 4 settings, T high, T low and P high, P low, where it is something which can actually help the patient to breathe on a background of an APRV. We don't have enough evidence or randomized control trials to actually say that APRV can be associated with improved survival in patients with ARDS. However, the oxygenation part is somewhat better. But in patients who are left on spontaneous breathing with APRV, the chances of barotrauma are known to be a little more higher. Whether they will reach statistical significance or not is something which we will know if at all there is a randomized control trial in this scenario. Coming to non-invasive strategies, I'll just the last couple of slides. So in patients who are having acute hypoxemic respiratory failure, high flow nasal oxygen is known to postpone or known to avoid mechanical ventilation in patients compared to standard oxygen therapy as per the FLORALI trial. But however, in a COVID-19 pandemic, they try to compare high flow nasal oxygen to that of helmet and IV, which found that there is no statistically significant difference in the outcome, even when it comes to support-free ventilation days or even it comes to mortality. So, summarizing of the present current guidelines, low tidal volume ventilation with low plateau pressures, prone ventilation of greater than around 12 to 16 hours per day, avoid high frequency oscillatory ventilation, higher PEEP with moderate to severe ARDS. At this present point in time, we don't have enough evidence to say what is the best modality. So the ARMA high PEEP FIA to table in moderate to severe ARDS is as good as any other methods at this point. Recruitable maneuvers are big no. Conservative fluid management is the way forward. Neuromuscular blocking agents, we have a very ambiguous we have very ambiguous evidence for that. So it depends upon how well we are actually trained in managing a patient without neuromuscular blocking in patients who are on prone ventilation. So if nothing works, we can actually go ahead for veno-venous extracorporeal membrane oxygenation support. However, unfortunately, we don't even have a robust evidence even for supporting ECMO at this particular point. So to conclude, most impactful strategies are lung protective ventilation and prone ventilation. So these are the only major 2 trials which have time and again showed that they have benefit. Then the important adjuvants are the conservative fluid strategies and neuromuscular blockades. So which requires further research are the driving pressure concepts, which as I was saying, it's not a randomized control trial, it's a data which was reanalyzed, and obviously for veno-venous ECMO and PEEP strategies. Thank you.
There's a wonderful presentation. I love the evidence and very well done. And I think it's what sir has also taught us that ARDS is a heterogeneous disease. Unfortunately, in the past it was a lot about classifying it into more of a homogeneous element. Yes. And I think you've gone through the evidence beautifully. And I love this last slide, because it was very clear those 4 endpoints. Simple things. Go with low, lung protective ventilation, number 1, prone ventilation, number 2, and conservative fluid management, NMB. I think these are the 4 things, irrespective of the resource where you are, that can be done easily well. I always have a concern about, sir, the ARDS mimics. I feel in our practice, everybody loves to overdiagnose ARDS, whereas very often than not, you have other causes like heart failure, pulmonary hemorrhage. So I think we tend to overdiagnose ARDS, and a lot of these strategies people tend to use for the severe ARDS. For example, high PEEP, I love it when people go with the high peep and then they have nebulization in the order and the circuit gets disconnected. So we do many opposing things. So I think the simple fundamentals are really crucial, and I think you've covered them really wonderfully, man. I didn't want to say that, but yes, sir. Any questions from the audience? Any inputs from the audience? Okay. Thank you.
Thank you.
So that was a great talk. And to facilitate speaker as well as the panelist, I would like to call Dr. Akshay Chalani. So next we are going to discuss case. The presenter will be Dr. Daksh Bohra. Moderator for this case presentation will be Dr. Mahendra Bagor and Dr. Om Prakash. And the panelist will be Dr. Swarna Deepak, Dr. Jay Kotari and Dr. Sagar Sinha. Please come on the stage.
Check.
Yeah, to present the case, I request Dr. Daksh to be on the dais, and Dr. Mahendra and Dr. Om Prakash will go through the cases and monitor the flow actually.
Hello. Good afternoon, everyone. This is a 31-year-old male with no known comorbidities presented with complaints of fever with chills, abdominal pain which was periumbilical and reduced appetite since 3 to 4 days. History of presenting illness: the patient was apparently asymptomatic 3 to 4 days back, after which he developed low-grade intermittent fever which was associated with chills. Fever was gradual in onset, intermittent and partially relieved with medications. Patient complained of abdominal pain, predominantly in the periumbilical region. Patient was dull aching in character, non-radiating, mild to moderate in intensity with no specific aggravating or relieving factor. Patient also reported reduced appetite since the onset of illness. On 21st March, the patient was admitted to an outside hospital for further evaluation and management. Based on the clinical presentation initial investigations, patient was managed with the provisional diagnosis of viral fever and was treated with IV fluids along with supportive care measures. Despite ongoing treatment, the patient demonstrated rapid clinical deterioration over the subsequent 48 hours, characterized by altered sensorium, persistent abdominal pain, and persistent low-grade fever and icterus.
This young patient who is presented with fever with chills, abdominal pain, jaundice, and altered sensorium. What should be my differential diagnosis in this scenario?
We are in Navi, Mumbai, so if you have fever with chills, I would jump to tropical fever, typically in our setting, considering we're in Navi, Mumbai. And here, when I say tropical fever, that opens the door to all your conventional tropical fevers. That icterus coming on day 2, but again, it all can be a feature of, so I would think of a tropical fever as the most likely differential. In a tropical fever, you can add all your dengue, malaria.
In Mumbai or Navi Mumbai, in this scenario, this is true maybe.
But without the absence of further information, and I would still say that one thing that we don't do is, we never give us the clinical examination findings, which is I think something which we remember that also is equally important besides the history. I think conventional things, you look for icterus, hepatomegaly, even for blanching, these are very good signs to understand the, but but I'm sure you'll do it probably once the patient has come to Apollo.
Serial lab investigation outside reveals significant worsenings of thrombocytopenia from 1.45 lakhs to 81,000. Concurrently, the patient developed clinically evident icterus with marked hyperbilirubinemia of 10.7 milligram per deciliter and progressive hepatic dysfunction as SGOT was 657 and SGPT was 1086. Clinical course was further complicated by the development of profound coagulopathy with INR exceeding 120 seconds. USG showed reactive gallbladder wall thickening. However, in view of progressive clinical deterioration and worsening biochemical parameters, the patient was referred to a higher center on 23rd March for advanced evaluation and further management. When he came to Apollo, on presentation, he was febrile with a temperature of 100 degree Fahrenheit, tachycardia with a heart rate of 112 beats per minute, blood pressure was 110 by 80 millimeters of mercury, RR was 22, saturation was maintained on room air at 98%. Clinically, icterus was present.
Sorry, just go back one slide. I would want to ask anyone on the stage, tell me what is so significant about this blood pressure? What makes it very particularly interesting in this context?
Looks like pulse pressure is very low, sir. Yeah.
Very low, or rather, pulse pressure is. Yeah, I mean, so that's the whole point. So this actually is a very simple clinical marker of hypovolemia, and I know what the case is heading towards. But you have a tachycardia, dehydration. This 110 by 80. This 80 is an extremely important marker, by the way.
Systemic examination per abdomen, abdomen is soft with tenderness localized to the periumbilical region and there was no organomegaly. CNS patient was drowsy but arousable and able to follow commands consistent with grade 2 hepatic encephalopathy.
Dr. Deepak, what is your take on till now?
No, it's, I think, quite summarized lucidly. So we have a patient who is rapidly deteriorating, his liver is involved, his hematological system is involved, and the time frame is quite short. So we're dealing with something which is acute or hyperacute, and liver is involved. Our differential diagnosis is always an acute liver failure. It's a syndrome. So etiology, obviously you need to take one medication history, which is very important, we commonly miss it, toxicology history, as well as the correct, most of the time our patients give a wrong history. So they try to undermine that myalgias maybe because of something like that. So you never depend on them. And at the same time, hepatitis workup. And one common case we miss is the Wilson's, so which we see it and it's underdiagnosed. So for whatever it's worth, diagnosis in acute liver failure, that is a syndrome, we need to deal with it. We have both the synthetic system is involved and detoxification system, both are involved.
Excellent. Next.
Investigations which we did are CBC with PTINR, renal profile, liver function test, albumin, ammonia levels, USG abdomen which was done outside, USG abdomen Doppler, CT head, blood cultures was sent, urine culture was sent, CRP, procalcitonin, tropical infectious panel, autoimmune profile and serum ceruloplasmin, HIV, HCV, HEV and HBV, dengue, malaria, urine tox screen. This was the ECG on presentation. And this was the ABG on presentation.
So you dare to do an ABG, good.
Sir, as that, what
you pricked the artery, no?
Yes.
So one common thing is you should be careful in pricking the arteries. You don't know. That becomes a primary issue. For example, yesterday night itself, for one of our registers, for whatever it's for the, now the primary issue is detract and now we're dealing with an arterial thrombosis. So you never, any procedure unless until required, try to.
On day 1, these are the labs. The patient was initiated intensive supportive management, including broad spectrum IV antibiotics, injection peptides, and azithromycin, lactulose, rifaximin, 3% hypertonic saline, and vitamin K supplementation. Coagulopathy was managed with tech-guided blood component transfusion. In view of critical clinical status, invasive monitoring was established with placement of an arterial line in the left radial artery and a central venous catheter in the right internal jugular vein. Despite aggressive supportive therapy and critical care management, the patient continued to show gradual clinical deterioration.
So here in the labs, one thing which we could see is definitely the enzymes are disproportionately low. That tells you the patient is extremely sick. The cells are getting necrosed. It's a massive hepatocellular necrosis. So these patients, deceptively, the enzymes are normal. You should not think about it.
Sir, should we start on empirical antibiotic with patient who's with liver failure?
Yeah, that's a good question to ask. How many of us will not start antibiotic? So I would start it. I don't know the history. I'm still in a gray area, so I'm not sure. Second is the one good point you mentioned is the tech guided. Most of the time we don't use a tech guided resuscitation. Most of the time these patients are procoagulable.
Yes.
Just because your INR is 4 doesn't mean that you should correct it. These are the patients. Second is most of the time you need not give an FFP before keeping a line. So you can always do a POCUS and POCUS guided line, because that is the only marker which tells you the patient is improving or not. Have you called the transplant team in the night?
Yes.
Yeah, that is the
This patient
clinching.
was admitted under transplant team.
Okay, good.
But for this patient, whose INR is 10 around INR was 10, so should we put the ST catheter and all the lines without FFP transfusion now?
10
INR is very high. Yes, take.
What
Suppose
did
I
the
don't
tech
have take machine. We have here. Suppose we don't. That was my next question. When should we consider to shift the patient to the transplant center?
Why azithromycin?
Ammonia is 146. 146.
What does that tell you?
Is in hepatic decompensation.
So ammonia, as per the latest guidelines, it is the single most important indicator. Ammonia and INR. Right? Ammonia will correlate with the course, and as it will predict the encephalopathy and iteration also.
Sir, in your center, how do you monitor the ICP in patient with acute liver failure?
Yeah, one is clinical, second is ONST. That is how we do it. We never keep an ICP. In fact, we do never dare to touch it.
And any role of anti-seizure medications, the prophylactic, like levetiracetam, who has grade
If they are
3,
not
grade 4 encephalopathy?
epileptics before, we don't usually keep a prophylactic anti-epileptic.
But this patient may throw the
Anyone can throw, but if they throw, that means that either you are not controlling ammonia or they have developed a bleed usually. So both are catastrophic. So you need to control the metabolic rate. So if you do it, prophylactic anti-epileptic, we never do.
But there are physicians and there are people who try to build that bridge where it is not required. I'm worried about the seizure and I would be a little more aggressive care लेविसिट्राम देने से नुकसान क्या ही है?
Suppose patient with grade 3, grade 4 encephalopathy who got intubated and
That's what
this
I mean
patient
to
may
say.
develop the paralysis, may develop the non-convulsive status epilepticus, and because of seizures, his ICP may increase. Whether should we give or not?
But that will not be prevented by anticonvulsant anyways. It is ammonia monitoring and you probably need to do CRRT and plaques for that ammonia, then levetiracetam. But a clinician would err on the side of what? यार 100 मिलीग्राम एफकोलिन देने से क्या ही होना है? So हम लोग बहुत सारी practice ऐसे करते हैं normal life में, but that's not warranted. So if the patient, if you want to prevent him from going to status epilepticus, yes, be aggressive about CRRT plaques.
That antiepileptic has to be cleared by liver again.
Exactly. Most of them have metabolism and all your pharmacokinetics, everything will go for a toss. In fact, in these patients, your medication order should be the simplest.
Yes.
Rather than trying to populate needless medications, for these patients, you should have the simplest medication orders.
If the patient has fever, what do we do?
There are recommendations. Because fever itself can technically lower the seizure threshold. So the question you were worried about, so
By day 2, the patient showed progressive worsening of hepatic encephalopathy with increasing hemodynamic instability characterized by hypotension and reduced urine output. In view of evolving acute liver failure with multi-organ dysfunction, inotropic support was initiated. Therapeutic plasma exchange for 3 cycles, standard volume was done with using fresh frozen plasma and albumin replacement. Owing to worsening metabolic status and renal dysfunction, continuous renal replacement therapy was also initiated.
Sir, is there any role for the plasma exchange in patient with acute liver failure? If there is any role, when should we consider the plasma exchange?
It's a very important question. The recent trials, in fact, the latest trial by the UK group also, it showed a reasonably beneficial benefit in the trials. But point is, again, it's a bridging therapy. It is not a definitive therapy. You are going to buy some time till your transplant occurs. And there is no much difference between high volume and standard, at least as the latest trials. But the trials keep on evolving. Certain hospital does more TP, certain hospital do less.
By day 3, as no suitable living donor was identified within the family, the patient was listed for a super urgent liver transplantation. During the course of illness, the patient progressed to grade 4 hepatic encephalopathy associated with metabolic acidosis and lactic acidosis. In view of deteriorating neurological status and airway compromise, the patient was intubated and initiated on mechanical ventilation.
अच्छा अभी तक इंटुबेट नहीं करे इसको. Why with that?
See, sir, asking you, like, did we wait for him to go into grade 4 and then we had to protect the airway, or it was already a planned?
Initially, patient was on the grade 2 only. That time we were not intubated. On day 2, next day we intubated the patient. Sir. This is a day.
Day 3 we intubated.
What was the medication between day 2 and day 3? Like, what medications besides piperacillin, tazobactam, and azithromycin?
So
when sir asked about ammonia. So, simple question to you: how do you actually get the ammonia out, or how do you prevent the progression of the encephalopathy?
I think grade 3, day 3 only we started him on the CRRT, sir. What is
No,
the role of lactulose we started?
This is nothing asked. We all start lactulose, but what is the actual target of lactulose, by the way?
The target is we have to 3 to 4 loose motions per
I
day.
want to ask, how many times have you actually ensured that in the shift? I'll tell you something, we all
Yes,
start
sir, yeah.
lactulose. How many of us actually asked the nurse, did the patient actually pass? Yeah.
So we do here in our
No,
center.
I'm just not
But
Why did you wait for intubation for 2-3 days? Take on that, suppose he is not aspirating or there is no hypoxic brain damage. We are reasonably okay to wait if these two things are not happening. Reasonably wait.
The dynamics are changing because initially all of us were not very aggressive about tracks and about CRT. So 10 years back, or till the liver transplant program gets settled in such manner. In the last about 10 years, I guess we are becoming more clear about the role of tracks and CRT in hyperammonica state. So what happens is now we are putting them on track CRT, so they hover around to a grade 2, grade 3 encephalopathy for quite some time, and the liver failure does not improve. The only very few liver failures that improve with time is hepatitis A. Most of the other liver failures persist and worsen. So Dr. Saab said it is a bridge therapy to transplant. Unless you have a transplant, you are on a dead end. For hepatitis A, we have saved 4 patients with 700 ammonias, plaque CRT, and without the transplant. That is something which is, what is the cause of this?
We know the underlying cause.
Somehow these numbers are not reflecting the seriousness of the situation.
LGBT is not.
And how much is the ammonia by the time you
Started 146.
146 was the ammonia.
Sir, on this point of plex, we had this wonderful debate at our hospital a couple of weeks back, and the same discussion happened. A lot of heavy discussion. The question was, we have many ratol cases, phosphine, phosgene, and there was this thing of plex saves it. I was very clear that plex is evolving evidence. The point here is, if you have that kind of a liver hit, either you get transplant or you will die. Matlab, you get my point. If you have not that kind of a toxic dose of the phosgene, and there are specific doses, then whether you get plex or whether you get masala, you may still survive. So we don't know that tipping point in terms of what was the tipping point. So sir, I am still particular condition? Because अगर liver failure होना है, अगर transplant करना है तो flex will buy time.
Liver failure. Flex just buys the time.
हाँ, that is buys time. It is not curative by any.
Apart from the rodent side.
Two things I'd like to just add. It's a very interesting thing that is going on. Explaining myself properly. First of all, acute liver failure, Raton, both are two different things. If you talk about Raton, one of the component of Raton poison is acute liver failure. Raton is a system. It causes acute liver failure. Along with that, it causes acute myocardial failure, it causes bone marrow failure, it causes acute kidney failure, it's a system cause. For Raton, I don't think this discussion is on the Raton. Nobody knows what is the right thing to do with the Raton. People have started with flex on the day one of Raton. Still, they could not reach the way. People have not done flex in the Raton. Still, the patient was affected. So nobody knows what is and why it is so diluted, because the Raton, whatever they consume, that is not fixed. Whatever they consume, they vary so much in the ingredients. If you see that, if you ask that somebody comes to the Raton, you tell them that what you have consumed is so good. You see that the 10 different patients comes to the Raton poisoning, same Raton poisoning, 10 different paste you will get. All 10 paste has 10 different components. So it is not standardized. So Raton is completely different. So coming back to the ALF, for all practical purposes, we do like say one course of failure as soon as the So that's the kind of standard cutoff we have kept as well as our institution cutoff, because we have found that if the ammonia will have those more than 100, that means these will be acceptable. And we do not usually we try not to raise the ammonia more beyond 150, because more than 150, especially if somebody is young, they hold. Whatever you do, whatever that doesn't matter. So flex is one form of therapy that allows you to bring down the ammonia, but that is not the sole thing. That's number one. CRT is one modality to bring down the ammonia. So we do CRT, we do a flex, followed by continuing the CRT at the same point of time. So the few occasions where patients are saying we do both the CRT and flex simultaneously, but at the same point of time. So here we are dealing with a case, somebody who has almost burnt out liver because of the liver failure, because there is no index. There is no index.
So the question is that when you use flex, standard number changes, your indication, you exclusion inclusion criteria, you shift the moment to do a flex. In that context, sometimes it's possible the patient is not relating or not willing for donation, patient do well, and sometimes you put everything, you post in for liver transplant. At that point of time, you are not very clear whether you have want the liver transplant. So how to take clinical decision at that point of time? That is the question.
So again, the cutoff criteria is completely different. Suppose the cutoff criteria for the area where the flex is being
Next question. उसके बाद क्वेश्चन
So flex is for not only for the bring down of ammonia, it is also to bring down a lot of cytokines, lot of endotoxins that comes out of the necrotic liver to the systemic circulation, causing the hemodynamic instability. They take over. Along with that,
The most important thing is the timing of the TPA. Before your grade 4 starts, you need to start it.
And especially for most of the time, so grade 1, grade 2, sometimes we accept in terms of the most of the time they protect their airways. But as soon as the patient starts become grade 3, that means they become vegetative. That means that is the time, most of the time we get the patients over here and we get intubated. Because if somebody becomes restless, vegetative, first sign, so that is a very, very crucial time to understand. Because intubation not only helps the fluid in the airway, it also helps to control the ICUs. So that is one of the
question was when should we consider the CRRT? You are already answering your question. And any difference between the SLADE and CRRT in patient like
CRRT.
RRT should not be done because the rapid change in the osmolarity. So for two patients, dialysis should be done for suicidal scenarios. One is liver and one is hepatic brain injury. In these two conditions, if you are supposed to do dialysis, then be careful 10 more times about the acute solute change. And for somebody who is already having a swollen brain, definitely quarantine.
By day 4, the patient demonstrated further hemodynamic deterioration requiring escalation to triple inotropic support. A second cycle of flex was done while CRRT was ongoing. In view of persistent severe coagulopathy, multiple blood product transfusions were administered for correction of coagulation parameters. By day 5, gradual hemodynamic improvement was noted with a decreasing requirement of inotropic support, and by day 6, the patient was on dual inotropic support with noradrenaline at 0.2 microgram per kg per minute and vasopressin at 1.2 ml per hour, indicating partial stabilization of circulatory status.
My last question will be, so when should we consider the patient with acute liver failure for the liver transplants? What's that?
Diagnosis.
So we don't, this liver failure is diagnosis. Sir.
No. Yeah, well, in terms of did you get anything positive in all those tests you sent?
Yes, sir, no, sir. Negative all the time. It is cryptogenic acute liver failure, so we don't know the cause.
Patient is reiterating.
Yes, yes. Antibodies were then, it was negative.
Lactate is going up, your encephalopathy is there.
No, I'm asking, when should we consider for the acute liver transplant in acute liver failure? Not in this case, sir.
See, broadly, ALF, by Sir said, ALF by definition is two things, encephalopathy and coagulopathy, in terms of the conventional thing. So if you have encephalopathy and coagulopathy, you have persistent support, then you are ending with the ALF which needs this thing. Now the problem is, this ALF turning, now this whole terminology has been changed. You know, if you see the European guidelines, American guidelines, hyperacute versus permanent, ALF, by the way, the spectrum is 26 weeks. It is not. Now in ICU we end up accelerating it to the point 3, 5, 7 days. But the true spectrum of ALF is 26 weeks.
Yeah.
Okay.
28 weeks. 26.
Based on that, and what Sugadev said, an acute setting, our ZTCC, Mumbai, we have a preset criteria. Now that does not mean that you have had to initiate 10 things to get the patient eligible into the LTX list. But if you have basically progressive encephalopathy, despite best measures, progressive coagulopathy, despite best measures, that itself is a criteria for consideration. I'm not saying for transplant.
Yeah, for transplant I'm asking, sir. Not
for
consideration.
consideration.
We should consider it.
By day 7, a deceased donor liver became available and transplant was done. Post-op patient was shifted to ICU with the continuous CRRT and immunosuppressive therapy was also commenced as per transplant protocol. By third day, the patient demonstrated gradual hemodynamic improvement with reduction in inotropic requirement and improvement in urine output, following which CRRT was discontinued. Serial laboratory parameters showed progressive improvement in hepatic function test as well as correction of coagulopathy. In view of prolonged critical illness and development of critical illness neuropathy, tracheostomy was performed to facilitate prolonged ventilatory support and weaning. Subsequently, the patient was gradually weaned off the ventilatory support and continued clinical improvement. Simultaneously, comprehensive neurorehabilitation and physical rehabilitation were initiated. Immunosuppressive therapy was gradually optimized and stepped up as per transplant protocol. With progressive clinical stabilization, improvement in functional status, the patient was eventually shifted from the intensive care unit to the ward for further recovery and rehabilitation.
Necrosis. Biopsy is done, na?
Biopsy, it was necrosis only. Ramesh, necrosis only.
नहीं पहुंचेंगे 95% of केस में नहीं पहुंचेंगे
necrosis, only necrosis.
I think that the patient which you have been spoken about is a daily, it's a subacute liver failure, not the acute liver failure. And it's a daily, mostly he was having some history of alternative medicines.
So there was some toxin, whatever, environmental toxin causes, probably.
No, no.
So thank you so much, Dr. Sagar and Dr. Jaykotai. Finishing the session now. Yeah?
Just
Yeah, that was a great discussion about the ALF case. And to felicitate the presenters and the panelists, I would like to call Dr. Mahendra. Acha, Dr. Akshay Chalani, sorry. I request Dr. Divya to just hand over the memento to Dr. Mahendra and Dr. Darsh.
Sudeep.
Now, now I am requesting Dr. Divya, Dr. Sudeep, Dr. Mahendra, Dr. Om Prakash to felicitate Dr. Akshay Chalani.
Thank you, Ashwini. Now I request Dr. Akshay sir to felicitate Dr. Ashwini.
Before I sign off, I'll just give a vote of thanks. Those all help. Thank you, Dr. Ashwini, all Department of Critical Care Medicine and Pharma Industries who wholeheartedly supported us. Ramesh for photography and his team members. Thank you very much. I really appreciate. Thank you all.
Sir का एक फोटो
सर का एक फोटो लेते हैं। सुदीप सर